My name is Mr. Metapoli. I'm the founder and the TMS Trust member. On behalf of TMS, I would like to invite you all to this amazing new conference, or our inaugural conference, the International Junior Doctors Conference for Aspiring Surgeons. So just a bit of the TMS Trust. So this was initially conceptualized by myself about in 2008 when I was a trainee working in Birmingham, and it was a very basic website to help junior doctors with their preparation for exams. Slowly, I got acquainted with various people, and one of our students, when I was a teaching fellow in Birmingham, was Kasun Wanigasuya, who is the current chairman. He had interest in web designing as well, and then he basically joined the troops. And since then, we made a very good progress and then made a lot of changes between 2010 and 2013, including incorporation of various educational activities and courses. Then we decided that this need to become more of a broader area to help international students. Hence, we made it a UK charity, which is a non-profit organization, and that's where the TMS Trust started. Since then, we made a long journey with various amazing people, and now we have got various aspects to this TMS Trust. We run collaborative projects, we run various courses for medical students and junior doctors, we give scholarships, we give prizes to various students and junior doctors depending on various activities we do. We run some essay prizes for medical students, and also we do some awards, including TMS Best Poster Award at our ASIT, the Association of Surgeons in Training Conference. So a bit about the team, but I would be delighted if any of you want to come and join us. The membership is free, and then once you become a member, you will know what we do, but more importantly, you can actually come and join as a council member, and depending on your contribution, you can go on to become even executive committee member. We have also got various roles like content directors for various specialities as well. So coming to the conference, I'd like to thank all the sponsors for their generous support. I'm very grateful to all the scientific panel members who are involved heavily in marking all the abstracts submitted and also chairing the sessions today. These are all consultants and senior registrars. They are doing this voluntarily and they don't get paid. So we do not have any control over them, but they are professionals and they mark without any bias. So to take the bias away, we have chosen various consultants from all over the world. We've got a few international panel members as well. Coming to the conference organizing committee, since from the conceptualization of this idea of running a TMS conference to its implementation, various people involved, but I would especially like to mention 3 people who are heavily involved right from the beginning. That's Pedram, Pushpa, and Sanjid. You have done excellent work to get this all right from the beginning, approaching us to run this conference, and then obviously involving with the TMS committee, and now come to the stage where we have already implemented it and then successfully going to run this conference. So well done at all of you for making this a huge success for the TMS, and obviously the TMS executive committee member. Some of you already are committee members for making this happen. So I wish you all success with this conference, and without any further ado, I would like to hand over to the amazing team, the organizing committee. Thank you and all the best.
Thank you so much, Mr. Mitropoli. That's very kind words from you, and we all appreciate it, and we all appreciate this opportunity, and we're very excited to be running this conference with you guys. So, guys, I just wanted to introduce myself. My name is Pedram Panahi, and I am one of the organizers, as Mr. Mitropoli introduce myself. So good morning, everyone. I'm very excited to be joining you guys. I'd like to also introduce my colleagues, Sanjid and Pushpa, who will also be saying hi.
Hi, everyone. I'm Sanjid, one of the other lead organisers. Lovely to meet you all, and thank you so much for attending our conference today.
Hi, everyone. I'm Pushpa. I'm one of the other lead organisers, and I hope you all enjoy the conference today as well.
Perfect. Thank you so much, guys. So the first slide, as you can see, is an outline of how the day will be run. This was circulated early on in the conference to everyone. So in the morning, prior to the break, we will have 2 talks from one of our core surgical trainees, as well as Ms. Lovett, prior to the break, followed by the morning oral presentations. Following this, our professor will be doing a research talk, and then we will break up for lunch. So I'm just going on to the next slide, which shows who will be presenting for the morning sessions. So this is a list of everyone who will be presenting. We will be coming back to this later on as well. Here is a list of the afternoon oral presenters. So without taking up too much more time, I'd like to just go on to the next slide and hand over to Sanjid, who will introduce our first keynote speaker. Sanjid, we can't quite hear you. I think you're on mute.
Thank you, Pedram. Thank you very much, everyone, for coming to our conference. Let's kick off with our first keynote speaker. I'd like to welcome our first keynote speaker of the day. He is a core surgical trainee based in Basildon Hospital in Essex, with a keen interest in orthopaedics. He's coming to the end of his core surgical training, and today he'll be giving us a talk about his life as a CST. It is my pleasure to introduce my good friend, Edward Laurent. Ed, are you there?
Good morning, everyone. Hi. Can you all hear me?
Can hear you. Are you able to take over?
Yeah.
Take control?
I think so. Shall I try? Nope.
No.
Wait.
There we go. Good. Over to you.
Yeah, brilliant. So hi, my name is Edward Laurent, as Sanjid kindly introduced me. I'm coming to the end of my core surgical training, 2 years. I'm based in the Mid-South Est Trust. I did my core training 1 at Basildon. I'm now at South End finishing my course. Today I'm going to talk to you about my general experience during core training, and also some tips and tricks that I sort of picked up along the way, which you may or may not find helpful. So I'd like to do a day in the life. It's almost impossible to do, which is because there's huge variation. You could spend a day in emergency theatre, you could be in elective theatre, clinics, first on call wards, etc. Such a broad specialty. That's why one of the main attractions to surgery, full stop, is that you don't get bored. You constantly have a huge variation, and you have many places to enhance your own skills and practice and experience. My overall view, I had a great time. First and foremost, you're doing what you want. For the first time, you're actually doing a surgical program, which is why you applied. You're not doing the ward rounds, which physicians do. You're doing surgery, which is fantastic. Okay. You're kind of off the bottom of the pile. What I mean by that is, I've never had F1s before. Very useful, very good. And it's quite nice to sort of find yourself progressing as your career begins to kick off. It is a fantastic chance to improve your operative skills. Most people, this is the area which you're weakest at, which is completely understandable. so you get a chance to really have exposure and improve those skills. And I put in brackets without expectation or judgment, because you are still there at junior level, so you can prove with the comfort and work your way up to registrar with that sort of safety net in play. Also, you get loads of study leave. There are some not so positives, things to think about. I put this, kind of find yourself on your own. What I mean by this is when you were maybe an F1 or F2 or a junior level, you'll find yourself with a bunch of other doctors at a similar level to you, so you can kind of bounce off each other and sort of help each other out. As a core training, you will find yourself maybe the only one in the department, a handful within the whole department. So it's something you need to adjust yourself about where you find help from. Have to work out your own learning needs. It's much more independent. You're not spoon-fed at all. You need to find out what you need to know and go out and find it. Okay, and it sometimes isn't as, you're not rotated in to meet all your demands, so you have to work around that. Exams, if you haven't done them, they have to be done. There's no way getting around them, and stress with exams. COVID, what I would say about COVID, I was obviously, because surgery, the way it's demanded, I was put into ITU for 4 months. Hopefully this won't happen to any of you, fingers crossed. But what I would say is if it does, make the most of it. Put in art lines, put in central lines, make a little plan, because when you can use this going forward. So here's some tips, and these are tips that are sort of collaborative between myself and other core trainings and registrars I've been speaking to. We've basically come together and got like a selection of tips, which I think would be helpful, especially before you start or when you're in the middle. It may sound silly, but you have to be organised. So what I mean by this is that you can find yourself in cruise control. You turn up to work in the morning, you leave in the afternoon, and you think you had what have you achieved that day? That's fine for a day here and there, but these days become weeks, become months, and by now you can do 3 months and realise I haven't actually achieved any of the goals that I need to achieve. So having a good plan in mind, I put weekly, monthly planner, but you need to know what you need. Entry requirements to ST3. Okay, this is core training is a stepping stone. Okay, you don't actually have to do it to become an ST3, but it's a great way of getting the necessary requirements. You need to find out the entry requirements of ST3 in whatever specialty you're going for. They're easily accessible. They're all online. Hold on, I seem to have lost my slides. Hold on. I seem to have lost. Can you still hear me, guys?
Yep, no, yeah, I can still hear you, yeah.
So the slide seems to have stopped working for some reason. Anyway, I'll just talk around this one. Okay, so entry requirements ST3, you will find them online. They're very easily accessible, and it lays out what you need to work towards. So it says the number of presentations, audit, publications, the amount of theatre time, what they look for at ST3 level. And that should be your guide. I put another thing to say that if you're not sure what specialty you want to go into, there's a lot of overlap, just to say. Now, this isn't to sound patronising, but it's so important to do this. The row coordinator has to be your best friend. They have the power to put you in theatre, to put you in clinics, to put you places where you need to be to sort of progress. And they also have the power to put you out of them. So if you give them something, they'll give you something in return. They need to be your best friends. SHO colleagues, these are the people that will cover for you. So if you're rotated onto wards, but there's an interesting case in the afternoon which you want to go in as, you can talk to them and say, guys, do you mind if I just go for an hour to do this one case and come back? These are the people that will cover for you. If some core trainees would just demand to do this and it doesn't go down well. Registrars, consultants, the more they invested in you, the more they'll allow you to do in theatre. And of course, never forget the scrub nurse. She's the one that will calm the theatre down when you're trying to get your perfect suture in. Educational clinical supervisor. As a core, you get to pick them. Okay, they're not picked for, you get to pick them. Nearly in every hospital, you get to pick them. Clinical supervisors, you could have multiple. I recommend utilising this. Get as many consultants as you can actually to be your clinical supervisor. like I say, if a consultant is invested in your training, by you telling them to be that clinical supervisor, you'll get a lot more out of the placement. I would also, just a little bit of advice, is with your educational supervisor, it's not as obvious as you might think. I would recommend picking someone that can influence change. Because if you consistently can't get out of meeting your necessary demands, you want someone that can influence the department to make change for you. All right, so comment on theatre. For theatre, for most trainees, this is the biggest stress, okay? It's usually due to theatre time or lack of theatre time. Most hospitals, every hospital is different, okay? And it's pretty common knowledge that district general hospitals, the small hospitals outside, much more theatre time than the tertiary ones in the city. They have a lot more simple cases, higher volume, less staff. The tertiary centres have much more complex consultant-led procedures, and you'll be competing with registrars. Okay, just something to think about when you apply. But obviously there are benefits to tertiaries over DGHs, but theatre is that one. And be smart with optimising your time. I kind of mentioned it before. If you're rotated onto wards, you can try and get a case in the afternoon if you're smart with this. There may be times when you just have to come in on weekends and you have to come in on your days off, but optimise your time and be smart about it. This is important. Always ask to do something. When you're in theatre and you're the first assistant, always ask to do something. They can only say no, okay? This is how you progress. Surgeons love operating, they love it. So they may not naturally give you stuff to do within the operation, but if you just say, would you mind if I close? If I mind if I do the leg? Do you mind if I put this port in? Do you mind if I just do this screw? You know, more often than not, they're gonna say, sure, this is how you do it. This goes back to the previous point about ST3. Index procedures are the procedures which, you know, you need to be getting in terms of get your registrar job, okay? For general surgery, it's appendixes. For orthopedics, it's DHSs. Find out what you need and then you target that, okay? So if you see a DHS in the afternoon, that's the one you go for because that's the one that gets you the necessary experience which is required for you to get into ST3. Just another point here, you'll always hear this person that did 1,000 appendixes and is a CT1 or did 1,000,000 hemis. It's ignore it. There's always those people, just ignore it. It doesn't help you. It just creates stress and it's actually counterproductive. You know what you need to do. You've seen the curriculum, okay? A comment on this. Core training, the purpose of core training is not to pass core training. The purpose of core training is to get a specialty registrar job. That is the purpose of it. There is a minimum requirement to pass core training, but to be competitive at interview, you need to do much more. So therefore, my advice is start early. Also be selective with your time. I can speak from personal experience that I spent a lot of time on projects that ended up going nowhere, okay? You'll get lured by people around registrars saying, "Oh, this research will get published in the best journals, you know, etc., etc." I think the prof will talk more about research. You need to have a step back and think: has this research actually got publishing potential? Has the person I'm working with been published before? And one bit of advice is: if you're in a hospital with a professor, seek them out. Ask them, like, "Are you working on anything? Can I help?" Also, you can now utilise F1s, F2s, other junior doctors to help you with this. Just another small point about also audits. You've now got to probably a stage that you've done 1,000,000 audits. You keep doing audits. Small audits, they take very little time, but they actually build a rapport with the person you're doing audits with. I can give you an example that I did an audit on Achilles rupture with one of the ankle consultants. And then it took me a day, you know, a few hours work max. He then calls me out of the blue and says, "I've got this external fixator. Do you want me to teach you how to use it?" He didn't have to do that call, but I think if I didn't work on that project before, then he wouldn't have given me that opportunity. Right, lastly is exams. Get them out of the way as soon as you can. Get them. You have to do them. They're an absolute necessity. You can't get around that. It should be the #1 focus until you get them done. Once they're out of the way, you can focus on the specialty you want to do. The exams are a broad thing. There's some of you that I'm sure that have done the exams. There's some of you that haven't done the exams. My advice is Get them done early and do not underestimate them. You do have to work hard for these exams. They've been my Achilles heel. But get them done and you can focus on what you want to do. So just to summarize on a few things, core training is a fantastic program. You're doing what you want to do. You have to be organized to get the most out of it and get the exams out of the way early. Just another point, if you're doing a run-through program, you still need to go from ST2 to ST3 via an interview. And if you fail that interview, they can keep you behind or take you out of the course. It's not as simple as just saying, oh, I've done my bit now, I'm going to be sailing through. So just something to think about. Lastly, best of luck, every guys. I think I've got some time for some questions.
All right. Well, thank you so much. Thank you so much, Ed. That was a great speech and really informative. I think it's really useful for all of us to know kind of, what to do when we embark on our core surgical journey. I think what we'll do is we will allow our participants, our audience members, to type in questions into the chat box. And what I'll do is I'll read them out and Ed, you can answer away if that's all right with you.
Yep, sure.
Stuff. All right. I'll start off. So how did you find the transition from F2 or, whether it be F2 or F3 into core surgical? How did you find that transition? Yeah,
good question. So remember, I went from F2 to core training. So before my core training, I did A&E and GP. So I had 8 months of not doing any surgery before I started. So it is a jump, it is a step. There's an expectation on you to be slightly better, and there's an expectation you put on yourself. But you've got to remind yourself that, you don't know everything, and it's fine to not know everything. You're still very low level, even though you think you might be just below registrar, but in fact you're just above F2. So it took a couple of weeks, but you do get into your stride.
Good. All right, got another one from Mr. Mitapali. So what would you advise the trainees to do to improve their academic CV?
To improve that academic CV in terms of publications or in terms of, yeah. So like I say, you have to select your projects carefully. Don't just jump on everything. Don't say yes to everything because your time is limited. So you need to be much more focused on the type of research you're doing. Don't take a step back and see whether this research actually has legs and whether you have the time to commit to it. If you do, then fantastic, go for it. I mean, I've certainly been stung a few times, and I imagine you will get stung a few times throughout your career. That's stuff that doesn't go anywhere, but sometimes you just got to take the leap of faith.
No, thanks for that. It's a good response. So next question is, what are the most important requirements to add into a CV to get into core surgical training? I think Lean may be referring to the core surgical portfolio. If you know, I'm happy to answer this. So essentially, there's a core surgical portfolio that kind of comes out every year. With each year as they come along, there might be small little bits of variation. I think in particular, the Masters in Medical Education wasn't counted as a Masters this year round, whereas it did last year. So it's something that you can all access if you create an email account on Oriel. Around about, say, like the October time, you can download the portfolio guidance and the CV guidance from Oriel when it comes to around about that time. Ed, do you have anything to add to that?
Yeah, absolutely. So it's sort of similar to where you need to find out what you need to do and how you need to word it. So there are specific words within the thing you need to be getting. So you need to influence positive change in certain aspects. It's written quite clearly. So that's your guide. Follow that guide to the T.
Brilliant. So our next question is, any tips for interview preparation? Well, what did you do, Ed, for the interview preparation?
Interview preparation. So my interview preparation was slightly different because of the COVID restrictions. So the whole interview process changed last minute. But talk to registrars that have been through the process. Okay, they're the best people to talk to. They've just been through it. They know exactly what it involves. There are question banks. There are courses. I recommend doing both if you got to put all your chips into this basket. practice, practice, practice. Find someone else who, either a registrar, a buddy, someone else going through the same process as you, and just run questions off each other. Because you only have 10-minute stations, you have to be slick from the moment. You can't mumble, think. You have to just deliver. Okay, so practice, practice, practice. It sounds cliche, but that's what you need to do.
Absolutely. And I think just to add, the TMS charity also host a core surgical training prep course as well in November, where we go through a number of scenarios from clinical to the management scenarios as well, just so that you guys can, practice that and giving advice on the portfolio section as well. So it's a great event to turn up to. So make sure you guys sign up to the TMS charity, and make sure, you guys sign up to the event coming in November. But no, absolutely, Ed, practice does make perfect. I can definitely echo that. We've got another question coming in. So how do you find time to work on portfolio work? I'm finding it hard during F2, but it seems like there's more study leave in CT. Has that helped?
Yes, I would put a little caveat on the study leave. You've got 30 days, but there's not any day of those days you can use for private research. It has to be courses. You have to justify every single study day. It's not easy. It's not easy at all, but you just have to work around that. Unfortunately, you have to sort of find times and have days off. Get help. I think when you become core, you can get help from F1s, F2s, keen people to help get the data, especially pulling data, and you can manipulate it. You do have extra time to do some things, but you just have to find the time, I guess.
Yeah, no, absolutely. I think it's an economy of time, isn't it? With all these things, and being organised. All right, another one from Deborah Brown. What courses would you advise as an FY1? I'm booking basic surgical skills and the MRCSA exam, but anything else advised?
Well, that's pretty good to do. Definitely worth doing the exam if you can get it done in your foundation years. Absolutely. So what I would say is getting on these courses, ATLS and CCRISPs, are actually really not as straightforward as you might think. They're core compulsory courses for many different specialties. So getting on the courses is very tricky. I'll just say that. You're doing the right things. I think, again, caveat that to follow on what you need for core surgical training. Find out what courses count, what courses don't. Don't point wasting your time and money on things which won't help you, not won't help you in life, but won't help you on the course, won't help you get into core training. So you have to really select what you want to do. I think basic surgical skills is one thing which can actually help you, full stop. So that's a really good one.
All right, I think our next one is a pretty loaded question here. How best to approach the Part A exam?
How best to approach the Part A.
I think we do a whole
all right, so
course
Part
on
A.
that.
So Part A, there's some really good question banks out there. There's the EMRCS and there's PASS Test. PASS Test has a lot of videos from a really good professor that teaches anatomy, and he teaches it very, very well. And it's all video led, so you can sort of flick through, pause, rewind. Really good. There's also a really good, can I plug a book or not? There are some
just to preface that, TMS aren't endorsing any books or any other material that aren't associated with TMS, but Ed, you can go ahead as a recommendation from your own personal experience.
From my own personal experience, there's a book called, I think the author's Rafferty. It's the standard book for the Part A. If you put it into Google, it's the first thing that comes up. It's a very good book, especially when you put it online, because it has an online code, because you puts it into modules, and that should basically mark out your whole revision for Part A, module by module. It's not a straightforward exam. Some people just say just use the question banks. You need to do a bit of both, and yeah, best of luck.
I think, yeah, I've got to echo that. I think when it comes to the revision, you've got to kind of use a number of sources. I used YouTube as well. YouTube is a great platform. I think it's almost underrated, and I think you've got time to also go through some podcasts. Depends what kind of learner you are. You're now an adult learners, so I mean, you guys have gone through med school already, so you should hopefully know by now how to study. But I think try and use a number of sources, because that's kind of like the trick with it. But yeah, I think the question banks are kind of the big hitters there. No, thank you, Ed. I've got another question here from Lydia Mann. What's your advice on being penalised points-wise for ST3 application if you've had more than 1 year out of training? Would you advise trying to avoid this penalisation?
So yeah, just in case people don't know what we're talking about, the number of years post foundation year is a number which is divided by the number of stuff you've done. So all your publications, presentations, audits get divided by the number of years you've been out after foundation year. So if you've taken extra years, that number increases, so you have to have ended up doing twice as much of your extracurricular stuff. So if you were to take a F3 year or a CT3 year, then you have to think about that. For COVID, they actually increased that number. So me taking an extra year is the same as me not taking an extra year in terms of that dividing number, if that makes sense. I don't know. It does have an impact. It depends what you do. A lot of people do CT3 years, F3 years. If you're quite productive with it in terms of getting some extracurricular stuff done, then it's worth it, definitely.
Yeah, no, I think, yeah, absolutely. I think, if you make best use of your time, regardless of whether you take years out, as long as you, as long as you make best use of your time, it really shouldn't be a problem overall. All right. So next question is, what courses are compulsory to complete in core surgical training?
Okay, there are 3 compulsory courses. It's the basic surgical skills, the Royal College one, not the one that your hospital does. CCRISP, which is care of the critically unwell patient, I think was it. And then ATLS. They're the 3 compulsory, absolutely have to have them. There are other courses depending on what specialty you want to do to think about. So for orthopedics, there's the AO course in basic trauma fracture management, which you don't have to do, but it's encouraged. But they're the 3 you have to do, and you get full funding for all 3 of them within those core training years. Just a thing.
So a great way to save some money then, I think, to try and do them in your core surgical rather than early on.
Well, you've got to get into core training first.
Of course, yeah, no. Yeah, no, of course. All right then. Our next question is, would an F3 year of non-surgical jobs or locum shifts have a negative impact on CST application? I'm
not sure about CST application. I think the process is it doesn't seem to affect, if I'm correct, Sanj, but
so,
it will do for ST3, because even that extra year may not affect you going into CT, but if you go into ST3, it will affect you in terms of the number of years you've been post foundation too.
Yeah, fine. Because so I'm actually an F3 and I've got into core surgical training, and I found that this year was actually really good for me in kind of a number of ways, and it's helped me with my portfolio because I've been a bit more active and a bit more time. So it really does depend on kind of what what you do with your time. If it doesn't really affect it for core surgical training, but I think the upper limit of how many years you can take out, you kind of exceeded that already, going into applying for ST3 already. So yeah, I mean, hopefully that answers your question there. All right, so next one from Asha Asif. When would be the best time to do an MSc/PhD? In between F2 and CT1, ST1, or during surgical training? What are your thoughts?
Ooh. I mean, if you're doing an MSc PhD, you're going to have a really good portfolio, so that's a really productive way to do it. When to do it? So kind of up to you. If you go into ST3 with a master's and a PhD, then you're just going to cruise through surgical, specialty training in terms of your portfolio to get a really good wedge. When to do it? It's kind of up to you. I know some people that did it between F2 and CT, and it worked really well for them. And I know some people that did it between CT2 and ST3, which is also quite common. I don't think there's a right or wrong answer here. I don't
think there's a right or wrong answer here either. I think it should really, I think really with the focus on this, with the MSc, PhD, it should be something that you're really interested in. Remember, you're going to be doing a whole thesis on this, so you've got to be, first of all, interested in it, and you've really got to take a liking to it. And second of all, it's got to fit in with your your life plans. You can opt in to do a less than full-time training and do a PhD alongside with. I know people who are doing that already. And it really doesn't matter when you do it and what you do and how you go about doing it. So yeah, I mean, that's really good that you're thinking about it. But yeah, I think the answer is that it's down to you as to when it's right for you. All right. No, thank you, Ed. Thanks for that. Our next question from Thomas. Mrozek. Sorry, I think I've butchered your name. I'm so sorry. Any recommendations on how to select topics for research projects as a first author?
Ooh, I think there's going to be a nice talk from a professor later on today. Might help you with that.
I think so. I think we've got a whole session on that as well.
Hold
Yeah.
that question for him. I think he'll be better answered.
Good stuff. All right. Next question, another one from Deborah Brown. Would courses from the RCS Edinburgh differ in any way regarding points from RCS England courses?
I wouldn't have thought so. I haven't got the right answer, but they're both the Royal Colleges. They're both in talks with each other. They're pretty fluid, especially in the early stages. So I wouldn't have thought so. I would imagine they mean the same.
No, I don't think there's any.
Give you a definite yes or no answer to that one.
Yeah, we obviously can't speak on behalf of the Royal Colleges, but I think from a junior doctor point of view, I think it's all the same and it will all apply because they're all Royal Colleges, so they're all pretty legit. All right, and I mean, for example, your this attendance certificate that you guys will be receiving after filling out the feedback form will be awarded from the Royal College of Surgeons of Edinburgh. All right, okay, next question is, can taster days in different hospitals add up, or does it have to be a stretch of 5 days at one particular hospital only?
I'm not sure about that. I think you need to talk to your educational supervisor about whether that does. My understanding was you have to do a week and then reflect on it, but I don't know for sure on that one, truth be told.
That's all right. Yeah, I'm not sure on that one either. But yeah, no. Yeah, sorry about that. I think yeah, just to reiterate, I think all the college courses are all the same for everyone. I think just to reiterate that point from Mr. Mitapali. All right. So yeah, I think. And this question is, what are the main differences between the Royal College of Surgeons England and Edinburgh? I think that's something for you to kind of go ahead with and to try and, find out for yourselves. We obviously can't speak on behalf of the Royal Colleges, and different Royal Colleges will offer different things, from different courses and, different conferences and whatnot. Ed, what do you have to add to that?
Yeah, exactly what you said. In terms of the difference between, I'm with the Royal College of Edinburgh, but it doesn't really matter. The differences between them. They say they want Edinburgh as the friendly college, but that's just a thing.
All right. Yeah, and I think a great point from Casson, who's actually one of our trustees of the TMS charity. I agree with the speakers. Research should be done if you're really interested in what you are going to do and have funding, because it's a massive commitment. If you want to be an academic trainee, the program will allow you time to do a research degree. Majority of us do it out of program through a normal training program after getting into ST3/ST1 as part of program for research. So there you have it. Thank you, Casson, for that. Brilliant stuff. All right. So how have you found, well, a question from me actually, how did you find kind of navigating theatre time, trying to negotiate that with the registrars? Because imagine, it's your first day. Take you back yourself to when you were first day core surgical training 1. You're at the bottom of the pecking order, really. How did you manage to kind of get time in to to scrub in for those operations you needed?
It's very hospital dependent. There are core training programs where they rotate you into theatre as first assistant, and there are other programs where you have to really negotiate. And what I mean by that is, you may be put onto a ward, but you need to talk with your other people on the ward to say, can you dip in for a case here and there? It may not be as obvious as what you may perceive. most registrars have been through the same process. They've been where you are. They know what you need to do. So they're much more helpful in certain things. Obviously, they're registrars themselves. They'll probably do the most of the work, but they may let you close and show you how to do certain things. You need to be present and you need to build trust with the registrars and the consultants alike. And then if you, sometimes you just have to be there. You just have to be there, and eventually you'll be getting more and more as you go along. No one expects you to be doing stuff straight off the bat when you're a CT1, because you are still very low down the pecking order, like you say. But you just got to build confidence, be in theatre, learn how it works, and you'll build confidence and you'll get more stuff as you progress through to core surgery too. Yeah.
Brilliant. Brilliant. I think Mr. Mitapali, if you're around, you can, please feel free to chip in for any exam-related questions or for anything or any advice, with regards to what you expect from a core surgical trainee. It'd be great. Please, please chip in whenever you feel free. All right. So. I think that's pretty much it. We're just waiting on some more questions. Mr. Mitapali, do you have anything else to add to what has already been said?
No, I think excellent talk, and I think you covered everything. Just to touch base on the colleges, all the colleges are same. I'm sure whatever you hear, and the points you get for various courses, they're exactly the same from each college. And the exam, it's an intercollegiate one, so there is no difference which college you get from. Obviously your affiliation will be different, but the actual points you get for courses and the recognition for the exam is same for whatever college you choose.
Amazing. No, thank you, Mr. Mitapali. Just wanted to direct you guys as well to, at any point during the conference, you can all have access to our social poster hall. I've just posted a link into the conversation box just for you guys to click away and have a look through. Really well done to you all for sending in your posters and doing well enough to get a poster presentation. Thank you so much. Ed, thank you so much for your talk. It's been very informative, and I'm sure it helped a lot of us out in preparation for CST. Actually, I think we've got one more question from Tim. Oh no, from Miss Lovett actually. The transition from FY2 to core is an important point in your career. As a trainer, I want to see you be present, and then I'm more likely to give you on-the-job training pointers and operating opportunities. I think that speaks volumes, really. Thank you, Miss Lovett, for that. I think Pedram wants to add something. Oh, hold on.
Yes. Thank you so much for that, Ed. That was a fantastic talk, very informative, and fantastic tips in there throughout the talk as well. I think everyone who's applying to core surgical training, it's very important to note that it is a very, very packed year. So if you're going into core surgical training and you have your part A and part B to sit, it will take up a lot of time. People usually spend about 3 months for each part. And if you, in the grand scheme of things, when you are trying to learn and improve upon your procedural skills, at the same time as revising, it can be quite difficult. So it's very important to bear in mind that this is a very, very packed 2 years, far busier than foundations, and probably busier than when you start your registrar training as well, because in those 2 years, not only are you trying to pass your exams to be able to progress through to registrar level, but you're also trying to increase your operative numbers, working towards that ST3 criteria, which again, I cannot stress how important that is. From before applying to core surgical training, I knew what the ST3 criteria for the specialty I was interested in was, and I knew exactly what I needed to try and achieve. It's really important that you have a plan ahead of your core surgical training for what you're going to do. This is especially important for the very competitive specialties, because your competitors will be doing this from the very outset, and you have to make sure that the time you lose in spending on revision for the part A and part B exam, you make up by planning ahead of this. And this is because the MRCS is a hurdle which everyone passes. You don't get a point for passing the MRCS when you're applying for SC3. Everyone has already passed it. So it's really important. Whilst it's great that, if you've already passed your exams and you're going into core surgical training, then that is absolutely fantastic. Quite a lot of people already have their Part A prior to starting core surgical training. I personally didn't, and this meant that for me, I had to work extra hard at the start to make sure that I get the Part A done. And like Ed was saying, the most important thing about Part A is question banks. You just have to do the questions again and again and again, because it's all about pattern recognition. There's a time pressure. And once you've done that, you should be able to pass the MRCS. There are great courses out there which you can attend for the MRCS exams, and people do this and find that it is indeed helpful. But of course, if you're doing a course on the exam, make sure that you've already done the book work. If you're going to a course that teaches on anatomy, it wouldn't be much point if you're opening your anatomy books for the first time since medical school. So just I can't stress how important it is to know that, whilst, getting the MRCS out of the way is important, everyone will have this by the end of their CT2 to be able to get an outcome 6 to be able and satisfactorily progress to registrar training.
All right. Thank you so much, Pedram. We've got our next. Thank you so much, Pedram, for that. I want to thank Ed for giving us that talk. Thank you so much for that, and thank you so much for your time. So yeah, feel free to hang around, and looking forward to see you again at some point in the future. All the best and good luck to you. Thank you very much.
Thank you very much, everyone.
All right. So I wanted to introduce our next keynote speaker, who is a consultant surgeon with a special interest in laparoscopic surgery. She is the core education lead for East of England Deanery. She's also a clinical unit service lead at Basildon Hospital. She's also an examiner for the intercollegiate MRCS over at the Royal College of Surgeons of England, and also an executive committee member there as well. She's also a human factors tutor at the Royal College of Surgeons of England, and in her past life she ran for Buckinghamshire 800 metres and for the 1500 metres, and won a full blue at Cambridge University for athletics, and now plays hockey at a bit of a slower pace at Chelmsford now. So it is my pleasure. Essentially, we'd love to who is to give us a talk on leadership and management. It is my absolute pleasure to introduce the one and only Miss Bryony Lovett. Thank you very much.
Oh, thank you, Sanjid. Can you hear me?
I can indeed.
So
I'll let you
take control of.
Please take control, please. Thank you.
Okay, let's see if we can move on. So I've got a new job now. I'm actually the medical director for surgery for the newly formed Mid and South Essex Foundation Trust. I'm no longer the core director for East of England, but I am the chairman of the Court of Examiners. So I'm very interested to hear what you have to say about the MRCS, because that's really very much my baby at the moment. Today I've been asked to talk to you about leadership and management, and you might think that leadership and management is something that you do later on in your career, but that's not true. It's something that starts from the very beginning, and it's an essential part of the application process. In the core application, if you go onto the website, you will find a section on leadership and management, and it makes it quite clear that to score 8 points, which is as possibly difficult to achieve, you need a national leadership or managerial role related to provision of healthcare for 6 months or more and demonstrate a positive impact. And if you read the guidance, it's really quite clear about what you need to do to achieve the 8 points. It's a bit like your GCSEs or your A levels. You're not going to get 8 points in an 8-pointer question, but you might get 6. You might get 6 quite easily, and you might spend a lot of time trying to get 8, but 6 is enough to pass. So just bear that in mind when you're going through the sections on the application form. You need to get more than half, nearer the top, but don't leave one section empty because you've decided you want to get a PhD in some bizarre subject. and get a big fat 0 in the leadership and management section. So look through the whole application process and make sure you tick all the boxes. And if you don't have anything for a box, work out what you can put in the box. Okay. Be aware that you need to consider all the aspects of your surgical training, and leadership is something that you've already all demonstrated. I read lots of CVs from trainees at your stages applying for various jobs, and in order to have got to where you're sitting today, you will already have demonstrated leadership at school, at university, medical school. Maybe you have done a research degree, you've had to work independently or part of a team, and you'll have done things within the NHS that interest you. So not everybody wants to be the mess president, and not everyone wants to join ASIT, although I would highly recommend it if you're a surgical trainee and you haven't joined the Association of Surgeons in Training. That is an excellent place to get national and international posters and presentations. Remember that all of the stuff you do outside your training is important. You know, working in the charity sector, it's almost essential to have done some volunteering to get into medical school, and you've probably continued with that if you have an interest, or you've been a scout or a guide, or you've worked overseas in a vaccination programme. These are all places where you have already started to develop management and then leadership skills. I alluded earlier on to be present. You know, if I don't see you on the ward or on the ward round, it's not that I forget that you're there. I'm very interested in you, but if I don't see you, I can't talk to you. And then when I'm doing the ward round and I think of an interesting audit project or a management project on the ward, if you're there, I'm going to say, why don't you do that? And then I want you to lead in it. I don't want to have to keep chivying you to do something, or I'm not going to chase you to say, have you collected that data? I want you to lead, not just to be a participant. And then you'll lead others. And I think Ed alluded to utilising was the word he used. I think encouraging your junior colleagues to participate is probably the term I would use. But initiate quality improvement projects, and they are the most important thing that you can do as part of a management pathway. Think about how you can improve the environment in which you work and then the safety for the patients that you're looking after. So what's the difference between leadership and management? Leadership is leading people to a common goal. You need to inspire people, motivate them and encourage them. You can't lead on your own. I can't lead a team of surgeons across 3 hospitals with a population of 1.2 million on my own. I can't do all the operations. I can't see every patient on the ward. So I have to inspire others to see the vision of a combined MSc Foundation Trust, and then I have to let them experiment and do things and change things and suggest things. Management is just the process of dealing with and controlling things or people. Managers plan, organise and coordinate. You already alluded to the rota coordinator. The rota coordinator is a manager, not a leader. They have an extremely important role in managing the shift so that every hospital has the right number of doctors at the right grade at the right time for every shift 365 days a year. And I don't envy them that job. So if you become friends with them, they will certainly help you. Eisenhower said leadership was the art of getting someone else to do something you want done because they want to do it. They think it's their idea. So if you can suggest to somebody that it was their idea in the first place, they're much more likely to support you. But it's also in management, if we know we're being measured, things get improved. And it's the Hawthorne effect. If I tell you I'm doing an audit of the time at which you arrive at work, you'll all be on time. If you don't think I'm measuring it, then it starts to change. So if we think we're being observed, we all sit up straighter, we all straighten our tie, we all wash our hands more diligently when the CQC are in the building. But actually, you should do all of those things all of the time, and you should encourage others to do them. So leadership is about nurturing and enhancing other people. There are some top 10, if you Google leadership and management, you find all sorts of interesting things on YouTube and on the internet. And there's a list of things that you need to be a leader and a manager. And I think it's, if we sat down in a workshop, you could probably come up with these skills, and you might look at them all and you might think, gosh, I can't do all of those things, or I'm very good at strategic thinking, or I'm rubbish at strategic thinking, but I'm very good at being punctual. My communication skills I can work on. You can become better at those by going on courses or just by practicing. Your interpersonal skills are things that you will have developed through the experiences that you've had through your training. You might be very good at taking on responsibility, or you might find the first few weeks as a core trainee quite daunting because that's not something you've ever had to do before. You've always had a really good team around you, and suddenly you feel like you're on your own. Some of the things that core trainees say is that the surgeons are never around. And that's not true. The surgeons are always in theatre. So if you ever feel lonely on the ward and you don't know what to do with the patient, you know, go to theatre, because you'll find a surgeon who will always help you. So I look back at what I've done in my career, and I'm not suggesting that any of you are going to be me. You're all individuals and you all have your strengths and your interests. So you've got to look at what you're doing in your jobs at the moment and work out where these are examples of leadership and management that you might want to discuss in an interview or put onto a CV that allows you to talk about the skill set that you have. So, you know, these are things I've done in my life, and many of you have done some amazing things. I'm always really pleased to hear about the interests outside work that drive and motivate you, because having a good work-life balance is a really important thing as a surgeon, making sure that you have something to switch off to go and do in the evening, whether that's you know a 10K runner, or you like to play badminton, or you're just good at reading books, or you're a concert level pianist, or you're just learning to play the flute. Who knows? It's whatever interests you, but all of those things will teach you the skills that you need. You know, learning to teach and coach, developing trust, showing responsibility. As a house officer, that was the first time I suddenly felt very lonely. I looked after 56 patients on the ward on my own every day. It felt like I was on my own, but I'm pretty sure that there was a registrar and there was definitely a consultant once a week who came around to check on what we were doing. But really, there was a sister on the ward. But I was on call 1 in 2. None of you have the misfortune to work 1 in 2 rotas very often anymore. But I worked in a team and I got my first chance to go to theatre. I was expected to spend all day in theatre as well as look after the ward. So that was the thing about time management. I became much more clinically aware of patients being admitted under my care. I worked out how to problem solve by using the Oxford textbook of surgery, which was a constant companion. But I learned to work as a team and I took responsibility. So start thinking about where in your career you have achieved some of your management skills. SHO or core trainee, again, delegation, suddenly having some other people to look after and be responsible for. Planning, so I could get to theatre, being organised, mentoring those 2. In fact, my first 2 house officer colleagues both became surgeons. It was something I was incredibly proud of. That was at Broomfield, too long ago to remember the date. But it was a commitment, and then I went off to be an anatomy demonstrator, because that was a very good way of passing what back then was the Part 1 FLCS. Again, it question banks, getting that time organised so that you could fit in everything you needed to do, and being 1 step ahead of the medical students when it came to demonstrating the anatomy for the next tutorial. Then life gets busier. Registrar, I did research between. I was a Calman trainee, so I did some years as a registrar, then my research, and then I went back to being a registrar, and then I became a lecturer in surgery. And along the way, I did lots of other things. I was fortunate enough to be the ASIT rep for North East Thames, and through that I became ASIT president on the national committee. I also represented trainees at the Women in Surgical Training inaugural event with Avril Mansfield. I've been mess president and treasurer in a number of hospitals. When I was the RMO at the London Clinic during my research, I got picked up to be the representative for the 3 of us, which meant I got to go and talk to some very senior consultants about the working conditions for the RMOs. Living in Harley Street was really quite tough. But I learned communication, self-awareness, delegation, forward planning. I had to get my research written in those 3 years, as well as being on call. As a consultant, it carries on. They're just the same skill set, you just do more of them. And I think as you go through from medical school through SHO, registrar, the subject doesn't change. Surgery is the same subject. It's just that your skill set grows and you become more confident. So now I've progressed from being CSU lead and divisional director to being the medical director for surgery. But that's brought out a whole new range of management and leadership, of understanding data, of being involved with people who do analysis, who think very, very differently from clinicians. Clinicians think about managing the patient, solving a problem. I don't think I had a lot of commercial awareness when I started my leadership pathway, and I didn't have the language of leadership that I sit in meetings listening to, and I wonder what they're talking about. And I now know which way up to hold a spreadsheet because I've been on financial training courses. I understand about cost improvement projects. I understand how to run a hospital in a crisis through COVID. So all of these things, they grow as you go through the experiences that your career will undoubtedly expose you to. So the language of leadership, a new lexicon. You all know about the audit cycle. And in fact, I always thought it was an audit spiral, not an audit cycle, because once you do an audit doesn't mean you've finished your project. Although you may move on to another job, someone else will repeat the audit that you've done, hopefully, in a few months' time. Otherwise, the audit ceases. But that's evolved into quality improvement projects, and you'll be familiar with the plan, do, check, act. In order to plan to change something, you need to know where you are now. How good are you? So if you don't have good data, you don't know where you are, whether you're good or bad, and that doesn't help you to focus on which areas of your department need to be improved. So plan. You talked earlier on about how do you choose what you want to research. When you're a young doctor, you may not know, and you will rely on your senior colleagues to suggest ideas. But then if you go away and think about it overnight, you may actually make that idea a much better thing, or you may focus it on a particular area of the job that has concerned you. So make it your plan. Take my idea and make it your plan, and ask questions. There's the who, what, where, when, why questions. Why are we doing this? Who should be involved? What are we going to collect? Don't get sucked into filling in an enormous spreadsheet with hundreds of data points that you will never complete in the 6 months or 1 year that you've got for the project. Focus your question. Then plan what you're going to do what you're going to do, collect the data, analyze it, get other people to analyze it or look at it. They may see things that you have missed. Then decide what you're going to do, work out how you're going to do it, and then measure it again. So you might get a run chart, for instance, if you have undertaken a project. This is time from GP referral to consultant appointment, something that exercises your managers on a daily basis. It's called the RTT, and hospitals are measured on their referral to treatment time. So if you looked at this graph, you can see that over a year, the time that it takes for the patient to get to see the consultant has changed. Certain things have happened. And I would focus on the red circle because something clearly happened in June that meant that the time from getting the GP referral to seeing a consultant has changed significantly. So I want to know what happened because I want to do more of that. Okay, so it allows you to select a point in time to go and look at and say, what might we have done? Well, we might have employed an external company to come in and do waiting list initiative clinics. We may have appointed a new consultant. We may have changed the referral pro forma for the GP so that we actually got the patient in the right clinic. There are lots of things that may have explained that change. So you may want to look at special cause variation. This is a tool where you can plot your data in time order. I'm going to show you a graph in a second. You try and work out where the median line would be in your data points, which half the data would be above the line, half would be below, and you plot them over time. And then you look to see whether you have a shift, 7 or more consecutive points above or below the median, a trend where they're all going in the same direction, runs which aren't quite a shift, or one outstanding astronomical point. So this is what a shift run chart looks like. Certain things happen along the timeline. This is a generic chart. We're measuring a characteristic. We've got some results that go up and down, above and below the median line. And then we've recognised that things have happened. We started collecting the data. And initially we had a bit of a positive effect because everyone knew we were measuring the data. Then everyone got bored because we were still collecting the data. And then we presented it to the surgeons in the audit meeting, and suddenly everybody started engaging in the particular thing we were measuring. And we did quite well with 1, 2, 3, 4, 5, 6, 7 points above the median. That's good. That's positive. and then something happened. The new junior doctors started, and we forgot to tell them about this project, so we dropped below the median again. And then we introduced electronic prescribing, and we got much worse. And then we pointed this out to all of the surgeons at the meeting, and they suddenly realised that there was a problem, and they all got better. So this is a very interesting tool that you can use to see how things are working in your department. And that may interest some of you, and some of you may be completely disinterested in shift run charts, but this is how you monitor a quality improvement project. Did the action that you took, arrows 1 to 4, actually have a positive or even a negative impact? You all need to develop leadership skills. At the very bottom, I would suggest that you're all definitely above 1. You started off as highly capable individuals when you went to medical school. You had to be to get there. You're now, having been foundation doctors, contributing team members. Without you, the hospital does not work. I cannot function if I don't have a team of juniors beneath me who are all making their individual contributions to the management of the patients. And that's not just doctors, that's all of the allied healthcare professionals. Hospitals don't work if you don't have portering staff to bring the patient to theatre. You can be the best surgeon in the world, but if you can't get the patient from the ward to theatre, it doesn't matter how good your operating skills are. If you don't allow other members to contribute to the team and you try to do all the work yourself, then you don't have enough time in the day. So you are all now at the point of being contributing team members. You're trying to become competent managers as you transform to core training, because you need to manage the team around you of the nurses, the porters, the FY1s and FY2s. And I would also suggest you're managing the medical students who are increasingly present on our wards, because they are part of the team too, and they can often point out something you haven't noticed because they may have clerked the patient or been aware and read about it and asked you a question that points you in a direction you hadn't thought of. How do you progress from being level 1 to being level 5? Those of you who are fortunate enough to work at Basildon, our chief exec is Andrew Pike, and I think he's probably one of the most motivating executives I've had the pleasure of working with, because he genuinely is interested in the success and well-being of the team. He talks to everyone in the hospital as if they're a personal friend, but he can still be quite demanding when he wants something done, and he wants it done now. But you have to give people the chance to grow. And in order to become the level 5 executive, you've got to be compassionate, genuinely interested in the people around you. You've got to be prepared to take risks. You're not always going to make the right decision, and mistakes are an optimal opportunity to better yourself and your decision-making skills. Now, sometimes in medicine, making a mistake can have catastrophic outcomes. And of course, we always investigate unexpected deaths or complications. We discuss them in audit meetings. And I would encourage you to go to audit meetings. I think one of my biggest concerns is the lack of foundation doctors and core trainees at audit meetings, because discussing morbidity, mortality, return to theatres and prolonged length of stay is crucial in learning where we're doing well and where we need to improve. You need to coach people, give feedback that enables growth. Don't criticise people when they get it wrong, but try to delegate and recognise the effort. And if they don't get it, don't do it quite how you would have done it, and take the time to discuss that with them, help them to develop and grow. You need to be an effective listener. To manage, you have to listen to what people are telling you on the wards when you ask a question. And there's good evidence that most people only listen at 25% efficiency. So if you're going to be a good manager and leader, you have to commit yourself to listening to the answer to the question that you asked. And you need to cultivate an inspiring vision. And Claire Paniker, who's the lead, the chief exec of MSE Foundation Trust, has created that vision over a period of 7 years, so we all know where we're going. Many of you will recognise transactional leadership. This is what you do on a day-to-day basis, often in a crisis or an emergency. So imagine a trauma call. It's transactional leadership. The leader of the trauma call will have supervised you, organised you, hopefully won't punish you, but will reward you when the results are good. They might note points for improvement, but they tend to be very directive and action oriented. If you're in the military, then you will be used to transactional leadership. This is the squadron major telling you how to do the project that needs to be carried out in a specific way. But even transactional leaders can think outside the box, but they're best suited to problem solving rather than strategic thinking. So how do you go from being transformational rather than transactional? How do you motivate through example? Well, the best thing to do is to be the best you can, and to acknowledge when you haven't always performed at your best, but challenge others to take ownership of their work. And I would recommend that you look at a YouTube video called Turn the Boat Around. I actually went to see this, I watched it the other day. It's about a nuclear submarine commander in the US military who completely changed the way he led his submarine, so that it went from being the worst performing submarine in the US military, almost a laughing stock, to being the best performing submarine, where every member of staff went on to achieve promotion and their own command. And he said something that I thought really resonated with me, that it's we, not they. And sometimes you hear people say, they, the managers, haven't provided me with the right something to do what I need to do. And if you want to have a really good team and you want to lead a good team, it's we are the team, not they are the somebody who's not done something for us. Your team members all need to be invested in the success. So I invest in the success of getting my core trainees onto surgical training numbers. I invest in taking surgical specialty doctors who come from overseas and want to go through the CSER route to get onto the specialist register. And if you invest in people, then they reward you, and they'll come in at short notice when someone's gone off sick and cover your shift. You know, they will be part of the team because they want the team to succeed. Each member needs tasks according to their strengths and weaknesses, but they also need to be given tasks that might not be their strength in order to demonstrate to them they actually do have that strength, but give them time and space to achieve those tasks. Make sure that you've achieved clear goals, but set high expectations of performance. This will influence your team to go beyond their own self-interest, and encourage followers to question you, because you're not always going to get it right, and they may have some really, really good ideas. But be prepared to review progress. And if some of you will have come across Richard Bomer, who's the Harvard professor who's been involved at Mid-Essex for some time, and he constantly says you should be acknowledge that you may have made a wrong decision. Don't be scared to say, we decided to do that and now we realise that wasn't the right thing and we need to do something different. So once you're leading, you're going to be part of a team, and teams also have leadership behaviours. And you can see here, this diagram is quite an interesting way of evaluating the strengths and weaknesses of your team. At the top, we've got inspiring a shared purpose. Has your team, this team's pretty good at that. They've managed to inspire their shared purpose. Maybe they're not so good at engaging the team as a whole. Maybe that's what they need to work on. Do they need a team building day where they go and carry logs across streams at the nuclear assault course? But they're good at holding each other to account. But do they do that in a way that encourages others, or do they hold each other to account in a way that undermines people? Do they connect with the service? Are they good at talking to patients? Have they got lay people involved in their decision making? So you can start to look at the strengths and weaknesses in the leadership behaviours of the team around you. You can either appoint people to fill those gaps. So this one, evaluating information. Maybe we're not very good at looking at our data, so we bring in a data analyst or someone from an external company to look at it, so we improve our performance in that area. So are you a divergent thinker or a convergent thinker? I think it's interesting when you look at this. The convergent thinker here looks very cheerful. It's quite clear there's a straightforward question. Is it a sunflower or is it not a sunflower? I don't know, you might think that's a sunflower. If you're a divergent thinker, you're looking a bit more confused and a little more unhappy, but you're asking much more interesting questions. Most of us are, well, I'll speak for myself. I think most doctors are on the spectrum, quite a long way on the spectrum, highly intelligent, driven by results, interested in facts, not always the best communicators, but we like facts. We have been learning facts since we were at primary school. We know the answers to the question because we've learned all the facts. We use logic. In fact, we use pattern recognition. And we sit over here as convergent thinkers. But what you really need to be a leader or a manager is to have divergent thinking, and you have to practice this. Work out how to take yourself out of the comfort zone of being a convergent thinker and use your divergent thinking to think, okay, how this isn't working, how do I think differently? What could we do to make it different? So I want to introduce you to the concept of wicked problems. You'll be familiar with the green evil witch, the wicked problem. A wicked problem is one that doesn't have an easy answer. And if you're going to think about projects that you could look at for management and leadership, you need to look at the wicked problems, not the easy audit of, how often does the ward door get left open? How often do people wash their hands accurately? But you've got to start looking at the paradoxes going on around you. And two things are going on at the same time that may not necessarily work together or might complement each other. And you have to ask these questions. This is quite a good template. How is it that we are doing something and doing something else at the same time? Don't try to blame people. Don't ask nasty pointed questions that almost blame others. Don't ask questions that you can answer with data, because if we can answer it with data, it's not a wicked question. But expect these questions not to have easy answers. An example at foundation and core level might be, we've noticed, how is it we can step up to reduce infection and step back to empower the ward to take ownership of prevention practices? I don't want to go on the ward and tell the ward sister how to tell all of the staff on the ward how to wash their hands. I want to empower the ward sister to realise that her ward is the best ward in the hospital in terms of infection rates, and try to work out how she's achieved that by empowering everyone to be responsible for their own infection control practices. And the converse is also true. So if you put up a ranking score of different wards' infection rates in the governance meetings across the hospital, the ward sister whose ward has the highest infection rate is going to be going and visiting the one with the lowest infection rate quite quickly to see what they're doing on their ward that she could or he could take back to their own ward. One for you that we often ask: how can we achieve 95% VT target and allow individuals to take ownership of the assessment and prescription rather than employing somebody to go around the hospital and do it on every patient routinely and upload it to the system? So we're running slightly late, so I apologise for that. I'm going into a coffee break, but you might want to think about how is it that we are doing something simultaneously. So think of your own wicked questions, because those are the questions that start to exercise your leaders. How do we banish complacency? Has our culture evolved with time in the way we think it should have done? Are we really being totally honest with ourselves? Are we breaking new ground? Are we looking at ourselves through the right lens? Are we sufficiently critical of ourselves that we are going to make improvements? So what opposing and yet complementary strategies do we need to pursue in order to be successful? On a personal level for you, your opposing yet complementary strategies are going to be: how do I do enough questions to pass the part A while making sure I'm present on the ward, so Miss Lovett gives me an audit project and I get to theatre to practice my basic surgical skills, for instance. So I apologise for running slightly over, and I'm happy to take questions.
Well, thank you so much, Miss Lovett. Thank you so much for that talk. I think what we'll start is we'll take some questions from Mr. Mitapali. I think you've got some ready, don't we?
Yeah. Bryony, excellent talk. Congratulations on your new role with the college examinations. And I'm sure I'll see you around when we do some exams together. I couldn't agree more with you regarding ASSET. I've been the ASSET Council member and executive. That's where I met you when I was the Director of Education at the ASSET conference. I've got a couple of questions. I've got quite a few, but probably I'll leave it to the others to ask. A couple of questions. The first one is, do you think our current programs or the training programs teach our trainees enough skills in leadership and management?
I think that leadership and management didn't, well, when I was training, there wasn't a program of training at all. The ISCP curriculum does actually have leadership and management in it, which is a huge step forward. But there are some hospitals where leadership and management is included in the training that's offered, and there are opportunities to shadow managers and leaders. And I think that's something that we've talked about in MSc, is giving, if you don't realise what's going on in the management office, you start talking about them as they. And sometimes you hear people talking about managers as they need to do this, forgetting that a well-run hospital is clinically led, and a clinically led hospital has clinicians who are also leaders and managers. So if you go to any of our executive meetings, there's not a team of managers telling the surgeons what to do. There's a team of surgeons who are also leaders and managers. And when you say, let's have a consultant meeting without managers, which consultants are you going to not have in the room? Because essentially we all have a responsibility for managing. You manage your own team, you manage the ward. So actually I quite often say at the beginning of the ward round, who's going to lead the ward round? Because I don't want to lead the ward round. I've already been up all night. I've seen most of the patients. I want one of you guys to lead the ward round and decide which patients we're going to see in order of preference of importance. And I want you to tell me what you're going to do with them. And I'm really there to just check that you're doing what I want to do. So leadership and management is embedded in our day-to-day work. We just don't necessarily always recognise it as that. But I would encourage you on your 0 days to take the opportunity to spend time with the people who manage the service that you work within, and then you'll have a better understanding of what is required to make sure your theatre list starts on time with the right staff and the right equipment, and all of the people get to the right hospital to do that operation. And what's the pathway that the patient's taken? Who organised the green zone in your hospital? Who sorts out pre-assessment? Have you ever been there? You've got to start asking those questions on the back, in addition to learning all of the anatomy, physiology and biochemistry that you need to pass the exams.
Absolutely. I mean, that's excellent. And I try to do the same, actually, because taking a step back and then letting the registrars or juniors to take the ward round and take the control, you're actually observing and then teaching them how to lead. That's excellent. Just another one. What's your advice to these all junior doctors? How can they optimize to get more leadership and management skills during their day-to-day job? I know sometimes some of the consultants are very pro. We let them lead and then actually teach them all these skills. But what they can do to actually optimize their training better as a junior doctor?
I think there are opportunities in many hospitals to be part of the education and training programme. And if you look at the leaders in the hospital I work in, most of them started as the educational leads. They were educational supervisors, clinical supervisors. They were on the education committee. They took the college courses and delivered them in their own hospitals, and they sat on the sort of the medical student committees, and then they progressed from there through into leadership and management of the whole hospital. So if you want to start somewhere where you feel comfortable, I remember the first teaching session I was ever asked to give as an SHO, and I didn't know I was going to give a teaching session. No one had told me. They just said, you're going to teach the students. We found you a room. And I was like, okay, I know, I'll talk about the patient I admitted last night, because I was the expert in that room about that patient. None of the students knew anything about the patient because I hadn't seen the patient. So I was a whole step ahead of them, like I was a whole step ahead when I was an anatomy demonstrator, because I'd read the book the night before and I was bright enough to remember it. So teaching is a really good place to start to hone your skills. And the really important thing about giving teaching session is getting the feedback at the end of it and being honest with yourself. If someone gives you feedback that is less than perfect, then that is more useful to you than, oh, that was a great session. What you really want to know is, which bits of that could I make better? Which bits of me do I need to improve? So you need to look at yourself with a very honest lens and say, this is what I need to do to take the next step up this confidence ladder of leadership and management, because every single one of you has already done leadership and management. I bet through school you've been prefects, you've been first violinist in the orchestra. There will be something in your portfolio that already shows that you have that ability, but you've just got to be confident enough to keep experimenting with it and recognise that sometimes you'll get it wrong.
Yeah, no. Well, thank you so much, Ms.
Thank you.
Lovett, for the talk, and thank you, Mr. Bismarck, for those questions. Ms. Lovett, thank you so much for your time and for that informative talk. And yeah, it's always a pleasure to have you, and look forward to see you at some point in the future. Thank you so much. Thank you. What I'm going to do is just introduce Pedram, who's one of our lead organisers. We are running a little bit behind time. So I think what we'll do is we'll save the questions for another time. So Pedram, are you there?
Hi. Yes. We are running slightly short. So what we are going to have to do is launch straight into the oral presentations. Now, as all the oral presenters have already been briefed, please make sure that you stick to your 5-minute allocated time. At 4 minutes into your presentation, and we will be using the raise hand feature to give you a 1-minute warning. And then following the end of this, there will be 1 minute for question and answers, and finally there will be 1 minute of transition. But please make sure that once you reach your final slide, you do not do anything, and we will take control back. Please make sure that you keep your microphone switched off before and afterwards, and we can now go on to the next slide. We do have 3 minutes, so if you wanted to quickly stretch your legs, please feel free to do so. And our first presenter will be Dr. Lacpria, so please stretch your legs, and we will restart at 10:30.
Thank you very much, Pedram. Just to remind everyone that our poster hall is live, so when you do have free time, just to check it out. Thank you to all the participants who have submitted in their posters. It's made for a wonderful poster hall. So yeah, just as Pedram said, we'll be starting at 10:30 with our first oral presentation. Thank you.
Dr. Lacpria and Dr. Maham, are you with us? If you're
yes, we are, Pedram. Hello.
Perfect. So if you want to take control of the presentation, and then once it takes 10:30, please feel free to start.
Yeah, lovely. Thank you.
It's 10:30. Start.
Okay.
You have to do.
Yep. Hi all. Good morning. I'm Dr. Safia Lacpria, and I'm joined by my esteemed colleague, Dr. Maham Khan.
Hello.
We are both clinical anatomy demonstrators in trauma and orthopedics based in Southwest. So our presentation, Trauma Talks, the evolution of impact of weekly orthopedic junior teaching sessions in a major trauma center during COVID-19 pandemic. As we all know, the COVID-19 pandemic has presented many challenges to training, including an important one being teaching, whether that means attending it or delivering it to the trainer and the trainee both. Trauma Talks was a concept developed to help overcome this issue during the global pandemic. This entailed hour-long teaching sessions every week in a trauma and orthopedics department in a major trauma center to all members of staff, delivered by all levels of the trauma team, including trauma and orthopedic consultants, and trauma and orthopedic senior registrars, senior house officers, physicians associates, acute care practitioners, and medical students. The teaching or the training sessions ran over a period of 10 months, now going on to the 11th successful month. The curriculum was designed along with the consultant trauma and orthopedic surgeons and consultant orthogeriatricians to reflect the outcomes of an orthopedic juniors poll, which we held before the start of the series. So far, more than 35 sessions have been delivered on topics covering basic orthopedic principles and skills, common orthopedic presentations, management of orthogeriatric conditions, journal club sessions, and academic surgical skills. These sessions were delivered physically in a designated seminar room in the orthopedics department, adhering to the social distancing guidelines at the time, and was broadcasted virtually through Microsoft Teams via a channel allocated for teaching. We had guest presenters, trainers, and our very own team members delivering teaching remotely once the system was established. To reduce the gap between the virtual teaching and getting participants to interact, teaching was facilitated by the use of applications such as MyRobot, in which the trainees could participate in labeling or interactive activities, a complete anatomy application in which virtual dissections were made possible, and Kahoot quiz, an online group quiz application to test the knowledge of the participants. Apart from the trainer leading the session, these were also mediated by a co-led facilitator to set up the logistics and to monitor the chat function while the sessions were being delivered. Consolidated feedback was given to the trainers, trainees alike, which ticked the boxes of observed teaching and created a platform to discuss areas of improvement and knowledge. Certificates were issued to the teachers and the trainers and the participants. I will now pass on my microphone to my colleague, Dr. Mahan Khan, to talk about the results and the conclusions.
So our results showed that about 62% of the participants had managed that they didn't receive any organised series of formal teaching prior to Trauma Talks in the department during COVID-19. All of the participants agreed that these sessions were relevant, improved their clinical understanding and practice of the day-to-day orthopedics and orthogeriatrics topics. As my colleague previously mentioned, some of the orthogeriatrics topics covered both medical and surgical topics, which was quite useful for the junior doctors in the department. In comparison to delivering the lectures, use of novel applications such as complete anatomy, Miraboard and Kahoot had increased the engagement in the teaching sessions. So overall, the feedback from the team was extremely positive as they had more protected teaching and training time and were able to receive constructive feedback. The trainers and the participants both had access to the Trauma Talk series remotely, resulting in the maximum participation. So currently we've disseminated our sessions at a regional level to other departments, and we've adapted the concept of Trauma Talks. It's not only helped trainers get the opportunity to treat during COVID, which is quite difficult to do, but also to get some feedback on it from the students or junior doctors or whoever it may be. Some of the limitations mentioned were that all the teams weren't able to be present at the time, and we counteracted that by using the online platform and recording the sessions for anyone who had missed it. We've got a further scope to sort of expand this at a national and an international level, and we want to start making some basic surgical skills workshops and some plastering workshops. And the good things about this talk is that it's completely free. As we all know, courses are really expensive and difficult to access, especially during COVID, and it's difficult to be reimbursed if you're not a training member.
Thank you. Do you have any questions? Shall I stop presenting and pass over the
control button? Mr. Abdullah, if you have any questions, please let us know.
No, I'm all right. Thank you.
Okay, perfect. If there are any questions from the audience, please just type them into the chat box. If not, we will proceed on to the next presenter, who is Dr. Henry. Please make sure you, Dr. Henry, please make sure you turn on your microphone and let me know if you can take over control. You may start at 10:37. Thank you.
Hi, yeah, I can take control now. Okay, good morning. My name's Helena. I'm currently an F3 in trauma and orthopedics, and today I'm going to speak to you about an audit we did looking at chemical VTE prophylaxis in elective upper limb surgery. So VTE prophylaxis for surgical patients with lower limb trauma is well established, and most trusts have their own local policy guided by national standards. But for elective patients undergoing upper limb surgery, trust guidelines are less well established. There are a number of orthopedic bodies which do offer guidelines, but they tend to vary in their advice. So really it's down to the named surgeon to decide which to follow. So BSSH had some guidelines published in 2019, and they look at the thrombosis risk factors for patients. So it includes age and comorbidities. And then they look at whether they had LA or GA and their anaesthesia time. And then they'll risk stratify these to decide whether a patient should have no prophylaxis, mechanical prophylaxis, so TEDS, or we should consider chemical VTE prophylaxis, so Clexane. The British Elbow and Shoulder Society are slightly different. They don't recommend any chemical prophylaxis for patients unless they have active cancer or a history of thromboembolism. NICE do offer some guidelines, but these are more to consider giving it to patients. Again, they look at their comorbidities and anaesthetic time, but are somewhat more vague. So the aims of this audit were to look at the extent to which patients who undergo elective upper limb surgery in an elective orthopaedic London hospital were prescribed chemical VTE, and whether this follows current recommendations outlined by BSSH and BES. So this was a retrospective study. We did 2 cycles. We collected data on demographics, the length of surgery, so this was defined as time from knife to skin and surgical end, whether they had any intraoperative VTE prophylaxis, so flotrons, and documentation of VTE prophylaxis in the operation note. Each patient was individually assessed, and then we compared it to the BSSH and BES guidelines. So the results from cycle 1, perhaps as you would expect for elective operations, most of these patients were ASA 1 or 2. 12 out of the 43 were over 60, and only 9 patients had an operative time of more than 90 minutes. So when we looked at each patient individually, we found that in general, most patients did satisfy the guidelines. However, there were a few which deviated from the guidelines. So one patient had an operative time of more than 90 minutes, more than one risk factor, and was not given chemical prophylaxis, but there was no documentation as to why. There was another patient who, again, was not given VTE prophylaxis, who perhaps should have been given it according to BES criteria. And out of the 43 patients, documentation of specific guidelines was only in a few of the operation notes. So the conclusions from the cycle 1 was that the discrepancy in upper limb surgery as to who should be considered for chemical VTE prophylaxis. The majority of patients are not prescribed it, and whilst this may be appropriate, the documentation as to why we reached this decision is lacking. So the aims of this, aims from this cycle were to encourage the surgeons to clearly document in their operation notes which guidelines they followed, and then we re-audited this. So for the second cycle, the demographic data was very similar. And the results showed that 96% of cases did satisfy the guidelines we were following. One patient who underwent shoulder surgery who had a previous DVT was not prescribed it. And again, we're not sure why, because there's no documentation. And if we compare the 2 cycles, there was a modest increase in percentage of patients that satisfied the guidelines and percentage of patients who actually had a documented decision in their operation note. So future aims really from this audit is to encourage specific documentation. Whilst we did try to educate our team on this, inevitably when it came to filling out the operation notes, this again was missed. So we suggest that a specific VT section is added into all operation note templates to ensure specific documentation. And hopefully this will improve patient safety and patient care. Those are my references. I would just like to acknowledge my supervisors, and we will now take any questions.
Okay, thank you once again. If the audience have any questions, please type them into the chat box, and if the scientific panel have any questions, please unmute your hand. Okay, Dr. Philip, if you're with us, please can you take control, and once it reaches 10:44, you may start.
Yep, I'm with you. I hope you can all hear me. Is that okay?
Yes, we can hear you fine. Thank you.
Perfect. Are you happy for me to start now?
If you could just please wait till 10:44 and then you may start.
That's perfect. Okay, so good morning, everyone. My name is Filip Brzezinski. I'm a junior doctor in NHS Lothian in Edinburgh, and today I'll be presenting a systematic review on the role of preoperative sarcopenia detection in emergency laparotomy surgery. So sarcopenia is defined as an age-related generalized skeletal muscle decline, and it's an important topic because up to 10% of the world may be sarcopenic, and with the aging population, those numbers are likely to increase. Now, there are specific guidelines on diagnosing and defining sarcopenia in patients defined by the European consensus, and essentially they look at the patient's muscle strength, muscle size and quality, and also at the function of muscle parameters. Now, sarcopenia has been shown to be associated with poor postoperative mortality and outcomes in many different surgical fields. So we do know that. And when we actually think specifically about emergency laparotomy, which is an incredibly invasive procedure for quite, often life-threatening conditions such as bowel perforation, obstruction, these two factors both are likely to combine and have poor outcomes. So just intuitively speaking, I think any one of us would prefer to operate on someone with a healthy body composition. You can see that there's good muscle bulk and the muscle is of high quality, highly attenuated, and there is low fat infiltration of muscle, compared with someone who's sarcopenic in the bottom row and just seems to look more frail. So the aim of the study was to assess methods just currently present in current literature used to detect preoperative sarcopenia in emergency laparotomy patients, and to evaluate the associated postoperative outcomes for these patients with skeletal muscle decline. So For methods, the study was performed with reference to PRISMA guidelines. We used Medline, Embase, and Google Scholar databases to search for publications on preoperative sarcopenia detection methods and associated outcomes after emergency laparotomy. Essentially, our inclusion criteria required studies to have patients as defined as sarcopenic and patients as defined as non-sarcopenic, so they had to identify sarcopenia in some way, and then they had to compare the outcomes after emergency laparotomy between the two groups of patients. And the risk of study was assessed using Newcastle-Ottawa scale. So the results showed that we didn't actually have that much research in the current literature. Only 103 studies were identified, 19 full texts were reviewed, and eventually only 7 studies were included in final analysis. So sadly, because there wasn't really that much research on the topic, we couldn't perform a meaningful meta-analysis. But in the study, across 7 studies, we had 1,107 females, 973 males, and the age range was actually just about right for a sarcopenic cohort, ranging between 36 to 95 years of age. Essentially, all of the studies that we included used CT scanning to measure patients' psoas muscle mass and defined patients as sarcopenic as someone who had low psoas muscle mass. And different studies used different cutoff ranges. 3 of the studies additionally used muscle quality by looking at the CT images and looking at the attenuation of psoas muscle mass. And patients who had low, essentially, attenuation of psoas muscle on CT imaging were also defined as sarcopenic. Of the studies which essentially assess patients and define patients as sarcopenic or non-sarcopenic based on muscle mass alone, 5 of the 7 studies showed an association between low muscle mass and increased mortality rates after emergency laparotomy surgery. And the studies which define patients as sarcopenic based on muscle quality, 2/3 of the studies showed poor 30-day survival rates in patients with low muscle quality. Essentially, we thought that most of the studies had pretty good quality. 4 of the 7 studies were deemed to be of high quality, and 3 of the 7 studies were moderate quality based on the Newcastle-Ottawa scale. So in conclusion, I think the first point is really that there isn't much research done on sarcopenia in this emergency laparotomy setting. However, low psoas muscle mass and quality are generally associated with increased mortality after emergency laparotomy. Psoas muscle mass measurements compared to muscle strength and function seem to be more prevalent, and this kind of does make sense. It's difficult to measure muscle strength or function in someone who has an acute abdomen and is peritonitic. And future research should further investigate muscle measurements as predictive tools for preoperative planning, decision making, and possibly muscle measurements may already augment prognostic scoring systems such as PPOST and NALA. I'm just about to hit 5 minutes, so thank you very much. Does anyone have any questions? Here's my references.
Hi, Philip. Yeah, so all our patient, all the inclusion criteria was only on elective basis or emergency basis?
It was just emergency patients, emergency laparotomy.
But I think our recommendation for elective planning or for emergency planning?
Say that again, sorry?
Our recommendation for the elective or emergencies?
For emergency, it's for emergency specifically, yeah.
Emergencies. All right. Can you tell us more about the Newcastle score?
Yeah.
So
the Newcastle-Ottawa score basically just looked at different parameters of assessing just systematic quality of the studies. It looked at how well the subjects were chosen for the studies, how well they were compared to the controls of the studies, and it just there was basically a 9-point system that you used to basically assess the quality and systematicity of the studies.
All right, thank you.
Thanks.
Okay, thank you. Dr. Temideo, are you with us? Can you please take control and start presenting at 10:51?
Can I start now?
Could you please wait till 10:51 and we may start?
All right. Okay, thank you. Hi, good morning. I'm Dayo. I'm an academic foundation doctor from Yorkshire and Umber Foundation School. And today I'd like to present a study where we investigated the if psoas muscle thickness measured on CT scans can predict mortality in patients with alcoholic liver disease. So alcoholic liver disease refers to liver damage caused by excess alcohol intake. And liver disease is one of the major contributors of mortality in the UK, and alcoholic liver disease contributes a lot to this. The definitive management for alcoholic liver disease is liver transplantation. But of course, donor organs are scarce. And there needs to be a way to prioritize patients who need transplantation. And in the UK, we use a sickest first policy, whereby patients who need the liver transplant to survive will get it. And in the UK, there's been an evolution of how patients are located liver for transplantation. So it started with the Child-Pugh score, and then we moved on to the UKNC liver disease score, which looked at various biochemical parameters like creatinine, INR, and bilirubin. But in 2018, we moved away from this prognostic model because it was felt that it wasn't predictive enough because it didn't predict for certain patients, such as those with refractive ascites. So currently in the UK, we use a transplant benefit score, which was introduced in 2018, but this score is undergoing validation at the moment. However, various studies have shown that sarcopenia is actually a major independent predictor of mortality in patients with alcoholic liver disease. And it's also been shown that, as mentioned in the earlier talk, there are various methods of measuring sarcopenia. One of them is using CT scans, MRI, and also using some form of function for this patient. However, we chose to use CT scan because CT scans are routinely done for this patient. And also we've chosen the abdominal section because abdominal muscles are less likely to be impacted by activity compared to like appendicular muscles such as biceps or triceps. And the reason we've chosen the psoas muscle is because it's a well-defined muscle in the abdomen. So the method we used was we looked at the psoas muscle and measured the maximum axial thickness. So looking at the psoas muscle, we just measured the maximum diameter anterior to posterior, and that's the axial thickness. And then we measure the maximum transverse thickness, so the perpendicular diameter to the axial thickness. So those were that's the method we use in this study. And the aim of this was to determine if using this method to measure psoas muscle thickness on CT scan can predict mortality in patients with alcoholic liver disease. And this is a single center case control study of patients admitted to a regional liver unit between 2012 and 2013, and who had CT scans within 6 months of admission. And we measure the axial and transverse thickness. And for our outcome measure, we check their status at four years post-admission. So were they alive or dead? And we compare their thickness using various statistical methods. So we have 54 patients included, and 26 of them were alive and 28 were dead. And comparing the psoas muscle thickness in both, there was no statistical significant difference between the dead and alive group in terms of the transverse thickness. And also for the axial thickness as well, there was no statistically significant difference between both groups. So this study is limited as its limitation. So firstly, it's a retrospective study. So we had a lot of missing data, for example, the patient's height, because of course we should be looking at the psoas muscle thickness relative to height. And also we had a small sample size and we used a soft tissue landmark. So we used at the level of the umbilicus to measure the psoas muscle, and patients with ascites will of course have different sites for their umbilicus. So based on this study, we suggested that psoas muscle thickness on CT scan is not a reliable prognostic tool for to predict mortality in patients with alcoholic liver disease. And thank you very much.
Okay, if there are
Thank you.
Okay. So if there are no questions from the scientific panel, Dr. Temidayo, can you start your next presentation at 10:58 and keep control of the presentation?
All right. Oh, sorry. All right. So I would also like to present another study where we investigated the prognostic utility of various blood parameters in predicting postoperative complications after lumbar fusion. So spinal conditions have become very common due to the aging population, and lumbar fusion is a commonly performed procedure in this in spinal surgery, especially for degenerative spine diseases. It's been shown to give significant functional outcomes, but it also comes with a risk of complications which can increase mortality and morbidity. So it's very important that we have an effective but cheap risk stratification tool that will enable us to identify high-risk patients that need closer monitoring postoperatively, as this would aid early recognition of treatments and complications and treatment of complications to decrease the risk of morbidity and mortality. So commonly used assessment tools such as Charlson Comorbidity Index and American Society of Anesthesiology grading. They've been shown not to be completely predictive of complications in spine surgery, and also sometimes that could be subjective as well. However, various blood markers such as neutrophil lymphocyte ratio has been used in various fields such as cardiac surgery, cancer, and stroke medicine to predict outcomes. So as a result, the aim of this study was to investigate whether routine laboratory biomarkers collected preoperatively can predict the development of complications after lumbar fusion. So we conducted a single center case control study of consecutive adult patients that had lumbar fusion from 2012 to 2019 in a regional neurosurgical center. And the variables we considered were demographic and surgical variables such as age, sex, smoking status, as well as various preoperative blood such as full blood count, white cell count, and also biochemical parameters such as sodium, creatinine, and albumin. And for the sake of this presentation, I would like to define what we mean by lymphocyte percentage. So it's lymphocyte count divided by white cell count times 100, while neutrophil lymphocyte ratio is neutrophil count divided by lymphocyte count. So our outcome measure was, did this patient develop any postoperative complication after 30 days after surgery? And the complications that we considered were determined a priori by looking at literature. And this patient were grouped into complication versus no complication. And for our statistical analysis, we use receiver operating characteristics and binary logistic regression. So we found out that 11 out of 88 patients had complications, and the most common complications were surgical site infection and pneumonia, occurring in 4 patients. And following our region receiver operating characteristic analysis, we found out that patients that have lymphocyte percentage that are less than equal to 29.5%, we had greater risk of complications, while those with NLR of greater than or equal to 2.32, we had greater risk of complications. And from looking at the AUC area under the curve, you can see that the lymphocyte percentage is a better predictor of complications than NLR, and it was statistically significant as well. None of the other variables that we considered showed any statistical significance. And using the cutoff from our regional, from our receiver operating characteristics, so NLR greater than or equal to 2.32 and lymphocytes less than or equal to 29.5%, we found out that patients with raised NLR were 5 times greater odds of developing complications compared to other patients, and patients with low lymphocyte percentage were at about 12 times greater odds of complications compared to other patients. So based on this, our results, we concluded that similar to previous studies, raised NLR or decreased lymphocyte percentage are associated with worse outcomes, and also that patients with raised NLR or decreased lymphocyte percentage should be closely monitored as a high-risk group susceptible to postoperative complications after lumbar fusion. And we looked into literature to find out possible theories regarding why NLR and lymphocyte percentage predict outcomes. So raised NLR is a marker of subclinical inflammation, while reduced lymphocyte percentage is a marker of prolonged compensatory anti-inflammatory response. So it means this patient before surgery, their immune system might have been exhausted because of the high amount of inflammation, and then you do surgery with further decreases, which causes further immunosuppression. So this patient become at more risk of complications. The other theory is that this patient, they already before surgery, their immune system is pre-activated, and the cytokines released during surgical operation cause more damage, and the immune system, the systematic inflammation response is higher in this patient. Thank you very much. These are the references.
Okay, thank you so much, Dr. Temde. Can the next, are there any questions from the audience or from the scientific panel? Okay, if there are no questions, then Dr. Saad Mungal, are you with us, or Dr. Andreas Christo?
Hello, can you hear me?
Once you're ready, can you please start at 11:05?
Yeah, sure.
Thank you.
Hello, everyone. Can you hear me?
Yes, we can. Yes, we can.
Hi. So yeah, so my name's Saad. I'm currently in FY3. I did this research project with my colleague, Dr. Andreas Christo. So the title of our talk is A Virtual Teaching Series to Improve Knowledge and Exposure to Neurosurgical Pathology at a NHS Teaching Hospital, which was a DGH. So I've got nothing to disclose for this research project. Okay, so junior doctors in foundation training, because the foundation training has a broad curriculum, they often have limited exposure to, more specialized surgical fields such as neurosurgery. And to compound the problem further, many medical school rotations in these more specialized areas are very short. So exposure to common neurosurgical conditions is often limited and may constrain confidence in this area. So we thought that virtual training programs, which can be, have the advantage of being accessed anywhere, not necessarily if you're at a major trauma center, can improve confidence and understanding of these more specialized areas, which we think has implications for career planning. In terms of our methodology, so we developed an online neurosurgical teaching program following discussion with senior neurosurgery registrars, and we did this in part to increase the internal validity of the study. So we focused on the common areas that a junior in neurosurgery would be expected to understand, such as traumatic brain injury, assessment of a clinically unwell patient in neurosurgery, common neurosurgical emergencies, some of the more niche areas as well, such as endovascular stroke treatment, which is now up and coming. 31 foundation trainees participated, both FY1s and FY2s, and we developed a 5-point Likert scale questionnaires, which we distributed pre and post the actual training program. The reason why we think this is of relevance as well to anybody who's not necessarily interested in neurosurgery is that take TBI, for example, traumatic brain injury. It's one of the leading causes of death, I think, if not the leading cause of death in young adults in this country, and approximately 1,500 patients attend emergency department every year with head injury, so it's completely relevant. So in terms of our results, so baseline characteristics, we had, as I said, 31 participants, twice as many males participated, and we had a roughly equal split between FY1s and FY2s. And as you expect, most of the participants were interested in a surgical specialty. So in terms of results, as you can see in all topics apart from the GCS, we saw significant improvements in the proportion of participants assessing themselves as being confident or fairly confident. And I suppose the reason why we didn't see any significant changes in the GCS is because that's commonly incorporated in any sort of algorithm that's used in assessing any unwell patient. Again, this is just a pictogram demonstrating the changes in confidence levels. So yellow and green is what you want to be looking for, and that's what we saw in the majority of people post this program. So one of the limitations of our study is that it was a single center study. We only 31 people participated, so we have a small sample size there. And again, we use a Likert scale for this qualitative study, which we assumed the data was going to be interval. So in terms of the conclusions, well, the main things to take away from this small study is that a virtually delivered teaching program in specialist areas like neurosurgery is feasible, and it's also effective. Secondly, programs like this could be a viable approach to addressing the relative scarcity of some of these more niche areas that are missing from broad training programs. I mean, if you take the example of neurosurgery, in the foundation program, there's 4 to 7 roughly tracks every year. So some people who may be interested in those more niche areas may be disadvantaged because of the higher competition. So there's also implications for career planning by developing this to supplement taster weeks as well. The final thing I'd like to say is that because we've demonstrated its feasibility in this pilot study, we can extend this to other specialties as well.
Sorry, so
Thank
if
you.
you ain't got any questions, we're running out of time, I'm afraid.
Thank you.
It seems like we don't have any more questions. Dr. Tenistan, can you please start at 11:12? Thank you.
Yep. Okay, no problem.
Thank you.
Okay, so it's 11:12. Good morning, everyone. My name is Denise. I'm currently an F1. Thank you for the opportunity to be able to present the project. This pediatric urology project was performed on the use of mirabegron in overactive bladder and its role in the exit strategy after Botox treatment in children. So just a brief overview. Idiopathic overactive bladder is a common lower urinary tract dysfunction in children, and it is usually characterized by the presence of urinary urgency, accompanied by daytime urinary wetting, nocturia, and or nocturnal enuresis. And the symptoms can be also associated with neuropathic bladder. So mirabegron works by basically acting on the smooth muscles of the bladder, which causes relaxation, and as a result, increase the bladder capacity without changing much micturition pressure or any voiding contraction or post-void residual. Mirabegron is a recent addition to the management option of the overactive bladder, especially in children. So there's not much limited research on it. When the overactive bladder symptoms are refractory to anticholinergics, usually that's how we start them on. And then Botox usually would be the next available option before commencing on mirabegron. While Botox is a very well-recognized therapeutic option, there is no clear pathway as to what will happen after it wears off. So moving on, this retrospective study was just to ascertain the mirabegron role in the treatment algorithm of therapy-resistant overactive bladder and to evaluate its efficacy and side effects. So what we did was we collected case notes of children receiving mirabegron between the dates mentioned as above, and we collected the data, and the efficacy was assessed based on the clinical response in the clinic letters. All patients that were given mirabegron were given a baseline test including full blood count, liver and renal function test, blood pressure check, and the ECG testing as well. And also a routine blood pressure monitoring was done 1 to 4 weeks after commencing mirabegron treatment. Next. So the results showed that we gathered 41 children, 21 males, 20 males between the age of 8 to 17 years old, with a mean age of 12 years old. 35 of the children had idiopathic OAB, and 6 of the children had neuropathic OAB, and the duration of treatment was about 20 months. Most of them were started on a 25 milligram dose and then after increased to a 50 milligram mirabegron dose. So moving on to the results, we did see that on combination therapy, 34% patients had complete response, 37% patients had partial response, 29% patients had no response. There were 6 children on monotherapy and 2 of them had complete response, while the other 4 had partial response. Overall, 76% had complete or partial response to mirabegron treatment. 41% children had mirabegron as an exit strategy for return of symptoms following weaning off of the Botox effect. These 17 children had Botox therapy for resistant OAB, and 7 having more than 1 Botox session, with an average of about 2 Botox sessions before commencing on the mirabegron treatment. Of the 17 children, 15 of them had complete or partial response, and 2 had no response. The mean duration between their last Botox therapy and the assessment of mirabegron success was about 44 months, excluding any residue effect from any Botox treatment. So moving on to discussion. In our study, we found that we preferred combination therapy of mirabegron as compared to monotherapy, and 85% of our patients were started on combination therapy. About 71% of the children were on combination therapy, and 6 of the children monotherapy had complete or partial response. So we found in our experience, while the minority had a long-term resolution with Botox, in a majority, there's still recurrent symptoms when Botox wears off. So anticholinergic or mirabegron combination therapy is an important rescue therapy after Botox therapy. And mirabegron is a well-tolerated drug. However, there are side effects, including headaches, nausea, dizziness, abdominal pain, and high blood pressure. Our study did have some limitations. The description of the clinical records can be a bit subjective in terms of interpretation, especially of partial and no response, and our study was a relatively small size. But in conclusion, we did found that mirabegron improved LTD symptoms in 76% of the patients with refractory overactive bladder symptoms. It is effective and safe, and we use it in combination with anticholinergic as the next step in treatment escalation after no or partial response to anticholinergics. So we did highlight the role of mirabegron therapy in the exit strategy after Botox wears off. Thank you.
Okay, if there are any questions, we'll take them now. Okay, seems like there are no further questions. Please use the chat box if you have any questions and continue to engage with each other. Okay, Dr. Al-Khazali, are you with us? If you are, can you take control and start at 11:19, please? 11:19.
Okay, thank you. Okay, so hi everyone. My name is Pedram. I'm one of the Astroza Kings. I'm going to present a rare case of acute appendicitis in degarangio hernia. So, as a background, it was first prescribed by the French surgeon in 1731, and basically is the person's degarangio hernia is a presence of appendix in the femoral hernia. Rarely, they can be inflamed, and even rarer, they can present in male patients. So up until now, only 14 cases has been published in male patients, and 8 in the last decade. Moving on to the case, so we had an elderly gentleman who presented with 2 days history of increasing pain and increasing the size of a long-standing right inguinal hernia. There was no any other like GIT symptoms or obstructive symptoms, and on examination there was just a tender irreducible lump in the right groin area, and there was no extension to the scrotum. So bloods were unremarkable apart from slightly raised CRP. So obviously we had to do imaging, and CT scan was the best choice. And it showed a narrow neck right inguinal hernia with fluid-filled appendix. We can see here the axial and the coronal views. There was also streakiness of fat, and there was also some fluid in the right inguinal canal, which these appearances suggested strangulated right inguinal hernia. So obviously he went to theater, and he had an open periperitoneal groin exploration. So we found that he had an incarcerated right femoral hernia with gangrenous appendix within the sac, within the hernia sac. So the appendix and the sacs were reduced to the abdominal cavity. A mesh was put in, and then he had a diagnostic laparoscopy with with appendectomy, basically. Post-op, he stayed for 2 days just for IV antibiotics. There were no complications, and he was discharged with no follow-up. As for the discussion of this case, the presence of inflamed appendix within the digapharyngeal hernia is very rare and mostly occurs in elderly women, and the mean age is 71. Clinical examination is not very sensitive method to diagnose this presentation. A CT can prove very helpful in digapharyngeal hernia, and it can show incarcerated groin hernia. Regarding the surgical approach, there is no consensus up until now. Yes, in elective cases, laparoscopy is preferred, but in these cases, previously published approaches were like open, different kinds of open repair, inguinal, lower abdominal, and McKeevely, and also laparoscopic approach. Basically, obviously the laparoscopic approach has some advantages, and you can visualize the extent of the involvement in the intra-abdominal, in the intraperitoneal organ. Sorry. So take-home messages. This is a classical presentation of our case. Clinical examination cannot only alone cannot diagnose the case. It should be suspected where the imaging confirms a tubular structure within the hernia, and CT is very sensitive and specific. There is no consensus, as I said, there's no consensus regarding the approach, but laparoscopy can be very helpful and useful. And yeah, thank you very much. Any questions? Hello?
I think there are no questions. Sorry,
yeah,
that the slide. Please make sure you don't end the slides.
Sorry.
Yes, for all the oral presenters, please make sure.
I apologize for that. Yeah.
So, Dr. Yao, if you're with us, we will start once we get to the correct slide. So, please.
Yeah, that's fine.
Okay, so Dr. Yao, if you start at 11:25, please.
Yeah, okay. Okay, good morning, everyone. Thank you for this opportunity to present our study on radical nephrectomy with caval thrombectomy for renal cell carcinoma. My name is Lou, and I'll be co-presenting with Pedram. And now I'll hand you over to him.
Perfect. So the incidence of renal cell carcinoma accounts for around 2% of cancer and death globally. Local disease can be managed with active surveillance, nephrectomy, percutaneous ablative therapies, chemotherapy, and immunotherapy. Now, in up to 15% of RCCs, the tumor extends to the inferior vena cava, and in these cases, surgical excision is required for curative outcomes. So here at University Hospital Plymouth NHS Trust, we are reflecting on our 10-year experience of performing radical nephrectomies with IVC thrombectomy for these cohort of patients. The aim of our study was to review the long-term outcomes of radical nephrectomy and IVC thrombectomy in a single tertiary center, and this was over the last 10 years. This retrospective study was carried out from 2009 to 2019. Pre-operative, intraoperative, and post-operative information was collected using medical notes, investigation results, discharge summaries, clinic letters, as well as GP records.
Okay, so there were a total of 9 patients were reviewed, of which 6 were male and 3 were female. The median age was 70 years, ranging from 47 to 75 years old. All had renal cell carcinoma with IVC extension, with one extending into the right atrium. At the time of surgery, 4 patients had nodal or metastatic disease, of which 1 was to the aortocaval nodes and 3 was to the pulmonary nodes.
Could you try again?
Apologies. Only 1 patient underwent surgery with cardiopulmonary bypass due to cardiovascular instability. And post-operatively, 1 patient had adjuvant chemotherapy and 5 patients had chemotherapy for subsequent recurrent disease. The mean duration of surgery was 224 minutes and the mean hospital stay was 6.5 days. Significant complications were encountered for 1 patient who had cardiopulmonary bypass, which resulted in death 18 days after surgery. He required intraoperative internal cardiac massage, and post-operatively suffered significant bleeding from the IVC, coagulopathy, mesenteric ischemia, and liver ischemia. Minor complications without mortality were encountered in 2 other patients, including bleeding and post-operative ileus, both which were managed conservatively. Looking at long-term outcomes, those who had metastatic disease at the time of surgery were associated with poor outcomes. 2 survived 16 months, but 1 survived through 3 years and 7 months, and 1 is still alive and yet to be followed up. Of the 8 patients who survived to discharge, 5 had recurrent cancer, and of these 5 patients, 1 recurred after 7 years. The survival rate in our cohort was 16 months to 18 years, with a 75% 2-year survival rate and a 63% 3-year survival rate. Excluding the 3 patients who have not yet reached their 5-year follow-up since the operation in 2017, the 5-year survival rate is 20%. However, if the remaining 3 patients are still alive by 2022, the 5-year survival rate may be up to 50%. And interestingly, the patient who had atrial extension had the longest survival duration so far, 8 years. So in conclusion, although it may be fitting to assume that high tumour burden associated with worse prognosis, our study suggests against this. The literature suggests that the 5-year survival rate for level 4 tumour is worse than level 1 tumour, but no significant differences between level 1 to 3 or compared between supra and infra diaphragmatically. And radical nephrectomy and cable thrombectomy without cardiopulmonary bypass are shown to be the safe option, as the need for bypass was found to increase perioperative risk. And lastly, current literature reports a 5-year survival rate of 32 to 64%, and our results will be comparable to this if the 3 remaining patients are still alive by 2022. Thank you all for listening, and these are references, so we'll take any questions now. Thank you.
Great. Seems like there are no questions. Once again, if anyone from the audience wants to ask any questions at any point, please type into the chat box and continue interacting with each other through the MS Teams chat box. I'd like to just quickly remind you that the poster hall is interactive, so please bear that in mind. This will be displayed at lunchtime. So I will now progress on to the next slide, and Dr. Fladder is next. Dr. Fladder, if you're with us, would you mind please starting your presentation at 11:33? This gives us a few minutes to stretch our legs, so please, if the audience wants to quickly stretch their legs, and we will be starting at 11:33 by Dr. Fladder.
Great, thank you.
Please make sure to take control, Dr. Flather.
Okay.
Dr. Flather, it seems like you haven't taken control for the presentation yet.
Okay. I think that's me taking control. Is that correct? Okay, so I'll start.
Yes.
So hello, my name is Robert Flather, and today I'm doing my talk on different techniques for technical impression in Down syndrome, and this was performed as meta-analysis. So acute tunnel syndrome occurs when the ulnar nerve is pain and sensory disturbance in the sensory distribution of the ulnar nerve, which is digits 4 and 5 on both the volar and dorsum of the hand. But it can also cause muscle weakness in the nerves of both the forearm supplied by the ulnar nerve as well as the intrinsic muscles of the hand. And this leaves us with a characteristic ulnar claw deformity of the hand. And now cubital tunnel syndrome actually affects 6% of the population and is the second most common compressive peripheral neuropathy after carpal tunnel syndrome. And we know that surgery is the mainstay of treatment for cubital tunnel syndrome, and this can largely be split into two categories. The first of which being in situ operations, whereby the ulnar nerve is left in its original position behind the medial epicondyle. Or here on the right, as you can see, we can do something called a transposition. And this is usually an anterior transposition, whereby the nerve is brought anteriorly in front of the medial epicondyle that you can see here. And then there are different derivatives of each of these. These can be done as open operations. This would be an open in situ decompression. Or we can even do minimally invasive or endoscopic operations. And we perform approximately 15,000 of these ulnar nerve decompressions each year. However, approximately 30% of patients don't actually improve post-operatively, and 3% actually experience serious complications. So there's a real need to establish which operation or which operative technique is the best. And actually, in the past 10 years, there's been 15 different meta-analyses that have all used conventional pairwise methods, as you can see here, whereby Operation A is pitted against Operation B, as it were. And whilst they've been able to determine which out of A or B would be the best, there hasn't been any studies that have been able to delineate which operative technique has the best outcomes out of the entire group and the fewest complications. And so the overall result of this is there's been a persistent variation in practice with different surgeons performing whichever operative technique they felt would be best. So we decided to take a bit of a different approach, and we performed a network meta-analysis whereby we were able to use direct data from the studies that were incorporated, as well as indirect data from the statistical analysis. And this enables us to analyze all of the different operative techniques in one single analysis, which allows us to rank them in terms of their outcomes against each other. And that's exactly what we did. So we found 30 studies with 8 different operative techniques and 2,894 limbs. And what you're looking at here is a network diagram, which is a graphical depiction of the structure of the network analysis, whereby we have our nodes here in blue. So here we have open in situ decompression. And here we have subcutaneous transposition, and those are the two most commonly performed operative techniques. And in red here, we've got the different analyses between them. So our primary objective was symptomatic cure, or response to treatment, as we were calling it. But we also looked at secondary objectives to do with complication rates, symptom reoccurrence, and rates of reoperation required as well. So looking at our results here, this can look a bit daunting initially, but down the middle, we can see all of our different operative techniques. And at the top left here, we have the operative technique that performed best in terms of our outcome. And at the bottom right, with the lowest P-score, is the operative technique that performed the poorest. And above all of our operative techniques here, we've got the direct data. And beneath it, we have the indirect data. So we're just concerned with the direct data, the indirect data. So we're going to just focus on that. And actually, if we look at the two most commonly performed operations, which is our open in situ decompression and our subcutaneous transposition, we can see that if you were to offer an open in situ decompression, the response to treatment for your patient would have improved. And had you then offered an epicondylectomy, whereby remove the medial epicondyle on top of that, the outcomes improved again. And as well as that, we found that open in situ decompression, as well as up here, you can see it had the best response to treatment compared to any of our transposition operations. It also had the fewest complication rates, the least chance of reoperation, and the least reoccurrence of patient symptoms. So overall, the results are very clear that open in situ decompression, with or without medial epicondylectomy, has the best outcomes for your patients and with the fewest complications compared to any form of anterior transposition operation. And this has huge implications going forward, as it can help inform our surgical practice moving forward, so we can improve the outcomes for patients with cubital tunnel syndrome. So thanks very much for listening. If you have any questions, I'd be happy to take them now. And if you want to learn a bit more about our study, it's actually been published in JAMA Network Open. And if you scan the QR code here, it will take you to the study so you can learn a little bit more about it. So if you have any questions, I'll be happy to take them now. Thank you very much.
So Rob, can you hear me? All right.
Yes, I can hear you.
Yes.
Hi.
Hi, I'm Mr. Panahi. So very good presentation and very nice data. So is, in your experience, open in situ decompression the most commonly performed procedure?
So actually, subcutaneous transposition makes up approximately, I think it was in our study, we found that it made up 39% of the operations, whereas open in situ decompression currently makes up only 22%.
Okay, and is that going to change your practice now?
Sorry?
Is this these outcomes that you showed today going to change the practice?
So it's hoped that although we haven't been able to assess the current change of practice because the study is so new, it has received funding from the NIHR and Health Education England, a significant grant to be able to take the research forward to assess whether there has been change to practice, and to also distribute the information further, or the data further, so that we can start to shift practice and inform our colleagues to try and improve outcomes. Because without good reason, we really should be doing an open in situ decompression with or without medial epicondylectomy, unless there is a good reason otherwise, because the evidence was so clear.
Okay, thanks.
Thank you so much. So our next presenters are Dr. Diaz and Dr. Combs. When you're ready, could you please start your presentation? Dr. Diaz or Dr. Combs, are you with us?
Sorry. Hello, can you hear us?
Yes, we can hear you. If you can take over control of the slides and please start your presentation.
Perfect, thank you. Good morning, I'm Emily Combs and I'm here with my colleague Melanie Diaz. We're F1s at Hillingdon Hospital and presenting our audit on the right consultant for the right patient. We noticed that a significant proportion of inpatients in Hillingdon Hospital have the incorrect name consultant allocated during their admission on the IT systems. We will go on in this presentation to explain why this is a problem, but would like to draw your attention to the Francis report, which clearly states that every patient should have a named clinician and nurse. In Hillingdon Hospital, the consultant in charge is allocated as you can see on the right. Switchboard manually inputs rota data onto their system and sends this to A&E reception and the surgical assessment unit. It's then up to the secretaries to enter this information onto another system called PASS, and this system integrates with the other computer systems, so we have EatPro for discharges and ICE for results and requests. Unfortunately, not everyone can make changes on PASS, so this means only certain members of staff can access or update information on there. We collected data relating to the surgical inpatients on 6 occasions and set up a number of interventions between data collection points. We also involved a trauma and orthopedics specialist nurse who highlighted that her department faced similar issues, including a male patient incorrectly allocated to a gynae consultant. The first of these interventions was to meet with key players from Switchboard and A&E to improve the existing process. We put up posters in surgical offices, as you can see on this slide, which we felt highlighted the issue and also allowed us to explain what the doctors could do to help, for example, writing on the front of CAS cards. We made reminders for ward clerks and engaged them in the process whilst encouraging all members of staff to alert them to any errors. We ensured all new starters had information in their welcome packs when they started their surgical rotations. To ensure these interventions weren't just a tick box exercise with additional paperwork, we considered how to make them easily implemented and sustainable, ensuring buy-in from all the key players so that there was a willingness to improve. Our hope was that interventions would then be translatable to other specialties, have a lasting impact and result in real improvements which we can monitor through re-audits and reviews.
Okay, so moving on to look at the results. So one way data was collected was with a questionnaire given to a range of administrative and clinical staff. As you can see, this asked if the staff were aware of the problems and also how they felt it affected their practice and patient safety. Every single respondent encountered problems daily, with 2/3 of respondents encountering this issue several times a day, and everyone agreed that this had serious impacts on patient care. Other data we collected was to look through all the inpatients under surgery, including breast surgery, urology, and the 2 colorectal teams. We noted if the patient was under the correct consultant or incorrect consultant, but we also noted whether the patients were under the correct team or a completely incorrect team. Some patients were under entirely different specialties, whilst others had the wrong named consultant, but these patients were at least under the correct team. When developing our interventions, we also factored in whether consultant had switched on-call weeks or passed patients between themselves, or if their admission had no obvious error-inducing points. As you can see at the bottom, 45% of surgical inpatients had the right consultant allocated on initial data collection, and then at our 6th data collection point, 77% of patients were correctly allocated. We appreciate there is still definitely more room to improve, and we will continue re-auditing. Moving on to our conclusions, putting together all of our data, we proposed and implemented changes to the original pathway that we discussed in the earlier slide. So firstly, this means encouraging each department to update the consultant list weekly, and for switchboards test call, which they put out every day, to include confirming the consultant on call. Updating the CAS card should now be considered a part of clerking, and the ward clerk will use this to input the consultant information onto PAS. We also have ensured safety nets in this way to make sure patients have the correct consultant, including on discharge. Before we take questions, we just wanted to emphasise exactly why this is so important. We truly believe this will help improve patient safety. For example, making sure we avoid situations where patients are missed from ward rounds, especially when being moved around different wards. And this was especially frequent in COVID times. This also means that nurses are able to find the right team and escalate their concerns. And this not only means the patient can be reviewed sooner, but it means that as juniors, we don't get so many bleeps where all we can offer is a, no, sorry, the patient isn't under my team, try another bleep. There are also important ramifications on discharge if investigations aren't properly chased, or if there is a query from a GP or even a complaint from a patient. So we really hope this study will help keep patients safe and make the admin part of our job as junior doctors a little easier. Thank you very much for listening to our presentation.
Am I allowed to ask one question, Dr. Dash?
Yes, of course.
Yes, hi, Mr. Karri here, hi. So very good presentation again, and nice data in a way to show that you've improved your allocation of consultant from 50% to 77%. But you didn't quite reach the top level, if you like. And have you looked at the reason why it didn't reach any more than 77%?
Yeah.
Now, are you working on how to improve on that?
Yes. Yes, we are. So because during COVID there was a lot of patients being moved around, and some of the surgical wards were being taken over by medical patients, and there was a lot of confusion. I appreciate COVID hopefully won't last forever, so we do hope that the things that we've implemented, such as ensuring that during clerking, patients are making sure the cascade is filled in with the correct consultant and making sure people give the right information to switchboard. We're hoping these things will continue on, and when things become a bit more settled and we have our surgical wards back, we will hopefully get more than 77% of patients being allocated to the right consultant.
Thank you, Dr. Combs and Dr. Diaz. If there are questions,
one question.
Yes, please go ahead.
All right, so that was a good presentation. I just wanted to find out how responsive was Switchboard regarding your study and them not being able to allocate patients properly to consultants. Were they actively working with you on this, and are they keen to solve the problem?
To be honest, initially it was a bit difficult, but I think with a lot of prompting, and we kind of gave them a lot of positive feedback as well, because they get quite a few calls from people not knowing who the patients are under, and having to be transferred to all these different teams such as breast surgery, urology. So we kind of put it to them that it will help them as well if we get this sorted out, but also we can then translate it to different specialties, especially medicine, where this happens quite often. So they became very responsive once we explained the implications of our study.
Okay, thank you very much. Have the trust considered changing the entire system from top down, since Switchboard usually has a generic rota?
Yes, so the difficulty is PASS, because not everyone has access to PASS. So we were trying to make sure that lots of people have access to PASS, including clinicians, because we are the ones who usually clerk in patients, and we know when the consultants have swapped in terms of rota and things. So I think that was one of the ways that we went to the trust to help us. But yeah, no, we appreciate this is quite something that should come from the very top.
Thank you so much, Dr. Combs. I'm going to need to stop the presentation there. There are two questions for you on the chat. If you can please answer them on the chat box, and we will progress on to the next presentation. Thank you. Dr. Kyung-Jeon, when you're with us, can you please take control of the presentation, and your 5 minutes will start from when you're ready.
Yeah, I can start now. Hello, everyone. Thank you very much for this opportunity to present my case study. My name is Faith Jen. I'm a clinical research fellow working at the Royal Free at the moment. I'm here to present a patient who had a surgical correction of microstomia over a 12-year period. So microstomia, this is the narrowing of the oral aperture, and this has several causes as demonstrated here. I want to focus on systemic sclerosis, which is a complex rheumatological disease that causes widespread fibrosis of the skin and internal organs. When this involves the perioral region, this causes microstomia. So this is our patient. She presented to us at the plastic surgery department at the age of 42 years old. She had a history of limited cutaneous systemic sclerosis and a background of stable pulmonary fibrosis. She had severe orofacial fibrosis involving the perioral region. This restricted her mouth opening and mastication that had a direct impact on her nutritional status. She also couldn't close her mouth fully, so she was drooling. She had problems with dry mouth. And in particular, she had this lower lip retraction causing exposure of the lower teeth and gums. In these patients, the functional, aesthetic, and social impact of this has a great significant impact on their everyday, day-to-day living. And patients have reported, interestingly, that this is more concerning to them than the life-threatening complications that develop from their disease. So why so serious? The problem is that there is no current treatment options for these patients. They're told that although this is progressive and it worsens with time, that there's nothing that we can do. There are surgical options that can be explored. However, these are really reserved for those with severe functional restrictions and is not appropriate in our patients, as we will see. In the literature, some non-operative techniques have been described for microstomia, some specialized exercise programs to stretch the perioral tissues, or some splinting techniques have been described. However, the perceived benefits are short-lived, and due to poor patient compliance, they have high rates of relapse. Surgical techniques to increase mouth opening include commissuroplasties. These aim to increase the horizontal length of the mouth aperture and are usually combined with local techniques to reconstruct the oral lining, such as mucosal flaps or skin grafts. However, again, the problem with this is the high rates of relapse. Despite the strict postoperative splinting that they go through, they are prone to undergoing multiple surgeries. They end up with extensive and discernible scarring. And also in our patients with systemic sclerosis, this is not appropriate as they have undergoing and continuous fibrotic progression of the disease, which further compounds the rates of relapse. So our approach in this patient was used on the basis of autologous fat grafting. This is a established and minimally invasive plastic surgical procedure that is now being recognized to exert antifibrotic effects, which is potentially mediated by the adipose stem cells that are contained within the fat grafts. So fat is harvested from the abdomen or thighs using a blunt cannula. It is spun down in theatre using a centrifuge, and then the fatty portion of it is injected to the upper and lower lips, and also the nasolabial folds and cheek and chin as required. So this procedure was performed multiple times in our patient, either simultaneously or between other surgical procedures, as you can see here. She had a previous full thickness skin graft of her lower lip, so she underwent some scar releases. She had some other techniques to resuspend her lower lip and help in lower lip closure. So this is our patient at the end of the 12-year reconstructive journey. You can see the patient here at rest and with active mouth closure, and she's fully able to achieve oral competence. Even at rest, her lip ptosis is much better, and the patient reported increase in mouth opening. We measured it to be approximately 5 millimeters improved, and also she had better dental access for all procedures and better mastication. So autologous fat grafting is essentially a novel treatment method for patients with systemic sclerosis developing microstomia. Thank you very much for listening.
Thank you so much for that. If there are no further questions, then we can go on to the next presenter, who is Dr. Youssef. Dr. Youssef, if you're with us, can you please take control and start when you're ready? Your 5 minutes will start
then. What time should I start?
You can start whenever you're ready, please.
Okay. Hello, my name is Sofyan Youssef, and welcome to a presentation on the predictors of pneumothorax in mechanically ventilated COVID-19 patients. So I have no conflicts of interest or financial declarations. So the key points from this project are that chest X-ray severity scoring can predict incidence of pneumothorax in invasive mechanically ventilated COVID-19 patients. Ventilator parameters, tidal volumes, positive end expiratory pressures, peak airway pressures do not appear to be associated. Pneumothorax is associated with prolonged ICU stay, but it is not significantly associated with mortality. So pneumothorax is a rapidly emerging complication in invasive mechanically ventilated COVID-19 patients, and there's a quoted incidence of around 15 to 24%, but the data on it is very sparse at the moment. There's poor quality evidence around level 2 and below, implicating an increased risk of mortality. But there's significant paucity, as mentioned, regarding the etiology and prognosis of the disease. So we conducted a retrospective cohort study. We included all consecutive invasive mechanically ventilated COVID-19 patients admitted to ICU between March 2020 and January 2021. We looked at a validated COVID-19 chest X-ray severity score developed and validated by Reeves and colleagues, and ventilator parameters and demographics. Our primary endpoint was pneumothorax, and secondary endpoints were length of ICU stay and mortality. We used univariable binomial logistic regression for the relationship between the variables in pneumothorax, and a one-way ANOVA test for the relationship between pneumothorax and length of ICU stay. So a bit about the scoring system. So each lung was divided into 2 zones, and that would give a total of 4 zones for both lungs. And each zone was scored based on the proportion of zonal opacification and density of opacification from 0 to 3. And then the scores were totaled for the 4 zones to form a maximum score of 24. And then we split them up into 3, mild, moderate, and severe. So in pneumothorax patients, the most recent chest X-ray prior to diagnosis was scored. And in other patients, the first chest X-ray at ICU admission was scored. And this was done by consensus-based scoring by the intensive care registrar and consultant intensivist. So this is an example of the chest X-ray severity score. So we split it into 4 zones. And the right lower zone, proportionally wise of the opacification is 1/3 of the zone. And the same in the left lower zone. And then in terms of density, if there's no opacification, it's a 0. If there's mild opacification not obliterating the bronchovascular markings, it's a 1. If it is obliterating the bronchovascular markings, it's a 2. And if it's a complete whiteout, it's a 3. So in this case, both lower zones are 1 out of 3. This gives a total score of 4, which is a mild severity. So we included around 32 patients over that around 9-month period or 10-month period or so. 9 developed pneumothorax and 5 unfortunately died. Chest X-ray severity was predictive of pneumothorax, but there was quite a wide 95% confidence interval. The mean length of ICU stay was significantly longer in pneumothorax patients, and we found no other significant differences. So the limitations of our study, it was a small sample size, only 32 patients. The chest X-rays may have been scored at different points of disease progression. They were scored by non-specialist radiologists. And this was done at a small district general hospital without access to extracorporeal membranous oxygenation, which is usually a treatment that's used in these patients. So the learning points, chest X-ray severity scoring systems, these tools are valuable in characterizing the risk of developing pneumothorax. The ARDS network recommendations must be adhered to strictly, and these are recommendations for the ideal tidal volumes to reduce the risk of barotrauma. And more research is definitely needed on this topic. Thank you very much. Any questions?
Okay, it seems like there's no questions. There's a question on Microsoft Teams. It says, good contemporary audit, Sophie. And did you get a chance to compare pneumothorax and COVID patients versus non-COVID ventilated patients in terms of prognosis? Basically, of course, in COVID patients, or is it the same or equivocal?
So we haven't in this study, but previous literature has compared the prognosis, and it is worse in COVID patients compared to non-COVID patients.
Okay, thank you so much. Again, please keep interacting with each other on Microsoft Teams. Now, the next presentation is by Dr. Donnelly. Dr. Donnelly, are you with us? If you are, can you please take control and start when you're ready, please?
Hi, can you all hear me?
Yes, we can. Thank you.
Okay, great. So I'm good to start now?
Yes, please start when you're ready. Thanks.
Okay, thanks. Hi, everyone. My name's Liam. I'm one of the junior doctors in London. I'm going to be talking through a presentation, a project I did whilst intercalating at Leeds University. entitled Traumatic Anterior Shoulder Instability and its Surgical Management. So the shoulder joint or glenohumeral joint is the most mobile and most frequently dislocated joint in the human body and particularly affects young active males. 96% of all dislocations are due to trauma and 97% of all dislocations are anterior. Unfortunately, traumatic anterior shoulder instability is often recurrent, with figures ranging widely from 17 to 100% in patients managed conservatively, i.e. without surgery, and long-term effects such as osteoarthritis, chronic pain, and quality of life deficits as well are common. The predominant injuries seen in traumatic anterior shoulder instability are Bankart lesions. Bankart lesions describe the detachment of the anterior inferior portion of the labrum from the glenoid fossa, and they typically occur when a player lands on an outstretched arm, which is then on impact with the ground forced into excessive extension, abduction, and external rotation. This causes the humeral head to move anteriorly in an excessive manner and causes the Bankart lesion. In terms of my project, my aim was to study the anatomical stabilizers of the glenohumeral joint, and I had the great opportunity of using teal cadavers to do so. I then conducted a literature review to investigate the surgical management for Bankart lesions. So in terms of anatomical stabilizers, this sort of involves a complex interplay between both static and dynamic stabilizers, with static being the predominant stabilizing structures. Static stabilizers include the capsule, the glenohumeral ligaments, and the glenoid labrum. This photo is taken from an anterolateral point of view of the teal cadaver and displays some of these structures. The glenoid labrum itself is a fibrocartilaginous ring surrounding the glenoid fossa and is made up of a confluence of the capsular attachments and glenohumeral ligaments. In the photo, you can see the direct fibers from the SGHL, or superior glenohumeral ligament, joining onto the labrum. The labrum itself is about 5 to 9 millimeters deep and confers about sort of 50% of the total depth of the glenoid fossa, thereby increasing contact surface area and enhancing the concavity compression effect produced by contraction of the rotator cuff muscles. The capsule itself is very thin and has distinct thickenings known as glenohumeral ligaments, which are normally lax during the mid-range of motion, but then tighten and act as check reins towards the end ranges of motion. They sort of act reciprocally to each other, tightening and loosening depending on what position the arm is in. And it's these structures that are damaged in a Bankart lesion, particularly the inferior aspect of the glenoid labrum and the inferior glenohumeral ligament. In terms of dynamic stabilizers, the rotator cuff is a major contributor to glenohumeral joint stability, and the role of the long-headed biceps is much less clearly defined, although studies have shown that the long-headed biceps actually hypertrophies in cases like Bankart lesions, and it's thought to compensate for the deficits in stabilization. This photo illustrates quite nicely the long-headed biceps, both the intra-articular, the IA, and the extra-articular EA portions of the biceps brachitendon, traveling through the transverse humeral ligament and then joining or inserting onto the supraglenoid tubercle marked with a star. Surgical management yields low recurrent rates compared to conservative management in recurrent traumatic anterior shoulder instability, and traditionally open repair was seen as the gold standard treatment, with studies consistently reporting low rates of recurrence. However, arthroscopic techniques were introduced with the aim to confer some advantages, such as less invasive, superior functionality post-op, and faster rehab and return to play, etc. However, in the beginning, the recurrence rates following arthroscopic repairs were significantly higher than open repairs. Since then, however, lots of developments have occurred in arthroscopic techniques, and particularly the use of the suture anchors has now resulted in equal or similar outcomes to open repairs in regards to recurrent instability. And on top of that, arthroscopic techniques have shown to offer really good functional outcomes. So to conclude, despite all the stabilizing structures, the glenohumeral joint is inherently unstable, particularly affects young adults, and recurrence is an important problem. Surgery is better than conservative management, and arthroscopic techniques are now the most commonly performed repairs for Bankart lesions. However, high recurrence rates are still posing a problem postoperatively. Thank you.
Thank you so much. If there are any questions, then please continue engaging with each other. So we will progress on to the next presentation, which is by Dr. Susan Honeyman. Dr. Susan Honeyman, are you with us? Can you please take control and start whenever you're ready? Well, actually, if you start at 12:08, that would be fantastic.
Okay, thank you very much.
Thank you.
So thank you very much for having me. I'm Susan Honeyman. I'm a foundation doctor working in Oxford. I'd like to present this literature review and meta-analysis, which looked at endoscopic third ventriculostomy with choroplexus cauterization in comparison to shunting for pediatric hydrocephalus. So hydrocephalus is among the most common presenting pathologies in pediatric neurosurgery, affecting around 1 in 1,000 infants. And ventricular peritoneal shunt placement is the most well-established treatment. However, it's associated with significant risks of complications, including shunt malfunction and infection. And this poses challenges, particularly in low-resource settings, where children might have to travel hundreds of miles to reach their nearest neurosurgical centre for emergent care. Therefore, the optimal management really remains controversial. Endoscopic third ventriculostomy, ETV, is a procedure which involves creating a small incision in the thin membrane floor of the third ventricle, creating a CSF diversion route. And this procedure has gained attention as a potential alternative method of managing hydrocephalus, and it avoids the mechanical failure and device infection seen with shunting. This procedure has been shown to be less successful than VP shunting, however. The addition of choroid plexus cauterization, CPC, to the ETV procedure has been reported to improve procedure efficacy. There have so far been no large-scale multi-center studies comparing ETV and CPC with VP shunting, and no prior pooled analyses of current evidence. Therefore, the aim of this study is to systematically review the literature to identify studies comparing the relative success and complications between these two procedures. We carried out a systematic search of PubMed, Embase, and Medline between January 1980 and July 2020, and we identified studies which compared the outcomes from ETV and CPC in comparison to VP shunting as the primary operation for the treatment of hydrocephalus in pediatric patients. This slide illustrates our paper selection process. So following deduplication and screening of titles and full texts, we identified 8 papers, which included over 1,200 patients. The primary outcome we examined was procedure success, which was defined by no requirement for reoperation at 12 months. And our secondary outcomes were post-operative complications, including infection, CSF leak, CSF collection, wound adherence, bleeding, and hematoma formation. The results of our meta-analysis showed that there was no significant difference in treatment success at 12 months between these two procedures. However, there was a significant reduction in overall complication rates with the ETV and CPC group. Narrowing in further to look at infection rates particularly, there was a significant reduction in infection with ETV and CPC. So our review suggests that ETV and CPC is a safe and equally efficacious alternative to VP shunting, with lower rates of complications and in particular infection. In terms of strengths and limitations of our study, the strengths are this is the first review of its kind, and it included populations from across 4 continents, which should mean that our data is generalizable to the global population. In terms of limitations, there was a variable extent of CPC achieved between studies, and studies have shown that the extent of CPC is strongly correlated with procedure success, with the best outcomes achieved when you cauterize greater than 90% of the choroplexus, and this was only reached in 1 study included in our review. So we might be underestimating the true benefit of the ETV and CPC procedure. We were also unable to stratify outcomes by patient age and hydrocephalus etiology based on the original data of included studies. In terms of future directions, early results are promising, but assessment of the true effectiveness of this procedure will require large-scale multi-center RCTs comparing these two procedure techniques. These should also stratify by age, hydrocephalus etiology, and strictly document the extent of CPC achieved. And I think I also wanted to reflect on if reoperation requirement is really the best index of procedure success in these patients. And my team think that we would also recommend looking at cranial metrics in these patients, their motor and cognitive outcomes, because that might provide a better insight into which procedure affords the most benefit to these patients. So I'm very happy to take any questions now if anyone has any.
Okay, thank you. It seems like there are no questions, so we will progress on to the next presentation. Thank you very much. Dr. Keshwani, if you would like to take control and begin your presentation whenever you're ready, please. Thank you.
Hello, hi, this is Dr. Baksh. I'll be presenting on behalf of our project we have done.
Thank you, Dr. Baksh. If you please start whenever you're ready. Thank you so much.
Lovely, thank you very much. So we have conducted a project during the times of COVID on the implications of COVID-19 on the surgical training in our hospital in Ashford and St. Peter's Hospital. So we all know that COVID-19 has affected everybody. There were changes in rotations, moving into the new trust departments. There were hampering in surgical skill acquisitions, as well as there were completely there was new guidelines every day, which just made everything haphazard. So the aim of our study was to infer if how COVID-19 and the redeployment impacted the surgical skills via a qualitative and a quantitative study combined. So we conducted a retrospective observational study which to compare the lead surgeons who were doing laparotomies as well as appendicectomies during the times of starting from the lockdown of March till July 31st in 2009, comparing with 2020 and 2019. Also, we conducted a subjective survey to elicit any perspectives on skills and academic advancements and trust and delivery support which the trainees have received. We have conducted a focus group discussion between 4 registrars as well to get an insight on their physical and the psychological well-being. So the results showed that the emergency laparotomies which were done comparing 2020 and 2019, which clearly showed that there were less number of patients during the times of COVID, of a total of 50 patients compared with only 75 patients in 2019. And it can be easily seen that the number of consultants is a bit lower, but the number of consultant registrars doing the operation is almost the same. And obviously laparotomy is a big procedure, so it's hardly expected that a core trainee would be supervising, leading the surgery on its own. But the most striking results we've seen is during emergency appendicectomies. So there was a clear drop in number of patients as well in 2020 and 2019. But the striking difference is before COVID, there were a number of core trainings who were the lead surgeon doing the appendicectomies. But in 2020 in COVID, it was almost, there were no core trainings, which is a clear drop in the emergency appendicectomies. And the number of registrars is almost the same conducting the surgeries. So also a link out questionnaire was sent all out to the trainees, and 57.1% agreed that the COVID-19 extremely affected the surgical training. 42.9% agreed that they suffered some form of mental exhaustion due to the training and COVID-19. 42.9% felt less confident in progressing of training in the upcoming years, and 28.1% agreed that they had a reduction in almost like 81 to 100% of operative logbook entries compared to pre-COVID times. We also conducted, as we discussed amongst 4 surgical registrars, and had a group discussion and tried to find out anything. And the highlights that outcome were there's decreased surgical logbook numbers due to loss of elective operating opportunities and increased inclination towards conservative management. Heightened mental strain during running emergency surgical services due to reduced staff, as the juniors were redeployed to help out with the COVID rota. So in conclusion, this study shows that throughout the initial surge of the COVID-19, there has been unprecedented change in healthcare services across the world. Although results were not significant difference in the number of cases managed by the surgical registrars, junior core trainees suffered decreased training of operating theatre numbers. Many surgical trainees reported perceived loss of training, logbooks, and portfolio, or less teaching or training opportunities and mental exhaustion during the period of COVID. And those are my references. Thank you very much. If there are any questions.
Okay, if there are no further questions, can you please progress on to your next presentation and start whenever you're ready. Thank you.
Thank you very much. So this is my another project which we conducted, management of acute appendicitis during the first wave of COVID-19 in our hospital in Ashford and St. Peter's Hospital. So during the first wave of COVID pandemic, surgeons were advised to apply non-operative management or open surgery for acute appendicitis because they were thinking that laparoscopic would be an aerosol generating procedure and which would increase the chances of COVID throughout members of staff, patient, and everybody. So this is a single NHS center study to explore the resultant management differences. We conducted a retrospective observation study. We took 3 months of COVID times and 3 months before pre-COVID 2019. So the number of appendicitis patients in this period of 3 months, there was a drop of, there were 35 patients which were managed in the COVID times and 43 patients were managed in 2019. This is the mean age difference. It was seen that there were younger patients presenting during the times of COVID. We found out that the mean length of stay was a bit longer, of around 2.2 days during the times of COVID compared to the pre-COVID times. There was a increased inclination towards imaging techniques to come to a diagnosis for acute appendicitis, which showed that 85.7% of the patients had either CT scan or ultrasound to come to a diagnosis of appendicitis rather than relying on clinical judgment only. This is the different types of management he used in terms of percentage, showing there was no very less laparoscopic procedures during the times of COVID and more operative procedures during the times of COVID. And we can see there is some conversions done during the times of COVID, which later presented. So this is the patients who were managed conservatively. A follow-up was done of around 6 months and was seen that during the times of COVID, 8 of the patients were managed conservatively, completely by IV antibiotics and were sent home, out of which 3 of them did have to come back for an emergency operation later on. And pre-COVID time, there was only 4 patients managed conservatively, either due to age or either due to inoperability at that stage in time, and out of which 2 of them did come back for operation at a later date. In conclusion, there was a tendency towards applying conservative approach or open approach during the times of pandemic. Though this was statistically significant, the total number of patients was small enough to achieve a statistically stronger conclusion. The mean length of stay was statistically not significant between the 2 groups. Laparoscopy was selectively used during the early phase of pandemic, where the benefit outweighed the risk. Neither significant morbidity or mortality was reported in both the groups, apart from 1 patient who did contract COVID after his operation. Limitations. Further data is needed to find if patient presented with delayed presentation in the first presentation during the time of COVID, and is there any relation to that and later on having increased conversions? Those are the references. Thank you very much. If there are any more questions.
Okay, thank you so much. So if there are any questions from the scientific panel, then we can invite them now. If there isn't any, then we can progress on to the next presentation. Okay, thank you so much.
Sorry, Pedram, just one question.
Yes, please.
Yeah, thank you for your presentation. It had a good look at and compared times before and during COVID. I did not quite get from your presentation in particular why there were more conversions to open. Was this because it was the first wave and the risk of aerosolization if a patient was COVID positive was identified, and that's why more patients had open surgery in the cohort of patients that you presented? Was that looked into?
This is what I've mentioned in my limitations. So the initial presentation, how they were suffering in the period and then only presented, we haven't looked into that. So that's a limitation. So I think that is could be one of the reasons why patients came a bit later and ultimately needed a better complex procedure to be done.
Okay. Okay, thank you.
Okay, thank you so much to everyone. So we have had a fantastic set of presentations this morning. I've thoroughly enjoyed the morning so far, and I hope you guys have enjoyed this as well. So for our next presentation, Professor Balasubramanian will be giving us a talk on research. He is an expert in the field of research and working and has set up CramSurge. And Professor Balasubramanian, if you're with us and you're ready, please could you take control of the slides, and we look forward to your presentation.
Okay, thank you. Thanks, Sanjid. Can you hear me?
Yes, we can hear you.
And can you see my slides?
Yes, we can see your slides.
Okay. Right. Hello, everyone. I'm sorry I couldn't join you for the whole day, but I kept coming and going. So it looks like a really good conference, lots of interesting abstracts. So Sanjid's asked me to talk to you for about 25 minutes, half an hour about research. So as you would expect, it's a really broad topic, critical appraisal and research. We could do 2 or 3 day courses and still not cover most of it, but we're going to give it a shot. I'll try and go through a set of about 25-30 slides and see if you can leave some time for questions. So if you want to interrupt me, Sanjid, 5 minutes towards the end of the talk, and if I still have got plenty more slides, then I'll whiz through them, and then we'll have some time for questions. Yeah?
Yes, perfect. Thank you.
Okay, right. So we're going to talk about what critical appraisal is, why this is important, a few general principles of appraisal. We'll then go through the structure of appraisal if you're going to do a critique of a paper in a journal club in your hospital, and I hope at least some of you are involved in critiquing papers in a regular fashion in the hospital where you work, and the kind of questions that you could be asked while you're appraising a paper, or questions that you could ask of the paper to increase your understanding. We'll then talk about research classifications, a very brief overview of classification of research and types of clinical research and designs, and then a short introduction to hypothesis testing, some basic concepts around it, and then we'll take some questions. Right. So what is appraisal? What is critical appraisal of scientific literature? Here's a definition from Wikipedia. I'll give you a few seconds to go through this. So quite a complex definition. Yeah, so another way of looking at it is to look at it as a systematic assessment of a report in terms of its research question, methodology, and results. Yeah. In very simple words, I would say that the objective of your appraisal or scrutiny is to answer some questions which boils down to what is this paper about? What's the research question? What's the background? And what knowledge gap is this paper trying to address? The next question would be, so what? So what are the implications of these results? How does it affect me and my patients? The next question would be how. So how have they come to the conclusions that they have come to? And how have they got the results that they are reporting? And then finally, what next? So you've got a set of results, you've made some inferences. Now, are you satisfied? Does this fully answer the clinical question or research question you've raised? Do you need more research? And if so, what kind of research? Or are you going to say, right, from now on, I'm going to change my practice, and this is how I'll change my practice? Now, the entire process essentially involves the assessment of validity. There are two types of validity. You've probably heard of these phrases. The first is internal validity, wherein you ask the question, are the results accurate and free of bias? And the other is external validity. So a study might have been done really up to very high standards, and you've done all you can to avoid bias creeping into the study. But then, is the methodology reproducible? Can somebody else come along and do what you've done and get similar results? And also, are these results generalizable to the average patient, to the average practice, to the average surgeon? Or is it something very special and specific about the study having been done by a super expert surgeon in an ivory tower of excellence that you simply cannot reproduce or generalize? Okay, so it's important to remember these two phrases, internal validity and external validity, when you're critiquing a paper. So you might say, well, I'm a super specialist surgical trainee involved in, I don't know, facial reconstructions. I'm not really bothered about appraisal. How does it matter to me? So as you would expect, I would say that you need to be up to date with what you're doing, and you need to understand the basis of clinical decision making. So appraisal is important for all surgeons, regardless of what, how much super specialist you might be. It's also useful to be able to communicate the results of research, not just to patients, but to your own colleagues and to educate your juniors. And if at all you wanted to get involved with research, and it might be very simple research, it might be just a small audit in your hospital, you need to understand some basic aspects of appraisal, because you're going to be, your work is going to be critiqued. Now, you may or may not have come across this paper by John Ioannidis. He's a professor of medicine at Stanford University, and he is an expert in appraisal and methodology, and is a huge critique of the way academic medicine works in the current time. And he published this paper in PLOS Medicine, and this is, I think, by far the most downloaded paper scientific paper on the internet. It might be worthwhile, if you're interested, in downloading this and reading this paper and understanding the basis of his claim that most published research findings are false. And if you go through this paper, there are a few take-home messages that I'll just put in one slide, but it's quite a complex paper, and he's made some dramatic claims, but has backed that up with complex statistical calculations and epidemiological theory. But let's just see what he says, and it's useful to keep this in mind. So his statements or corollaries are that research findings are less likely to be true in studies that are small number studies, which kind of makes sense. But for each of these statements, he shows the evidence behind it. They're less likely to be true in studies with small effect sizes. What does that mean? Small effect size means if you're comparing treatment A and treatment B in the treatment of a specific cancer, if the new treatment B improves survival by maybe 1%, so that's a small size, compared to say 10%, that's a slightly larger size. So the smaller the effect size, the more likely that the research findings are going to be false or spurious. The findings are less likely to be true in studies with large number of tested relationships. If a number of different variables are being compared all over the place, then you're more likely to come up with a significant finding that the authors might make a big deal of, and that might be a false relationship. If there's a lot of flexibility in designs, definitions, outcomes, and methods, just the amount of flexibility might end up with, might increase the chance of you getting a spurious result. If there's financial interest and prejudices, and if the area of debate is quite a hot area, a trendy area with lots of controversy. Right. The other thing to keep in mind is we need to know what to look for when you're critiquing a paper, right? So there's no point in me trying to critique a complicated neurosurgical sort of technique if I don't know anything about neurosurgery. So in addition to that, so the first thing is you need to have some understanding of the field. So from a practitioner or expert's point of view, you need to have the insight. And also, more importantly, I need to have insight from a methodologist perspective, from a perspective of somebody with some understanding of methodology and appraisal, right? So here's an example. So let's say you've got a 54-year-old lady with heart failure who developed lung cancer and received chemoradiotherapy. And 2 years down the line, a CT scan was done. And this lady's CT was shown to a group of radiologists. And this happened, this is true. And here is the CT scan. The radiologists were asked to comment on the findings in the CT scan, and they pointed to lots of different findings. I won't go into the detail. But I know this representation is not very typical. The scan is quite small, but if you see here, there's a little gorilla there, and the vast majority of radiologists, although the scan is quite clear and displayed on a massive screen, the vast majority of radiologists failed to pick up on the gorilla because that's not something they're looking for, right? So just to illustrate that unless you know what you're looking for, unless you understand some basics of appraisal and also have some insight into the domain, you're not going to be able to do a really good appraisal, yeah? Okay, so general principles. Most papers are written in accordance to the IMRAD structure. You've probably heard of this. There are a few journals that do not follow the structure, but the vast majority of surgical journals do. And the IMRAD structure stands for Introduction, Methods, Results, and Discussion. Okay, so I'm not going to dwell on this, but we'll go on to how do you critique the introduction, methods, results, and discussion in that order. One of the things that you need to get used to, and this will come with practice, the more journals, papers you criticize, the more journal clubs you partake in, the better you get at it, is to learn to summarize. So if somebody asks you to talk about a paper and that you critiqued, so you should be able to summarize the essence of the paper in just a few lines, and that'll come with practice. You start off introducing the title, the authors, the institution, and abstract. You then talk about the background. Essentially, what is the state of play in this particular area? What is the clinical question? Is this really relevant to the average surgeon in the field? What does literature say about it? And what are the aims and objectives? So usually you will find this in the background section. If it's not very clear, then that's not a very good introduction. You then move on to the study design, the method section, and describe the participants, the settings, interventions, and outcomes in the study, and this will apply to the most of the clinical research papers that you encounter. It doesn't matter if it's a randomized controlled trial or an observational study. You then look at the methods adopted by the authors to try and reduce bias, and bias comes in various forms and guises, and then you describe the statistical methods. A moment here to talk about what bias means. So essentially, bias is anything that will take you away from the truth. So it's different from error in that bias is systematic, something that's happened in the course of the study. It could be that you've selected patients that really don't fit the bill. It could be that some patients have had one treatment when not due to chance, but because of some other sort of underlying condition. Anything that will systematically affect the results of the study is what you refer to as bias, as opposed to error. Error is random, and error could be a typographical error, error could be a clerical mistake, so that's error, right? So there's a difference between bias and error. Right. After having done the introduction and the method, you move on to results. You focus on the baseline numbers. If two groups are being compared, you want to give the baseline numbers in the two groups. You want to talk about the outcomes in the two groups, and then you want to talk about any deviations that might be highlighted when you're reading the results that either has been explained or hasn't been explained. So the authors say this is what we set out to do, and they've done something else, and that's evidence in the results section, in the tables, in the figures. Then you talk about that. Finally, in the discussion section, essentially it's all about the implications of the results and what inferences the authors make of the results section, right? And a lot of the times, in most good papers, there will be a section on limitations, right? And authors would choose to highlight certain limitations that they can usually address really well, and they may not necessarily talk about limitations that you might pick on. You know, not all the limitations of the study may not be covered, right? So you've got to look into that. And then you've got to comment on your take on both internal validity and external validity, right? So like I said before, internal validity is relates to study design, how they've avoided bias, and how the limitations could have been addressed, whereas external validity refers to generalizability. What do the results of the study mean for your practice, for your patients, and for future research? Okay. So a few do's. So follow a systematic routine. It's very easy to just stick to the IMRAD. That's how most papers are described: introduction, methods, results, and discussion. Try and distinguish between issues that are methodological and issues that are clinical. If you're comparing laparoscopic versus robotic, I don't know, gastrectomy, for example, you might want to look into what kind of robot was used, or the technique of operation was employed, and whether the surgeons well trained, and that kind of stuff. And that'll be clinical or biological issues. You might also want to look at. Give me 1 second. Apologies. You might also want to look at methodological issues that relate to design and how the study was conducted. And for that, you need some knowledge of research methodology. Think of possible sources of bias, like we talked about, and try and distinguish between the views of the authors as described in the discussion and your own views. And then try and distinguish between what's important for internal validity and what's important for external validity. Okay. So a quick review of questions to expect. So you should be prepared to summarize a paper. I mean, that's often the first question that people ask when you're discussing a paper. They say, can you just set off and summarize the paper in a few minutes. And the other thing is, I find people struggle with in journal clubs is to make a stand, to take a stand and say whether a paper is good or bad, right? Every paper has got at least a few good points and a few bad points, but you should be able to take a stand on whether the paper overall is good or bad, and then explain the good and the bad from both a viewpoint of the domain expert and from a methodologist's viewpoint. A common question is, would you have done the research differently, and if so, how? And then people usually towards the end of the critique move on to, will the results influence your practice? And you've got to try and be ready with answers on whether it will influence your practice, how and why, and if it will not influence your practice, why not, and is there a need for more research, and what will you do differently? Okay, so those would be some of the questions to expect for any journal critique. And some people like a structure. If they're preparing, let's say, for critiquing a paper as part of your FRCS exam, you might want to read a paper and make notes in accordance to a pre-specified structure. So you could start to note down answers to these questions, titles, authors, institution, journal, a brief summary. You should be ready with a brief summary. Jot down the points from the paper and put them into little boxes so that you could focus on the domain and what are the good and bad points about the domain, about the subject area. You could then look at methodology and jot down the good and bad points about the methodology, and that way it'll help you, structure your discussion well. And then towards the end, make a note of the limitations, relevance and applicability to practice, that's external validity, and need for further research and how you do further research. I hope that was a useful, really quick overview of what appraisal is and the need for appraisal and how to go about doing it. Right, so we'll now move on to classification of research. So there are many, many ways in which you can classify research. I just highlight 2 or 3 ways. You might come across these phrases and these descriptions, so it might be useful to have some understanding. So people talk about basic and applied research, and this applies to research in any field. Basic research is essentially to advance knowledge, and when people say applied research, they effectively mean that you've got a practical problem that you want to address. And in terms of surgical research, you could classify this further into translational research and clinical research. Translational research could be research on cell lines, could be research on mouse models, in vivo mouse studies, in vitro mouse studies, and other laboratory studies where you're hoping to address a clinical problem by first studying it outside of humans. And clinical research essentially involves human participants, like you'd expect. You could classify research as qualitative and quantitative. Most research that you come across and most research that most surgeons do would be quantitative, but it's really important to know that qualitative research is an important role to play in almost any specialty you can think of. And this is research where you get or try to get an in-depth understanding of the issues that face various stakeholders. It could be patients, it could be clinicians, it could be juniors, nurses, and so on, where you try and understand people's preferences, values, attitudes around a specific problem. Okay, a lot of research that aims to do this becomes semi-quantitative in the form of surveys. Another way of classifying research is to split research into hypothesis generating and hypothesis testing. So there may be some research where you don't have a hypothesis. You start off asking a very general question because you want to learn more. So that would be hypothesis generating. Whereas hypothesis testing is you start off with a pre-specified statement or a hypothesis, and then you want to do a study to test this hypothesis. Now, let's take a few examples. Let's just talk about appendicitis, because I suspect that a lot of you would have dealt with patients with appendicitis. Now, if you want to know about the appendix and ask a very general question, what does the appendix do? And obviously that's basic research. Yeah, you don't specifically have a practical problem that you want to address, but you want to know more about this organ, right? If for the if as an example, you want to say do a large database study of hospital episodes in patients with appendicitis, this would be with a view to maybe improving outcomes or studying risk factors and so on. So that would be applied research, that would be clinical research because it involves patients with appendicitis. Clearly that would be quantitative, but it would be hypothesis generating because you've not specified a clear hypothesis, or you may not have a clear hypothesis, you just want to understand the disease, right? If, for example, you think that appendicectomy might be related to the future development of UC or ulcerative colitis, for example, you could come out with a statement to say appendicectomy reduces relapse rates in patients with ulcerative colitis. That is a statement or a hypothesis, so that would be hypothesis testing. To give you a little bit more understanding of what these specific research classifications mean. Right. Now let's move on to types of clinical research. Now I like to classify all clinical research into these two types, but there are many types that don't fit these two, not types, sorry, categories, right? So first is experimental or interventional, where you do something to change the natural history of a phenomenon. You have intervened, and then you want to look at the effects of the intervention. So that's interventional or experimental. The other kind of clinical research is observational, and you could be making observations on all sorts of things. It could be just clinical features, it could be laboratory tests, it could be lots of complicated molecular biology studies on blood samples and urine samples and what have you, but you're not doing anything to change the natural history, and therefore those would be observational studies, right? There is another group of studies which include secondary research, systematic reviews, meta-analysis, and so on and so forth, but we won't talk about this now. Right. Experimental research. Now let's just say that you've been doing appendicectomy for a few years, you've got a robot that you can use in the emergency, and you want to do robotic appendicectomy, and let's say you started doing it and you want to study the effects or the outcomes after robotic appendicectomy, and so you've got a single arm of patients without controls, and you describe the clinical outcomes of patients undergoing robotic appendicectomy in your hospital. So that will be a single arm study without controls. If you think hard about it, almost inevitably you will have some controls. It could be that you compare your results with those in the literature after lap appendicectomy or open appendicectomy, so you've got controls from the literature, or you could have controls from your own hospital which are historical, wherein you get the outcomes from patients undergoing open appendicectomy or lap some time ago. So that would be historical or non-concurrent controls. If you did then compare robotic versus laparoscopy, that would be a two-armed control trial. If you randomly allocated your patients and adopted the principles of randomized controlled trial, then you're doing an RCT. And there are some situations, and the robotic appendicectomy example doesn't apply here. For example, if you're looking at chronic pain, and the treatment of chronic pain would say acupuncture or some other medications, you could evaluate the patient before and after the intervention. So you are intervening, and that would be a before-after trial or a time series trial. There's not much surgical research that falls under this category. Okay. Research. Now, in observational research, in a sense, what you're doing is you're looking for relationships between variables. And I tend to classify variables into two main categories. One is called the exposure variable, and the other is the endpoint variable. Now, almost any observational studies, you can look at the variables and classify them into exposure and endpoint. There'll be some observational studies where you're looking at risk factor versus occurrence of disease, let's say infection as a disease after laparotomy, and there could be lots of risk factors. So the risk factors would be the exposure, and the infection of the disease, the infectious disease could be your endpoint. There could be other kinds of observational studies where you have variables looking at the impact of various treatments. So all the treatments would be the exposure, and the outcomes of the treatment, which could be failure of treatment, recurrence of cancer, infection, death, and so on, would be the outcomes, and those would be the endpoints. Okay, so discuss appendicectomy and the development of ulcerative colitis as an example here. So the three main types of observational research, and we'll talk about them with this example in mind. The first is what we call as a case control study. So in a case control study, you typically start with the endpoint. And the endpoint here, in this example, is the occurrence of ulcerative colitis. So you have a group of patients with UC and a group of healthy people, and you look back to see if they've had appendicectomy. So you start at the endpoint and look for the exposure. That would be a case control study. As opposed to a cohort study, where you typically start with the exposure. So you could take 1,000 patients who've had appendicectomy in 5 hospitals in a region, then you follow them up over time. So in a cohort study, time is important. There should be longitudinal follow-up. And then you try and determine how many developed ulcerative colitis. And you could also do that in a healthy cohort that did not have appendicectomy. Okay. Another type of observational study is the cross-section study. Here you evaluate both the exposure and the endpoint together at a particular point in time. Okay. Other kinds of observational studies, but I wouldn't worry too much about them. They are unusual in surgical research. Right. The really important thing I want to emphasize, and I feel that a lot of people get this wrong, is the understanding of what a case control study is and what a cohort study is. So I'll emphasize these points again. So in a case control study, you start with an endpoint as opposed to starting with exposure in a cohort study. In a case control study, you look for exposure in people with and without the endpoint. And in the cohort study, you look for the endpoint to see if the endpoint occurs in those with and without the exposure. It's not important in a case control study. Doing a case control study is therefore easy and cheap. Whereas in a cohort study, there has to be a longitudinal element of time, and therefore the studies are difficult, time-consuming, and expensive. There is a significant risk of bias in a case control study. There's also sources of bias in a cohort study, but they're less so, and that's why cohort studies are considered to be higher in the hierarchy of evidence compared to case control studies. Finally, case control studies by nature are retrospective. You've already had the endpoints. Cohort studies can be either prospective or retrospective. Okay, so keep in mind, people tend to assume that cohort studies can only be prospective. That's not correct. Cohort studies can also be retrospective. Now, we don't have time to get into the details, but I can expand on this if there are questions later on. This slide shows certain specific modifications of case control studies that try and address the problems with case control studies. And again, I'm going to skip this slide for a lack of time. So if you have an example, so here's an example, and you're asked to determine what kind of study this is. So if you run through this example, they're looking at 100 newly diagnosed breast cancer patients, and they're looking at their dietary histories, and they recruit a number of healthy first-degree relatives to look at their dietary histories, and they're looking at amount of dietary fat consumption in the two groups, right? So clearly there's no intervention here, so I'm thinking this is observational. And then I'm looking to see that they've already had the breast cancer diagnosis, and then you're looking back to look at the exposure, which is dietary fat content. So that's the study starting with the endpoint. Okay, there is no time involved, and for this reason, this is an observational case control study. Okay, so hopefully this kind of reinforces the meaning of a case control study.
Sorry, Professor. Just wanted to let you know it's 5 minutes left. Sorry, just to let you know.
Lovely, great, that's okay. So I'm going to skip this example then, and then we'll go on quickly to hypothesis, because I think this is important. So a hypothesis is a specific idea, statement, or premise. It's different to a theory. Theory is proven, right? Hypothesis is unproven. And you can develop a hypothesis either from observations. It could be your own observations. You observe a particular pattern in your practice, or you could deduce or derive it from theory. So let's talk of an example. So if you say obesity increases infection rates following surgery, now you could base that on experience that obese patients have more infections. So that would be development of the hypothesis from observations, or you could theoretically derive this hypothesis by saying people who are obese have poor peripheral circulation, reduced vascularity, that impairs the ability of the body to deal with infections, and therefore I'm postulating that obesity increases infection rates. Okay? Hypothesis is central to the research. It should be clear, well-defined, and testable. But keep in mind that not every project needs a hypothesis. You could do good quality exploratory research without a hypothesis, as long as you have a clear, well-defined research question. Okay, so that's important to keep in mind. Not all research requires a hypothesis. How do you develop a hypothesis? Now, let's say that your question is what factors predispose to infection after some kind of surgery. So you develop, you search the literature maybe, or you collect data in your own hospital, and then you look at the data for patterns. And then if you demonstrate or you find that obese patients seem to get more infection, your hypothesis then is obesity increases infection rates. Then you do a study to test the hypothesis, and the data that you collect from the study is then subject to statistical testing to see if the hypothesis can be supported. Okay, sorry, I'm rushing here, but let's see if we can finish this. So, types of hypotheses. Like I've explained, hypotheses can be inductive, i.e. based on observation, or can be deductive, based on theory. Hypotheses can be non-directional or directional. I hope that's kind of self-explanatory. So a non-directional hypothesis could be obesity affects infection rate without specifying in what way, or a directional hypothesis can be obesity increases infection rate. Okay. Finally, and you'll come across this a lot, the null hypothesis or the alternative hypothesis. So we'll talk about that. So the null hypothesis essentially states what's generally accepted or what was known before some new knowledge came to light. It is what you wish to test your data against, and some people refer to it as the hypothesis of no effect, no association, or no difference. Yeah, so you've all heard of the null hypothesis. So you could say obesity does not influence infection rates. That would be your null hypothesis if you're doing a study looking at these variables. The alternative hypothesis is just the converse of the null hypothesis, and what you would have to accept if you reject the null hypothesis based on your data. Interestingly, usually the alternative hypothesis is a starting point for most of our randomized trials and interventional studies, and that's usually based on your research question. Okay. Now, if you do a study that tests this null hypothesis, and the study shows that obese patients have the same infection rates as non-obese patients, what should be your conclusion? Your conclusion shouldn't be that obesity does not influence infection rates. Your conclusion should be that you do not have enough data to reject the null hypothesis, okay? Because a null hypothesis can never be proven. It can only be rejected or accepted. So there are two types of errors in all clinical studies. And these are the type 1 and type 2 errors. You might have heard of this. So I will show you a 2x2 contingency table that compares the null hypothesis to the data that you found, or the study data. So using the same example of the null hypothesis between obesity and infection rates, focus on this particular cell. So the null hypothesis is true, and your study has rejected the null hypothesis. And this is a mistake, obviously, because the null hypothesis really is true. Then you've committed a type 1 error, right? If the null hypothesis is false, but you have not been able to see a difference, and you haven't shown a difference between infection rates in obese and non-obese people, then you've committed a type 2 error, right? So these are the two errors that we are prone to committing when we do a study and subject the data to statistical testing to test your hypothesis. The power of the study essentially is closely related to the type 2 error. So power of the study is 1 minus type 2 error, and you've got to keep in mind that these are both very closely dependent on sample size. So higher the sample size, higher the power, less is the tendency to a type 2 error. Okay. Keep in mind that you cannot design the perfect study without error. You will invariably be subject to either a type 1 or a type 2 error, regardless of what result you get. I'll discuss an example very quickly just to emphasize the type 1 and type 2 errors, and then null hypothesis. So let's say you're comparing open thyroidectomy versus robotic thyroidectomy in a trial, and you want to reduce complication rates, or you want to see if the complication rates are similar or not, and you find that the complication rates are 10% in open surgery and 5% in robotic surgery, and you've got a p-value, and we're not talking about p-values today, unfortunately, but you've got a p-value of 0.8, and the p-value of more than 0.05 is considered not significant. So how will you conclude the results of this trial if your null hypothesis is that robotic and open surgery have similar infection rates? Would you say that robotic is better than open surgery? Would you say that robotic is no better or no worse? Or would you say that there's no difference to suggest that robotic is different to open? So I hope you will agree with me that the first two statements are incorrect and shouldn't be made. All you can say is that there is no evidence to suggest that robotic is different to open. In other words, a null hypothesis, you can reject it, but you can never prove it. Okay, I think I'm going to skip this other example, and I'm going to summarize. So I appreciate we probably dashed through this, but we briefly talked about critical appraisal, what, why, and what the general principles are. We've talked about how you could structure your appraisal if you're taking part in a journal club, and that's something I would encourage all of you to do. Try and join a journal club in your hospital, or try and set one up if one doesn't exist. We've talked about research classification and research designs as it applies to clinical research. We've talked very briefly about hypothesis testing and some very basic concepts of type 1 and type 2 error, and null and alternative hypothesis. We, with some trainees in our region, Yorkshire and Humber, have set up an educational group called Cram Surge, and we run online journal clubs, and we do some presentations on appraisal, statistics, and methodology. So if you wanted to get involved, you're very welcome to join us. Thank you very much.
Thank you so much, Professor Balasubramanian. Thank you for that very interesting talk, and I can, you know, there are many golden nuggets there that I'm sure we can all appreciate. So thank you so much for your time and for the presentation. If anyone has any questions for Professor Balasubramanian, please type away into the chat box. If that's all, thank you so much, Professor Balasubramanian. I hope you enjoy the rest of your day. Essentially thank you very much. Thank you. That concludes our morning sessions, and we'll be moving on into lunch. What I'd like you guys to do, the attendees, just to pay attention to our poster hall, just to have a look through there. There are many amazing posters there. I want to thank all the oral presentations that happened this morning as well. They were really, really good and really well done to all of you guys. I'm going to pass it over to Pedram now, who will kind of detail what is going to happen over lunch and in the afternoon sessions. Pedram.
Thank you so much, Sanjid. I just want to echo what Sanjid has said. There were some excellent presentations and excellent talks. So thank you so much, everyone, for the fantastic morning. I have thoroughly enjoyed it. So as you can see, we are going into our lunch break now. And as Sanjid mentioned, please use this lunch break to interact with the poster and posters on the Medal poster hall. I'll post the link to this onto the MS Teams chat, which you should be able to use directly to go onto the Medal poster hall. So in the afternoon, we will start with sponsor presentations for the first half an hour and finish off with the afternoon oral presentations. So thank you so much. So we're just going to go on lunch break and we will be starting sharp at 2 o'clock. Okay, thank you so much. Hi guys, we will be starting shortly with the sponsor talks. So the first sponsor is past the MRCS. We'll just wait for the hour to turn into 2 o'clock and we can start. David, once it's your, could you please take control of the presentation? Thank you.
Great, so I should have control now. Can you hear me okay?
Yes, I can, thank you.
Perfect, I'll go on mute until you ask us to start.
Okay, so I'm happy for you guys to start whenever you're ready, please.
Perfect, and so hopefully everyone can hear me okay. Everyone's good, yeah?
Yes, yeah.
Excellent. So hi everyone, my name is David and it's great to be here with you today talking about PASSE MRCS. We're really happy to be supporting this conference and hope it's provided useful insights into your future in surgery. A key milestone in that journey is obtaining your MRCS Part B, and the big hurdle is the exam itself. At PASSE MRCS, we focus on giving you everything you need to be successful in the Part B. We've been around since 2012 and have built up a reputation of being the most useful, relevant, and concise preparation resource for the Part B. We've achieved this by putting together a team of incredibly talented surgeons who write OSCE scenarios that accurately reflect the required knowledge and approach to the Part B. This team offers coaching to our candidates so that they're well versed in the do's and don'ts before ever stepping foot into the exam room. We're also the only MRCS education provider that offers Acton's Anatomy for free, so that all of our members benefit from real videos of real human anatomic specimens in their natural color. And what this all translates to is results for our candidates. Since we started, we've helped surgeons around the world pass the MRCS. In the latest exam diet in May, we supported well over 200 candidates, and after the exam, we gathered feedback to see how we did. As you can see from the slide, 56 people responded to the survey, of which 55 of them passed. We got a real big thumbs up on overall satisfaction and value for money, and with all of them saying that they would recommend us to their friends. We also gather qualitative feedback, as we love to hear from our members. Lots of the feedback is positive, as you can see from the slide, but there are areas where it shows cases where we can improve. And I think that's what makes PASSE MRCS different to other MRCS education providers, as we really take this feedback on board, and the team work to continuously improve PASSE MRCS for future aspiring surgeons. And with that, I'll now pass over to some of those future surgeons who recently passed the exam to share their story. They were in your shoes a couple of months ago, and I think it'd be great to hear from them about what top tips they have for MRCS Part B success. Over to you, Ryan.
Thank you, David, and it's a real pleasure to be speaking on PASSE MRCS this afternoon. My experience has been a really positive one over the past few months while preparing for the exam, and I definitely would recommend it to you guys when your time comes around. My examination preparation involved a bit of self-directed learning as well as group learning, and I think that PASSE MRCS is fantastic in the way it provides a really nice structure to the topics that are important for preparing for the exam. The website has been user-friendly, comprehensive, targeted, and really detailed, and it provided some critical learning points that were crucial when it came around to passing the stations. I think the coaching sessions are brilliant, and they involved a really experienced member of their team who coached 2 or 3 of us on a Sunday morning when it was convenient to us. I personally found that tremendously helpful as it increased my confidence in the topic, and I also got to learn from my peers. I think 2 main tips that I'll give to you guys for preparing for the exam is to plan ahead and sort of use a past MRCS as a guide and structure to what is important, as we know that the curriculum is really vast. And having a structure and knowing how to prepare for it and what topics are common and what topics are important is really, really key. The other thing would be studying with friends and using past MRCS as a sort of guide. And what we did was we would test each other using the questions on past MRCS, and we'd all learn simultaneously. Thank you, David.
Excellent to hear. Thanks, Ryan. And Saga, we'd love to hear from you from an international point of view. You're a surgeon from India who just passed the exam in May.
Yeah, thank you for the opportunity, David. And Dr. Ryan has nearly covered all the positives of past the MRCS. But from an international perspective, I have no former UK experience working as a doctor in UK at all. And I was struggling with communication skills and clinical skills. Knowledge, of course, with revisions, I was able to manage, but I have no idea how to present the communication part during the exam. And I must say, the coaching sessions that I underwent with past the MRCS have been a key to my success in the exam. In fact, it boosted my confidence, and during the exam, I felt that I have done my communication station really well. Other than that, there was the opportunity to practice the mock examinations on the website, which I have done several times, and I was able to manage my time by utilizing the mock examination part in the past the MRCS website. Ackland's anatomy is brilliant, and the ability to choose your coach and choose your time, that kind of flexibility, I really cannot imagine how you guys pulled it, but kudos to you.
Great to hear that. And Sonia as well, you're joining us from an on-call shift right now. So thank you for taking time out of your day to share your story.
No worries. I would say, I completely agree with what Ryan and Saga said. Past the MRCS was such an amazing resource. I'm very, very happy. To be honest, it was incredibly recommended to me by quite a few of my friends. I would say at least 10 people, I would say, have utilized the resource at some point in the last couple of years. And so, great feedback. And so I could say that I can definitely attest to it. I had such a great experience of using the resources. Everything was incredibly approachable, such a good layout. And then to add to all of it, the coaching was amazing. So, I booked numerous sessions. Oftentimes you find it's actually quite hard to find the study group unless everybody's studying at the same time. And so the coaching sessions meant that you'd be with 2 to 3 people and just practicing, and you could pick up tips from each other. So I think the coaching sessions were amazing. And then the final big coaching session at the end, just before the examination, was really good as well, because we were able to actually, right at the very beginning, highlight which topic we wanted to go over. So whether it's communication skills, whether it's anatomy, you could target your needs accordingly. And so I felt that these were incredibly instrumental to me passing first time. So thank you so much. In terms of recommended things advice-wise, I'd say use a variety of resources. So Ackland's Anatomy alongside using other textbooks, etc. Try and keep it incredibly vast. Don't limit it to just one book alone. Ask, about for previous kind of station ideas. There's lots of resources out there. Talk to people, get a lot of feedback, talk to your bosses at work. And finally, I'd say that, because they're station styles, they're not really MCQs. Even if you're on a lunch break at work, just try and find even a little bit of time to go over one station. Or if you're at work, you're in a clinic, ask your boss if you can examine a patient. Try and utilize any kind of free time you have to be proactive. And I think that once it becomes more natural to you, then you're more likely to pass the exam. So practice is everything, and using a wide variety of resources.
Great to hear. And Craig, you were one of our candidates who did quite a lot of coaching. And if you could share 30 seconds on kind of your experience of coaching with us, that would be helpful as well.
So for me, I think there's 2 points of coaching. There's the one-to-one sessions that you can arrange, and then there's also like more group-based sessions. I think both are actually essential, really. the one-to-one sessions helps build your confidence first, and then doing group sessions in front of other people is sort of like a step up from the one-to-one sessions, and it starts priming you more for an exam setting. So it's a way in which you can get the nerves out of you before you start moving into an exam. Because I find even if you've got all the knowledge, actually then getting into an exam station with an examiner in front of you, or two examiners in certain stations, and then knowing the stuff but not being able to get the words out is probably the first or the second hurdle, really. The first hurdle is knowing the stuff. But after you can actually get the words out, then you can actually start scoring points. So moving from one-to-one sessions into group sessions, I found a really good way for me to learn and for me to do quite well in the exam. And I think that's probably the main thing I would take from it. Group sessions with your friends are good, but you're doing it with a friend. And if you're doing stuff with a friend, the fear's never quite there, and you need to get over the fear to be able to perform in the exam. So it's just ramping up the sort of level of difficulty before an exam setting, so you're most primed and you're basically game day ready.
Excellent. Thank you all for sharing your stories. I think we're at time now, but if we just flip to the next slide, just want to say from our end, everyone that's on that call, we're here for you when the time is right for your MRCS Part B. Please drop us an email. We've partnered with the Master Surgeon for quite a while now. We've got a discount code with the Master Surgeon, especially for this conference. It's 20% off TMS conference when you sign up. But in general, just reach out to us on contact@passthemrcs.co.uk if you have any questions around your MRCS Part B. We as a team are here to help you succeed first time. Thanks, everyone.
Thank you so much for that, David and team. So we are going to go on to our next sponsor of the conference, who are MDU. Now, MDU unfortunately couldn't be with us, so we have a pre-recorded presentation that we will work our way through. Okay, so we will just start shortly. Pushpa, can you please?
Yeah, I'll take control, and I've unmuted this.
Perfect.
Hello everyone, my name is Jake Williamson and I am the Liaison Manager at the Medical Defence Union. Sorry I can't be here in person today, however I thought I would record a little video and a PowerPoint just to give you an insight into the MDU and where you might need support. If you haven't signed up yet and would like to do so, then the QR code throughout the PowerPoint is a direct route to do this. Feel free to do this as I'm speaking. So, a bit about us. The MDU was established in 1885 as the world's first organisation to defend the reputation of doctors. We are a not-for-profit organisation and the market leader for medical defence. But this first organisation is us and all the other medical defence organisations combined. We're also a mutual organisation, meaning that we're owned by you, our members, and the only medical defence organisation must have a doctor as a effort, so that your patients are not at a disadvantage to make a claim about the clinical care that you've provided. Doctors need to be indemnified for claims at all times, including for work done in the past, whether working privately or within the NHS. Do I need a membership of an MDO if I'm employed by the NHS? Whilst clinical negligence claims for doctors working in the NHS will be covered by the NHS indemnity scheme, other areas of practice are not. This includes private work, writing medical reports, support and representation at coroner's inquests. Ultimately, the NHS indemnity is there to pay out the claims and not provide the other support required if clinical negligence does take place, as I'll go through a bit further on the next slide. A little bit about multiple jeopardy. Multiple jeopardy is when one single incident can lead to all sorts of different investigations and outcomes for doctors. If there's one thing I can say today to convince you to sign up for the MDU, it's this. The top one here in orange, this is your civil claims. This is what's covered by the NHS indemnity. The rest of them, they're covered by us. Taking a look at a death of a patient, for example, leading to a coroner's inquest where there's a concern about the standard of care. Doctors who are subject to an inquiry have an obligation to self-report to the GMC. So already this doctor is subject to an inquest and a GMC investigation. Then we could also have a civil claim made against you under the Fatal Accidents Act as they seek damages against you. In this case, could well make its way to the media and you could gain coverage about you that's unwanted attention, and this could also damage your reputation as a doctor. Members calling us for assistance before a trial, fitness to practice panels, and or coroner's inquests, and our medical legal advisors can support and help to prepare statements, as well as arrange legal representation when needed. A little bit about your membership then. I will quickly touch on your student membership, as this is free and you gain access to applying for sponsorship for academic events such as this one. Gain elective support from the platform known as 10. This is included in the UK ones this year, as well as free indemnity for your electives. As well as you'll also gain an access of information on our website and the MDU app, and much more. Your student membership ends on the first day of the month following your qualification, and it's important that you're indemnified when you start working. Can't stress this enough, this is a GMC requirement, so get it done as soon as possible. A good way to know if you are signed up for your FY1 or not is whether you have one of these 3 gifts on the screen: the foundation program, clinical student study cards, or pocket prescriber, as you will receive one as soon as you sign up. Your F1 membership is £10 and gives you access to indemnity, meaning you have expert advice through our medical. As mentioned, you will get one of these free gifts posted to you in the next few days, probably a week, as soon as you get signed up. And it's good to know that your payment doesn't come out until just before you start working as an F1. Gift. As of this week, we are working with 2 charities that help doctors and medical students with mental health concerns. They are the Doctor Support Network and the RMBF. The idea is to donate half of each F1 subscription we receive in 2021 to support the amazing work that they're doing in these super challenging times. For each £10 we get, £5 will go to them, split evenly. This applies again to both 2021 and 2022 graduates, so there's really no better time to get signed up and benefit these charities, and in turn benefit yourselves. But managing your membership, it's really important to note that as a member, it doesn't mean that you've necessarily made your online account. The QR code or the URL is just filling out your application form. Once you get this done, you need to register online, meaning that you can access member-only content, keep your membership details up to date, and download membership documents. This is me then. I am Jake Williamson, your liaison manager, as I said, for the Midlands. And if you need anything at all or have any questions, please don't hesitate to ask. You can again use this URL or the QR code to get your MDU membership up and running. And if you have any doubts, speak to people who are more senior, speak to lecturers and those that have been in the industry for a long time. They can really show you and tell you about the importance of having your indemnity and the support that the MDU can provide. Or again, alternatively, drop me a line and I can give you a bit more information rather than this 5-minute lowdown. Thank you again for having me, and it's always a pleasure to sponsor events such as this, and I will hopefully see you soon.
Okay. So much. There was some echoing there, guys. This was a pre-recorded message from the MDU, and unfortunately, there was a little bit of echoing for some attendees. But we will now progress on to our next sponsor of the event, which is Wesleyan. Do we have the Wesleyan members with us? I believe we have Christopher Hooper and Vera Sueli. So I will.
Yes, yes, I'm here.
Hi, perfect. So if you want to please take control of the slides, and once you reach the final slide, please do not end the slideshow. I will take control back.
Okay, yeah, that's fine. I think I've got it.
Thank you.
Okay, so ready to go now, I'm assuming.
Yes, perfect. Whenever you're ready.
Okay, great. Good afternoon, everybody. My name is Chris Hooper, and I'm a financial advisor from a company called the Wesleyan. I'm sure many of you have perhaps heard of the company. We may well have sort of met you in person, or potentially met you at university through our student liaison team. We're one of the sponsors today, and in short, because we've only got sort of 5 minutes, let me just go through, obviously, just a bit of a quick overview of what the Wesleyan are about. So if you weren't aware, I and the Wesleyans specialise in providing financial or tailored financial advice for NHS professionals, their friends and family. A bit about the company as a Wesleyan in terms of why potentially you would like to seek advice from us. Essentially, we've been here now for over 175 years, so we've got good history, good pedigree. We sort of really make sure that we're trying to stay ahead of our competitors by having things like an NHS advisory board. So I'm sure many of you may have heard of Professor Parveen Kumar. The likes of her and sort of other people at the top of their profession sit on a Wesleyan advisory board, just really to give us an insight in what's happening, because you may be aware that you receive lots of generic information, but there's no one really out there to tailor it to you as an individual. So that's what we do as financial advisors. We try and get out in front of you and obviously tailor that advice to you and your circumstances and your situation. We specialise, as I say, within your professions. So we have a very good understanding of how your career progression works, how your pay structure works, and any other sort of issues you may have with your contracts and your benefits within the NHS. Because from a point of view of obviously your core benefits, you all have 3 core benefits if you're working for the NHS, and that would be sick pay, that would be death in service, and then that would be your NHS pension. And a lot of what we do is around the NHS pension and advice around that, because once again, I don't know what stages you all are in your careers at the moment, but there have historically been a lot of changes with the NHS pension, and there are lots of changes going on at the moment. So what we do is we get out there and really sort of like try and tailor that to your own personal specific situation and let you know essentially the implications of the changes on your own situation moving forward. We do a lot with charity, so we have a Wesleyan Foundation, and we are a mutual, which is a really, really important thing from our perspective, which means that we're not sort of propped up as a company by shareholders. We are owned by the members that obviously have policies with us, and what that means is rather than having to share profits with shareholders, we can put that back into the organisation in the form of hopefully bonuses on investments and pensions and reducing premiums on insurance products. And that brings me on to potentially how we can help you and where we can help you. So down here, it's just a bit of an indication of where we provide financial advice. So some people, once again, might associate us with just protection. Some people might just associate us with pensions and NHS pensions, but it's we would class it as holistic advice. So any area of your financial planning that you may require any advice in, we can do that. The reason that we do that is that we recognise that different areas of your financial planning will come at different stages of your careers. From a junior doctor's point of view, I'm sure that the majority of you have a priority of obviously becoming doctors, and then obviously starting the progression in your career. But our job is to try and encourage you to start to think about your financial planning, because historically, the earlier you look to plan and the earlier you have an understanding of your planning, the better position you will be in the long run. So I'm imagining for the majority of you at the moment, it's perhaps building up savings with one eye on potentially buying a property in the near future, and we can essentially help you out with that. And also a real sort of key focus on making sure you're protecting yours and potentially your family's interests, which is especially important for potential doctors maybe looking to progress into surgery, because there's a subtle difference between many protection arrangements, which is own occupation versus any occupation. So for surgeons, that's really, really, really important, and something that you should be aware of, making sure that you're getting the right provisions in place. And if you do want me to sort of elaborate on that a bit more, please ask me at the end. Also, yeah, just from your point of view, a recent hot topic, if I can go back, is some of you may have heard of the McLeod judgment, or may have heard of some of your colleagues talking about the McLeod judgment. Essentially, that's one of the key changes within the NHS pension scheme at the moment. Something that you may all be aware of or may need to deal with moving forward, and that's something that we can help you with. So what essentially I would be saying, obviously we're really fortunate to be an active sponsor within this sort of event, and historically we've always done that. I can only do a very sort of like brief synopsis on what we provide as from the Wesleyan, but what we would be encouraging all of you to do is essentially contact either myself or the company to really try and perhaps see someone, because all our service is offered at no cost and no obligation in terms of your meetings. It's really about obviously getting a grasp of where you are and potentially help you out moving forward and making sure you're taking advantage of the opportunities available to you. So at this time, I would encourage all of you to hopefully book a meeting to see your local financial advisor to ask further questions. There's a QR code that you can do that to, and also I will, if you can't do the QR code, I should be able to put a link in the chat for you to be able to, let's see if this works. Yep, there you go. So there's a link in the chat as well that will allow you to click onto there and essentially book a no obligation review to discuss things with you. Have you heard of your total reward statement? That's something that I would encourage you all to gain access to moving forward, and have a very good understanding of your benefits, making sure that your deductions are correct from a tax point of view, making sure your deductions from a pension point of view are all correct on your pay slips, things like that. So I think that's pretty much me done. But if there are any questions or queries, I'll be here for the next sort of 3 or 4 minutes. Please obviously fire away in the chat, or speak out and ask any questions that you may have.
Okay, thank you so much for that, and that was great. Once again, thank you so much to all of our sponsors for kindly sponsoring this event, and we have a short break, just 5 minutes, and we will be resuming with the oral presentations at 2:30. So if you wanted to stretch your legs, then please do so, and we will be starting with Dr. Kim Lim, who will be our first oral presenter of the afternoon. Thank you. Hi, Kim. Can you please take control of the slides? And when you're ready, you have 5 minutes for your presentation. So please, whenever you're ready, please go ahead and start.
Brilliant. So good afternoon, everyone. I'm Kim. I'm a junior doctor here in the Northern Deanery. I'm here to present today about my project that I partook whilst I was on my elective in New Zealand, titled Keloid-Associated Lymphoid Tissues in Keloid Lesions Express Vitamin D Receptors. So a bit of background information before I begin. So there we go. All right. So we know that keloid lesion, it's a fibroproliferative condition characterized by excessive dermal collagen deposition in response to wounds. So this can be things like ear piercing, surgery, burns, inflammation. It causes pruritus, tenderness, and functional problems associated with joint contractures. And this can also lead to psychological complications due to cosmesis concerns and can impair quality of life for the affected individual. Current empirical treatments, things like corticosteroid injections or surgical excisions, remain unsatisfactory, with high recurrence rates of 45 to 100% following surgical excision. So the team over in New Zealand, we came across this idea for the study after we've encountered literature noting that there was increased prevalence and severity of keloid disorder in patients with hypertension compared to normotensive patients. In addition, there's the inverse relationship that we had noted in other literature stating that there was serum 25-hydroxyvitamin D and blood pressure had an inverse relationship. And individuals with keloid disorder are more likely to develop vitamin D deficiencies and hypertension. With this in mind, and a reminder about renin-angiotensin later down the line, I wanted to talk about the next thing, which is KALTs, which essentially stands for the keloid-associated lymphoid tissues. They are just aggregates of inflammatory cells, including lymphocytes, macrophages, and mast cells, okay? So in our old study, we previously identified stem cell-like population within the keloid tissues, and they express renin-angiotensin system or components of them and constituents of the bypass loops, cathepsins B, D, and G. So we wondered whether or not there was also expression of vitamin D receptors there. Okay, this is just the image of the KALTs that we've identified under the epidermis of keloid lesions. All right. This is just a proposed model that we have, but essentially it showcases the embryonic stem cell population and the microenvironmental niche, and it showcases or emphasizes how the renin-angiotensin system plays a central role in the immune system with vitamin D deficiency, the vitamin D receptors, and hypertension alone. Okay, so moving on to the aim and the methods. The aim of our study was to investigate the expression of VDR by the primitive population within the KALTs that express components of the RAS. The study included both histological and immunohistochemical staining. And what we did as well was use reverse transcriptase quantitative polymerase chain reaction just to elicit expression of VDR, okay? In terms of the results, this is what we came across. So, H&E staining of the keloid tissues, it showed architecture that we suspect of the KALT underneath the epidermis, like what was mentioned in the literature that started this study. The IHC staining demonstrated expression of VDR, which is on the image 4C, highlighted brown on the endothelium of the microvessels and the perivascular cells within the KALT in all 11 of our samples. If you look down the image on the left-hand corner, the immunofluorescent staining demonstrated abundant nuclear expression of the vitamin D receptors. On the endothelium of the microvessels, on both the nuclear and cytoplasmic expression of VDR. Okay. the last one was to show you the results that we've got from our PCR test. And it also did show presence of transcripts for VDR against the housekeeping gene in all the keloid samples examined. So this was a very preliminary study. It was done to sort of emphasize whether or not we could use pre-existing medication to treat it. And essentially, we did report expressions of VDR in crowds. And moving forward, we just need a larger sample size and functional work to sort of unravel the precise interaction between VDR, RAS, other compounds, and the immune system that forms the microenvironmental niche. And it's hoped that through modulating the RAS, using inhibitors of the RAS or the bypass loops or the convergent signaling pathways, that pre-existing drugs or targeted therapies can be found. Thank you very much. Yeah.
Thank you. So if any of the scientific panel have any questions, please.
Okay, one question.
Yeah. Yes.
Can I ask you a question?
Yes, yeah.
Vitamin D prevalence is so common in this part of the world, and we know that the keloid incidence and prevalence is much higher in African countries and also Asian subcontinent.
Yeah.
I'm just trying to understand what is the implication for different kind of races, because vitamin D deficiency is so common in Asian and African population, and at the same time the keloid incidence is also high. Do you think there must be some kind of correlation, and that's where actually you're probably going to concentrate in terms of once you've done the larger sample size work?
So from what I understand, I think that's a very good point highlighted, and this was one of the things that we've actually noticed. So primary source of vitamin D comes from sunlight exposure, with skin pigmentation being the key determinant in reduced UV light penetration. So that leads to decreased cutaneous synthesis of vitamin D3. I think if there was a slide that I had, if I could, essentially it showed the flow chart with how, in terms of vitamin D, there were convergent signaling pathways that were involved in IL-6 and IL-7. And that was what led to the proliferation of myofibroblasts and fibroblasts alone. And I think that was one interesting area for us to focus in moving forward. Yeah.
Thank you.
Thank you.
Okay, thank you so much, and thank you so much for the scientific panel questions. So we will just go on to the next presentation. Dr. Henry Mills, if you can please take control, and you can start whenever you're ready. Thank you.
Thank you very much. So yeah, my name's Henry, and I'm a first-year doctor in Kingston Hospital. I'm going to talk to you about a project I started as a medical student. It's the outcomes of distally unthreaded screw fixation of slipped capital femoral epiphysis at skeletal maturity, and it is a comparison with the standard treatment. Here is an X-ray of a severe slipped capital femoral epiphysis, or SCFE for short, on the right hip. And the main treatment of this is to pin the epiphysis in its place with a standard threaded screw. And the prognosis of this is it can lead to a residual cam deformity, which is highlighted with this orange arrow on this X-ray here. This can cause pain as it impinges on the acetabulum, decrease the range of movement, and lead to osteoarthritis in the long term. Recently, there's been more interest in unthreaded screws, which have the distal part of this screw filed smooth, and this crosses over the growth plate. These are designed to enable more growth after fixation, which is thought to lead to more remodeling and a better functional outcome, which may be more beneficial in the younger patients who have more growth and remodeling potential remaining. So I set out to compare these unthreaded screws with the standard screws for radiological growth and remodeling and long-term clinical and functional outcomes in these more skeletally immature patients. So I recruited all patients treated with the unthreaded screws who had reached skeletal maturity. I then went through and found patients treated with the standard screws matched for skeletal maturity, age, gender, and slip severity. And this identified 9 hips treated with the unthreaded screws and 21 treated with the standard screws. And of these, 11 patients attended our long-term review at 11 years follow-up. So for the growth, I measured 5 variables on each hip, and then another 2 variables which measured the movement of the screw relative to the proximal femur. And then I also recorded the number of revision operations required for ongoing growth. And what I mean by that is, with growth, the epiphysis can move off the end of the screw tip, leaving the epiphysis vulnerable to slip progression. And this requires an operation to either advance the screws or exchange them. And for the remodeling, what I did was I recorded whether there was a residual cam deformity on final radiological follow-up. In terms of our long-term review, every patient got a hip examination and an impingement test, and they also filled out functional scores, including hip scores, activity level scores, and a health score. And on to our results. So what we found was that these unthreaded screws grew significantly more, both longitudinally along the femoral neck and also vertically from the top of the femoral head to the lesser trochanter. And the screws also moved, the unthreaded screws also moved significantly more compared to the standard screws, which indicates more growth. In terms of our revision operations, almost all hips treated with standard screws did not require a revision operation, whereas most treated with unthreaded screws did. And this led to a relative risk of over 6 times more likely to require a revision operation in the unthreaded group. In terms of residual cam, there was no significant difference between the 2 screw groups at final follow-up, and the only variable significantly associated with a residual cam was the initial severity of the slip, and that was as expected. At clinical review, there were only 3 hips which had no impingement, and these were all treated with unthreaded screws. However, we don't think this was due to the screw choice, as these 3 hips had the least severe slips of the cohort. In terms of the clinical hip examination, Trendelenburg test, and functional scores, these were all very similar between the 2 groups. So to conclude, the unthreaded screws do lead to more growth. However, their effect in terms of remodeling and long-term outcomes is less clear. And therefore, the unthreaded screws should not be recommended due to their higher revision rates without any proven benefit. Thank you very much, and I'll welcome any questions.
So, just a question from us, a panel. Nice study.
Thank you.
Just, you said screwed and unthreaded and threaded screws. Is it allowed to do threaded screws now? Then, if these are supposed to be better ones, why are they using the other ones, or is it not completely proven?
Yeah, so it's quite a rare condition, Skiffy. So there are all the studies out there at the moment. They don't have large cohorts with long-term follow-up, which is kind of why we've done this study. So people like to try these different screws which aim for growth, and then we're not really there where we've had a study with a large cohort with a long follow-up to actually tell if it's worthwhile doing or not. There are different types of growing screws. This is just one of them. Different parts of the world have tried different types of growing screw, but in this study we've kind of not really been able to show any benefit of it. So we really need some kind of larger cohort, which is what they are doing with this national kind of database, where they are going to input from various hospitals into it.
Okay, so somebody probably in the future will get some answers, I guess.
Yeah.
Okay. Thank you.
Thank you.
Okay, thank you so much. So we will go on to the next presentation, which I believe is by Dr. Al-Haiti. Are you with us, Dr. Al-Haiti?
Hi, yes, here.
Perfect. So whenever you're ready, please start.
Fabulous. Hi, everybody. My name is Dr. Al-Haiti, and I'll be presenting this novel paper today. Just checking my slides moving.
Yeah, yes, it's fine. Yeah.
Are they moving though?
Yes, they're moving. We are onto your outlines page.
Oh, there we go. So I hope to break down the study today, including our key findings, before reflecting on the conclusions and how best to take these forward. We have some statistical analysis to get through as well for those keen. As we're all aware, the SARS-CoV-2 coronavirus took the world by storm back in December 2019 with its index case in Wuhan, China. Viral transmission took place overseas, and by January we had our first confirmed case in the UK. By March, the World Health Organization declared a global pandemic similar to that of Ebola and SARS. And by July, we were third highest in Europe in terms of incidence. Personal protective equipment became the forefront of the media, thrice reviewed by Public Health England in March 2020, and the first barrier to how to bring this under control. They reviewed 6 certain areas as labelled here, and we hope to go through that today in further detail. However, generally a lack of consensus between these governing bodies led to significant supply and demand issues, with a further fear for depletion of resources. With practitioners at the forefront, cell contamination rates were high, and this was a further concern, with significant implications for both patient and practitioners' safety. You may have seen these in your workplace as per Public Health England, educational posters that we're hoping to advise and disseminate this information. So we looked to assess awareness and knowledge of personal protective equipment as per Public Health England, as well as the perceived confidence of these practitioners. By doing so, we hope to evaluate correlations between survey performance and associated links with clinicians' grade and specialty in order to identify key areas of deficiency. So our national author-derived 11-point anonymised survey was distributed over 2 weeks using various dissemination methods as listed. We looked at training grades and specialties, and the 6 knowledge-based MCQs were derived from Public Health England guidelines at the time. We hope to assess perceived confidence using the 5-point Likert scale, as well as adequacy of education to date as per our respondents. A total of 697 responses were collated, with the best specialty and grade, anaesthetics and consultants, with a mean score as listed. The highest confidence scoring specialties were anaesthetics and critical care, again with a score of 4.4 out of 5, with no particular difference across grades. With the vast overwhelming majority, 81% advocating further training and education on the currently and quickly evolving guidelines. A busy slide here, but can I draw your attention to anaesthetics and critical care and ophthalmology and psychiatry, who were the highest and lowest scoring specialties on averages in the knowledge-based questions. I've listed the questions here for those that can see them with the correct answers, and they honed in on essentially aerosol generating procedures, high-risk environments, and indications for filtered face masks. The final 3 questions on single versus sessional use of PPE and donning and doffing were the worst answered questions, with single and sessional use scoring only 18%. No authors take themselves as born statisticians, so we recruited the assistance of James Howard to help with our statistical analysis to take this further. And with a p-value of less than 0.05, we found that critical care and anaesthetics frequently showed to be the highest performing specialties of statistical significance. And for the surgeons, obviously here, there were statistically significant performances against psychiatry also. This is represented further when looking at confidence, with significance in by specialty, but not by grade, as you can see by the areas shown by circles there. So we found that there are key notable differences with statistical significances, and we can hypothesize that this is due to higher frequency PP use for frontline staff. The average perceived confidence was average at 3.3 out of 5. However, we can argue this has been skewed by those higher performing specialties and could well be much lower. Ultimately, there's an overwhelming majority of respondents advocating a deficit in knowledge and room for improvement. It's a novel study, and it's important to highlight that we have no unified consensus regarding current PPE, with certain disagreements, and further education and training is essential in bridging this gap. We hope to take this further with visual prompts in high-risk areas, and as with online and virtual training taking off, we hope to really use this as a forefront to unite a confined consensus. Thank you. Questions, please welcome.
Yeah, good study, very timely done. Were the findings unexpected? Because the ITU and critical care were dealing with these patients, probably they were well educated and they were using it in day-to-day practice, and the others were not.
Yes, very good question. So definitely the frontline staff, we expected to see that sort of trend. What surprised us was the lack of confidence even amongst those frontline staff, and how the variance based on grade was also noted, with consultants achieving higher. We thought this was then followed by registrars and core trainees, and finally by foundation doctors. So that was a more surprising finding that we feel education could help tackle.
Okay, thank you.
Thank you.
Thank you. So our next presenter is Dr. Molly Reed. Dr. Molly, could you please take control of the slides? Thanks.
Hello.
Hi. Yes, perfect. Whenever you're ready, you can start. Thank you so much.
Okay, thank you. Hello, I'm Molly. I'm an F1 at the James Paget Hospital. My presentation is on fecal immunochemical testing. So FIT is used to detect human blood in a stool sample, and it does so using antibodies that are specific for human hemoglobin, meaning it's not affected by factors such as meat in the diet. And it's been used as part of the bowel cancer screening program since 2019. As well as its use in screening, it's used to help guide referrals for patients with suspected colorectal cancer who don't have PR bleeding and otherwise don't meet criteria for a 2-week wait referral. And at the start of the COVID pandemic, NICE and local guidelines were changed to increase the cutoff value for a positive FIT from 10 to 120, bringing the value in line with the cutoff normally used for screening. So our aims were to look at presenting symptoms of patients referred to see how FIT tests are used in our area, to look at the sensitivity and specificity of FIT in picking up colorectal cancer, and to look at any potential impact of these guideline changes. To do this, we looked at all patients referred to our hospital on the colorectal 2-week wait pathway over a 2-month period and gathered data on those that had undergone FIT testing, leaving us with 104 patients. These were roughly 2/3 female and 1/3 male with a mean age of 68. 73 had a positive FIT test of more than 10, while 31 were negative. And the commonest presenting symptom was change in bowel habit, followed by PR bleeding. So roughly 1/3 of patients presented with rectal bleeding, despite guidance that FIT should only be used for those without PR bleeding. So these charts show investigation findings, and you can see pathologies that picked up included diverticular disease, polyps and hemorrhoids, and altogether 3 colorectal cancers were found. All 3 of these patients had a positive FIT test, although one patient had a FIT value of 16, which would normally be considered positive, but falls below the new cutoff of 120. The highest FIT value was more than 20,000, and this patient had no pathology found at all. And the mean FIT value for patients with colorectal cancer was actually lower than the mean value for the remaining patients with a positive FIT that didn't have a colorectal cancer. So all this suggests that there's no clear link between the numerical FIT value and a diagnosis of colorectal cancer. Overall, we found FIT to have a high sensitivity of 100% for colorectal cancer, but a low specificity of 29%. And to compare this to some existing data, this American systematic review looked at 19 studies of asymptomatic adult patients, and they found an overall sensitivity of 79% and a much higher specificity of 94%. And reasons for those differences could be our small sample size, and the fact that we were using symptomatic 2-week wait referral patients rather than asymptomatic patients for screening. The systematic review also found that there was a difference in performance between the various studies depending which cutoff value was used. So sensitivity decreased from 86% in studies where a cutoff of 20 was used to 67% when a cutoff of more than 50 was used. So to conclude, we found that almost a third of patients presented with PR bleeding, despite guidance that FIT should be used for those without PR bleeding, suggesting that FIT's not always being used appropriately. We found FIT to have very high sensitivity and negative predictive value, but a low specificity and positive predictive value for colorectal cancer. And lastly, we found that there's no clear correlation between the numerical FIT value and a diagnosis of colorectal cancer. So all this suggests that we need to be careful when assigning these arbitrary values to risk assess patients, as in this way it's possible that cancers can be missed. Thank you.
Can I ask you one question? Yeah. Did you find, or do you know from the literature or from the evidence that is available, is there a correlation between the sensitivity and specificity of the FIT test and certain symptoms for colorectal cancer, not PR bleeding, obviously? So are there any symptoms which, if you have those symptoms, the likelihood of FIT becoming positive is much higher?
I'm not sure whether there's a link with any specific symptom. I know that the numbers that NICE used with regards to changing these guidelines suggested that a FIT test of more than 100 would be associated with a 1 in 4 risk of a colorectal cancer, and that's kind of, there was the rationale behind those, using those numbers. But I'm not sure whether there's any link with specific symptoms and the sensitivity and specificity.
So what's the guidance? When do GPs or hospital doctors needs to use the FIT test? Is there a guidance on it in terms of the age limit and?
So FIT testing would normally be used if there's no other clear criteria that the patient meets for a 2-week wait referral. So if the patient doesn't have any specific symptoms like the unexplained weight loss, if they have symptoms which are unexplained and colorectal cancer is suspected, but there's no criteria that they can be referred on the 2-week wait pathway with, then we can use a FIT test. And if that's positive at more than 10, then a patient would be referred on the 2-week wait pathway.
Good, thank you. I think there's a question from one of the attendees. They said, they're asking, is FIT not for asymptomatic patients since it's a screening tool?
That's what I thought.
So it is used for screening, and so it's used in the bowel cancer screening program. FIT is used, and in that circumstance, a value of 120 is used as the cutoff for asymptomatic patients. Although in Scotland, a lower value of 80 is used. But when it's used for symptomatic patients to guide 2-week wait referrals, then 10 is the usual cutoff value used.
Okay, thank you.
Thank you.
Perfect, thank you. So is Dr. Trixie Yap with us? If you can please take control of the slide.
Yep. Hi.
Okay, perfect. And once you've taken control, you can start whenever you're ready. Thank you.
Okay. Afternoon, everyone. I'm Trixie. I'm currently a CT1 at St. Thomas's Hospital. Talk to you this afternoon about diabetes and peripheral arterial disease. So it's estimated that around 1 in 3 diabetics over the age of 50 have peripheral arterial disease, and the incidence of chronic limb-threatening ischemia, previously known as critical limb ischemia, is increasing. Some studies have shown that diabetes is associated with reduced primary patency rates, whereas others have demonstrated similar outcomes following revascularization. Therefore, our aim was to identify factors predicting outcomes in diabetic patients undergoing endovascular revascularization, in particular the impact of poor perioperative glucose control on long-term outcomes. We conducted a retrospective analysis on a prospectively collected database. Our population was defined as diabetic patients undergoing primary infrapopliteal endovascular revascularization, and data collected includes all patient demographic and procedural details, in particular point of care test results and perioperative hemoglobin A1C levels, as preliminary studies have shown that these may influence outcomes. These were our primary endpoints. Major adverse limb events here is defined as a composite of major amputation of the revascularized limb and or need for reintervention on the target vessel. An analysis was conducted using SPSS. Here are some patient demographics and comorbidities. 213 limbs were treated in our cohort of 203 patients. The mean age group was 70 in a predominantly male cohort. And 437 tibial vessels were successfully crossed using a combination of plain balloon angioplasty and drug-eluting technology. These are results at 1 and 2 years, respectively, which are reasonably good and comparable to published data. So available point of care tests, capillary blood glucose measurements up to 6 days post-procedure were recorded, so over a median of 3 days. Our baseline univariate analysis demonstrated that glycemic control impacted binary stenosis and major adverse limb events, however, was not associated with amputation-free survival. And we'll look at that in a bit more detail. So at our baseline analysis, both perioperative capillary blood glucose and postoperative HbA1c was shown to negatively impact binary stenosis. Here on the Kaplan-Meier curve, we can see that blood glucose levels more than 7 is associated with increased restenosis. And freedom from major adverse limb events was also significantly worse with higher postoperative HbA1c levels. So all the factors that were significant in the baseline analysis were inputted into a Cox regression model to identify any independent factors affecting outcome. Aspirin was found to be a significant factor for restenosis, and as seen in the univariate analysis, high perioperative capillary blood glucose was also shown to be an independent predictor of binary restenosis. Moving on to amputation-free survival. Age and worsening EGFR is associated with worse survival, and meanwhile, postoperative dual antiplatelet therapy was also associated with improved survival. Postoperative dual antiplatelet therapy again was associated with improved freedom from major adverse limb events, and as expected, higher Rutherford score was associated with worse outcomes. And as per our univariate analysis, high post-op HbA1c levels were associated with worse freedom from major adverse limb events. So our results are comparable to previous studies, which also demonstrate the negative impact of poorly controlled blood sugars. So there aren't many studies in focus on this small population of patients. So in conclusion, post-operative dual antiplatelet therapy has a significant positive effect on amputation-free survival and freedom from major adverse limb events. Poor renal function is associated with worse outcomes. And finally, high post-procedural HbA1cs and perioperative blood glucose levels were associated with a higher incidence of restenosis. This highlights the importance of effective management of diabetes in the post-operative period, and therefore we should be focusing on improving post-procedure glycemic control to improve patient outcomes. Next, any questions?
Good. Thank you very much. Excellent study. Just one question. So you look at the post-operative blood sugar control and HbA1c and its effect on the outcomes. Do you think there will be a similar effect if you look at the pre-procedure HbA1c as well?
Yeah, so we looked at pre and post-procedure HbA1c levels, and the pre-procedure HbA1c was not found to be significant in the analysis.
Okay, thank you.
Okay, thank you so much for that, Dr. Yap. So next presentation, I believe, is being presented by Dr. Castlake Holding. So if you're ready, Dr. Castlake Holding, then you can start whenever.
Good afternoon, everyone. My name's Florence Castlake Holding. I hope you're all hanging in there. I'm one of the F1 doctors based at UHBW, where I did a rotation in colorectal surgery. And I'm presenting the findings from a service evaluation I took part in of colonic stent procedures that were done over a 10-year period at UHB. So just a bit of an introduction. Up to 30% of colorectal malignancies present as an emergency with acute large bowel obstruction. Patients presenting with suspected malignant colonic obstruction typically have 2 treatment options. The first is emergency surgery, which is associated with a number of different complications, a high rate of stoma formation, and significant morbidity and mortality. And the second option is stenting, which involves placing a hollow, self-expanding metal tube in the large bowel to keep it open. NICE updated their guidance in January 2020 and have recommended the use of colonic stenting for acute left-sided bowel obstruction to avoid emergency surgery. And the benefits are that there's a reduced stoma formation rate without a detrimental effect on 1-year survival. So the aims and methods of our study, we retrospectively collected data on all colonic stent procedures performed over the 10-year period from the 1st of January 2010 to the 31st of May 2020. And our aims included identifying indications, complications and outcomes of the colonic stent procedures and comparing these outcomes to those for emergency surgery. The results that we got, so 87 patients had colonic stent procedures in the 10-year period. 97% were for obstructing malignancy, while 3% were performed for diverticular stricture, and 31% was performed as elective stenting procedures, whereas 69% was performed as an emergency.
Okay, sorry to interrupt. Do you have any other slides, or this is the only slide you got?
Oh no, sorry. I thought I was controlling the slides.
Can you try again, Laurent, please?
You can go to the slide you are talking about. You don't need to go back to all the presentation.
Is this now moving the slides forward? Sorry, everyone.
It's not. I will move the slides for you.
Oh, thank you.
Can you just tell me which slide you
I'm
want
just
to be
on results at the moment.
Okay.
I was just gonna say this chart here just shows that the vast majority of obstructing tumours were left-sided, either rectosigmoid or sigmoid. And then I was going to move on to complications. So during our data collection, a number of complications were outlined and the overall complication rate was 8%. These ranged in severity from bowel perforation and requiring kind of additional stenting procedures to tenesmus or PR bleeding, dislodgement of the stent and bacterial translocation with sepsis. However, a significant limitation to this method of data collection is that we're only able to identify complications that occurred and were documented during the admission. And this kind of raises the possibility that the true complication rate is a bit higher. Just on to the next slide, sorry. So 23% of patients actually, the stent couldn't be inserted, and these patients either had emergency surgery or were treated palliatively. As you can just see, most had emergency surgery. And survival. So overall 30-day mortality following stent insertion in our population was 9%. And mean survival was 38 months, as shown, and this is when stenting was used as a bridge to curative surgery. This is compared to a mean survival of 13 months in patients who underwent immediate emergency surgery. However, comparing in this way again has limitations because some of the people undergoing emergency surgery may have had a failed stent insertion attempt first. So just some discussion and conclusion points. The majority of colonic stent procedures performed at UHB were for obstructing colonic malignancy, and mostly that was left-sided. Few of these patients were suitable for curative surgery, and stent insertion was performed primarily for symptom relief and palliative intent. Where stent insertion was unsuccessful, 75% of our population were converted to emergency surgery. Complications were observed and documented in only 8% of patients, and overall 30-day mortality was only 9%. Mean survival following stenting as a bridge to curative surgery was 38 months compared to 30 months for emergency surgery. However, as I've discussed, there are considerable limitations to be taken into account relating to the retrospective nature of the data collection, and also it was quite a limited number actually in the end of patients who'd had it. But thank you very much for listening, and I'm happy to take any questions. And sorry about not doing the slides.
It's okay. Don't worry. Well done for doing a study which can be quite difficult, isn't it, to get a data retrospectively? I'm sure you had difficulties in that. Two questions. One question is that is there a national database for coronary stenting procedures performed in the UK? I don't know whether you have any idea. That's one.
Ooh.
And the second question is, I'm just trying to understand if your overall 30-day mortality was 9%. I mean, that is significantly high than for a coronary operation, whether it's emergency or elective. And I'm just wondering, what did you look into the causes of death in these patients, or you don't have the data?
So in the just to answer the first question, there's not a national database that I'm aware of, but that there might be one that I'm not sure about. And in terms of the 9% 30-day mortality, we had a look. So for the people who passed away during their admission, we were able to find the cause, and in some cases that was bowel perforation, sepsis, I think, and maybe a couple of other things. But for people who passed away kind of once their admission had ended, it was harder to find the information about that, unfortunately.
Okay, so if there are no further questions from the scientific panel, then we will press on to the next submission, which is by Dr. Darsan Raj. Dr. Raj, are you with us? If you are, can you please take control of the slides and...
Yep, thank you. Hi there, my name is Darshan. I'm one of the FY2s based in plastic surgery in Aberdeen. So today I'll just be talking about hepatobiliary complications from ruptured silicone breast implants. We did a systematic review based on this. This was following a patient that we saw in our own unit with a ruptured breast implant after that presenting with cholecystitis. And further investigation showed that it was due to the ruptured breast implants rather than other causes like stones. So just a basic introduction. So just a basic introduction. So Karri and Jero introduced silicone breast implants in 1962. It's first line now for breast augmentation in plastic surgery. There are many studies in the literature which kind of focus on complications of silicone implants, but they just focus on lymphomas and capsular contractions, but only a few studies discuss the hepatobiliary complications. So in this presentation, I'm just going to be focusing on that based on our patient and also a systematic review that we've done looking at literature across the spectrum. So we kind of reviewed the literature over the past 30 years to look at the presentation, the diagnostic findings, as well as the management outcomes in women with ruptured silicone breast implants. So we analyzed the data based on the PRISMA method. So we looked at about 34 papers, looking at the complications of ruptured silicone breast implants, but we excluded about 31 papers simply because they were mainly non-hepatobiliary complications, and they were just review articles. So we looked at 3 papers which looked at hepatobiliary complications following a rupture. So these are the results. So these are the 3 patients that we found. So if you look at the table, each patient kind of presents with either unilateral or bilateral breast implant ruptures. One of them presented with cholecystitis and eventually had a laparoscopic cholecystectomy. The other 2 were kind of lost to follow-up and there were no further treatment. We did not include our patient here, but our patient eventually was referred to our general surgery colleagues and was ruled to have acute cholecystitis due to breast implant rupture and had a laparoscopic cholecystectomy done. And I'll tell you the reason why she had cholecystitis if you move on to the next slide. So following discussion with our pathology colleagues, so liver biopsies were sent from the laparoscopic cholecystectomy was sent to the lab, and we found that there were silicone deposits in the liver, which kind of causes a syndrome called autoimmune syndrome in adjuvants. and or the ASIA syndrome, and that actually causes cholecystitis. It's poorly understood as to why it happens, as to why a silicone breast implant rupture would lead to migration of silicone particles to the liver, but it causes a foreign body reaction, eventually leads to inflammation of the gallbladder, which this patient eventually had. There are only four patients literature that we found to have this particular complication. So it's quite rare, but it does happen. So our conclusion was, any patient presenting with right upper quadrant pain, fever, can have cholecystitis due to a ruptured breast implant. Of course, you have to take a full history and examination, but in this case, it's quite rare, but it does happen. Thank you. It's open to questions.
Okay, two questions. I mean, could this be pure coincidence that these patients were unlucky and had acute cholecystitis, nothing to do with the breast implants?
Yeah, I mean, we were thinking that when we were ruling out as to why the cholecystitis happened, we discussed it with our general surgery colleagues, and we followed up the patient when eventually she had a laparoscopic cholecystectomy, and the gallbladder was sent to the pathology department, and our pathology colleagues got back to us saying that they found silicone deposits in the gallbladder, which is quite rare because you don't find silicone deposits in normal patients with no ruptured implants.
Okay, and do you have any idea what's the kind of the prevalence of the problem in terms of the rupture?
So in terms of, you mean in terms of rupture or in terms of the hepatobiliary complications?
Both.
So I mean, ruptures, the prevalence, I can't give an exact number, but for the hepatobiliary complications, I think it's about, if I'm not mistaken, according to the literature, it's about 2 in every 5,000 cases. So it's quite common. It's more common than we think, but usually patients don't get followed up as to why they have the cholecystitis. They usually just eventually get the laparoscopic cholecystectomy.
Thank you.
Thank you.
Okay, thank you so much, Dr. Raj. Our next presenter is Dr. Miraj. Dr. Miraj, if you can take control and start at 15:19, please.
Sorry, I think you are on mute.
They've not started yet. Dr. Miraj, could you go back to your introduction slide, please, and start at 15:19, please? Okay, you may start when you're ready, please. Sorry, I think you're still on mute. If you can unmute yourself, that would be great. I think Dr. Miraj has just left the call, so we will just have to wait for them to rejoin. And in the meantime, if I can again please ask the presenters to not end the presentation, as this will take us back to the first slide. Okay, Dr. Miraj, can you unmute yourself, please?
Pedram looks like he's saying that they can't unmute. So maybe, are they not in the presenters list?
Yes, once they rejoin, one of the other organizers will add them as a presenter. Either Pushpa and Sanjid will add them as a presenter. I'm just taking them back to their introduction slide. Dr. Miraj, are you able to take control now, please?
Dr. Miraj, there will be an option on the top, take control, if you press.
If you try now, Dr. Miraj, it should be able to.
Hi, I'm really sorry about that. I don't know what happened. Can you hear me now?
Okay, yes, we can hear you. You can start whenever you're ready, please.
Okay, I'm really sorry. So my name's Ruhanowita, and today I'm doing my talk on aneurysm growth after the endovascular sealing procedure for abdominal aortic aneurysms. So just an introduction, abdominal aortic aneurysms are a dilation in the vessel diameter by 3 centimeters or greater, and infrarenal abdominal aortic aneurysms are the most common type of abdominal aortic aneurysm. So for this study, we were looking at whether there was aneurysm growth, and for that we defined it as a 5% increase in the volume between the lowermost renal artery and the aortic bifurcation. And this is the first study to ever look at aneurysm growth, looking at the aneurysm volume, as other studies have looked at the aneurysm diameter for the EVAS procedure. So the EVAR procedure, endovascular aneurysm repair procedure, which is traditionally used, is one where the stents are inserted through the femoral arteries and are positioned in between the aneurysm, so blood can go through the stents and bypass the aneurysm. And this procedure has its limitations, as it's susceptible to endoleaks, which you can see there, where blood can get into the aneurysmal sac just by leaking. So that's why the endovascular aneurysm sealing procedure, which is what my talk is on, was introduced. And that basically is similar to the previous procedure, but the main difference is you've got this like kind of sac polymer like around the stents, and theoretically that would mean that blood couldn't really leak into the aneurysmal sac as hypothesized, as there wouldn't be any space. And with this procedure, there's something called the instructions for use, which are listed here, which are a set of anatomical variables that you expect patients having this procedure to be within, but surgeons will operate outside the instructions for use. So the aim of my study was to look at whether there was aneurysm growth following the endovascular aneurysm sealing procedure, as it's a new study, and looking at whether the instructions for use being used would have an impact on whether there's aneurysm growth. So this was a retrospective observational study carried out in the Royal Liverpool Hospital, and it only included patients that underwent elective infrarenal EVAS procedure. And so 112 patients had the procedure underwent the procedure, and of those 71 fit the inclusion criteria, and of those 19 were within the instructions for use. So from the study, of the 71 patients that were included, and with the 19 that were within the instructions for use, 8 had aneurysm growth, and 52 patients were outside the instructions for use, and 14 had aneurysm growth. Then once we did statistical analysis, we found that aneurysm growth, there was significant aneurysmal growth following the endovascular sealing procedure, but whether the instructions for use were used or not did not have any impact on the incidence of aneurysmal growth. And also just looking at the post-operative outcomes, you could, with patients that had aneurysmal growth and whether the patients didn't have any aneurysmal growth, they had similar post-operative outcomes in the first 30 days. So in conclusion, we did find there was aneurysmal growth following the endovascular sealing procedure. And what you can make of that is that you can kind of postulate that because there is growth following this procedure, it could mean that there's an aneurysmal pressure, and that could lead to poorer outcomes in the future. But as this is a retrospective observational study, it doesn't prove causation, and further analysis needs to be taking place. So thank you. Are there any questions at all?
Yeah, so a good topic to choose. Did study. The question is, how does it matter if there was no difference in the post-operative outcomes or complications, whether it's the diameter or the volume?
So basically, because it was only done over the course of 30 days, further analysis would have to take place. But you can kind of hypothesize that if there is growth, then it could lead to poorer outcomes in a more long term, in the long term.
Thank you.
Okay, thank you, Mr. Mitwali. So we will just go ahead on to the next presentation. So our next presenter is Dr. Smith. Dr. Smith, can you please take control, and whenever you're ready, you may start. You have 5 minutes. Thank you.
Hi, good afternoon. My name is Chanel Smith, and today I'm very excited to share with you my presentation on devices to measure intraocular pressure in eye casualty to determine who is the fairest of them all. Intraocular pressure refers to the fluid pressure inside the eye. Normally, this ranges between 10 to 21 millimeters of mercury, and it's important to keep this narrow range to maintain the shape of the eye and perfuse structures like the cornea and the lens. Eye pressure depends on 2 things: the vitreous humour, which remains roughly static throughout life, and second, the aqueous humour, which does fluctuate as it's constantly produced and drained, and therefore problems arise when there's an imbalance in this process. Too much aqueous means an increase in pressure, and this is dangerous because it compresses the optic nerve and can damage it, a process known as glaucoma. The problem with this is that the process can go unnoticed for many years, not causing any pain. So while patients can notice a gradual decrease in their vision, the change is often too small for them to notice until the damage is irreversible. Therefore, it's crucial for ophthalmologists to measure all adult eye pressures regularly in clinics, even in those with no symptoms, so that we can detect this change early. There are many different devices you can use, but the gold standard is a method called Goldmann applanation tonometry. To do this, you apply numbing drops and an orange dye to stain the surface, and with the head of the slit lamp, as you can see in this diagram, you gently flatten the cornea with the tip of the tonometer probe, and by doing that, you can detect the pressure. Other methods include the non-contact tonometer, which uses the same principle of flattening the cornea, but instead we use a puff of air. And because it doesn't actually touch the eye, this can be useful in children who sometimes get frightened of the idea of the Goldmann method. But the problem with this is that it's sometimes less accurate. Next, we have the tono pen, and you literally hold this like a pen, gently tap the surface of the eye, and it's really useful because it's handheld, portable, compact, but again, it does produce less accurate readings. And lastly, we have the eye care, which is one of our newer devices. It contains a tiny plastic ball which shoots out back and forth very quickly, but it slows as it approaches the eye. And the machine can calculate the deceleration and produce a quantifiable value. Again, a great device, it's handheld, portable. There's no need for numbing drops. But again, the disadvantage is it's not as accurate as the Goldman. So if the Goldman really is the gold standard, why would we even consider using other methods? Well, the problem is that a survey identified Goldman as the single most time-consuming element of an ophthalmic consultation. So if we can identify the most accurate and time-efficient methods, we may be able to save times in consultations and provide better outcomes for our patients. So we decided to compare these 4 tonometry techniques, Goldman, non-contact, tonopen and eye care, to determine the most accurate and efficient method. To do this, 20 patients in the eye casualty underwent routine ophthalmic exam from the same clinician and had their pressure measured 3 times with all the devices, and an average value was calculated, as well as the time taken for the readings to be recorded. So what we found is that the Goldman had an average pressure of 8.5. Highlighted in red, however, is the non-contact, which had 10.3, significantly higher, compared to the tonopen and eye care, which was a lot more similar. And the time taken of the Goldman was 56 seconds. The non-contact was significantly higher, whereas the tonopen and eye care were 38 and 23 seconds respectively, a lot closer. So we found that overall, in conclusion, eye care was the most accurate and efficient method, which was the overall aim of our study. While tonopen was accurate, some patients weren't able to tolerate it. The non-contact was significantly less accurate and slower compared to the other devices. These are my references. Thank you so much for listening, and I welcome any questions.
One question, what are the implications of this study? Where are you going to take this further?
So we conducted this study at Swindon Eye Hospital in the eye clinic. And I think going forward, we'd like to use the eye care, and they've actually just purchased now, based off this study, a new eye care device in Cheltenham Eye Clinic. And actually they found that it's reduced their time for consultations. So it's actually already been implemented in Cheltenham Eye Clinic, which is really great to see this implemented already.
Are you planning to publish this then? Write it up and publish it?
Hopefully going forward, I would love to get it published. So fingers crossed.
Well done.
Thank you.
Thank you.
Thank you so much, and well done. Okay, so our next presenter is Dr. Taylor. If you can please take control and unmute yourself. Dr. Taylor, you're scheduled to start about now, so whenever you're ready, please just crack on. Thank you.
Great, thank you. Hello, my name is Sabapathy Taylor. Today I'm going to be presenting a meta-analysis analysing outcomes following the transplant of lungs obtained from donors following circulatory death versus from donors following brainstem death. So the background to this study is that we wanted to look at whether we can increase the donor pool for transplant lungs. At present, use of transplant lungs following brainstem death is favoured, but the donor pool is limited, with only 18.5% of these donors being able to donate their lungs. So use of lungs following circulatory death could increase this number. It originally fell out of favour due to concerns over hypoperfusion of lungs in the donor and an increased warm ischemic period. However, we now know that this hypoperfusion can actually help with conditioning, as observed in ex vivo models, and developments in ex vivo perfusion technology can help bridge the gap in restoring perfusion. So we originally identified, we originally identified 1,254 studies comparing outcomes between the 2 transplant types, with 16 meeting our selection criteria. The primary outcome we looked at was 1-year survival post-transplant, but we also looked at 3-year mortality, airway complications, and post-op ECMO use. So in terms of donor survival, we found that 1-year and 3-year mortality were not significantly increased in DCD transplants. When we also looked at graft rejection, we found that primary graft dysfunction and acute organ rejection were both not significantly increased. And we also looked at airway complications, both anastomotic complications and freedom from bronchiolitis obliterans syndrome, and these were not significantly increased. We finally looked at hospital and ICU stay, which were not increased. Post-operative ECMO was increased, but there are some concerns over whether patients selected for DCD transplant may in fact be in a more severe clinical condition warranting ECMO use, and there's also not a lot of data available on whether pre-operative ECMO was in place. There are limitations with this study. The main limitation is that at the moment there are only a few small studies comparing DCD and DBD donation. In addition, DCD outcomes can be compromised by the fact that some recipients are of poorer clinical condition and awaiting donation by brainstem death donation. In conclusion, it does appear that DCD could be a suitable alternative to address the limited donor pool. However, the meta-analysis needs to be followed up as more centres are conducting and comparing DCD donation. That's the end of my presentation. I welcome any questions.
Well done. Actually, that's a good systematic review. I'm really surprised that there were no systematic reviews on this topic before. Is this your first systematic review, or did you find any other reviews already done on this topic?
So there have been a few done previously, but they haven't looked at so many outcomes. They've mainly focused on mortality rather than airway complications and graft dysfunction. And as more studies are coming out all the time comparing the two, it seemed that we needed an updated meta-analysis.
And you didn't find any randomized controlled trials, I suppose?
No, there aren't as of yet, but I'm hoping there's going to be some coming out soon.
Make sure you write it up, okay? I think that'll be good for your CV. I think it's a good study. Well done.
Thank you very much.
Okay, so if there are no further questions, we'll just move on to the next presentation. Dr. Smiley, if you could please take control of the presentation and unmute yourself. Thank you.
Yeah, can you hear me?
Yes, I can hear you perfectly. So
right.
If you just wait a minute and start at 15:39.
Fine, I'll just check the slides are working.
Okay. You've not taken over control yet, Dr. Smiley. There we go.
They're moving for you?
Not quite yet. It doesn't seem to be. Yes, it's moving now. Yes.
Perfect. Okay, hi, good afternoon, everybody. I'm Robert Smiley, and I'm going to talk about some basic science research using UK Biobank that fits under the theme of trying to work out the etiology of carpal tunnel syndrome. So to start with, what is UK Biobank? Biobank is a massive study, over 500,000 people that was started between 2006 and 2010. To try and determine the determinants of different diseases. So they asked people about their lifestyle factors, their demographic, their medical records, and some genetic analysis too. And the idea was to follow these patients up and allow researchers to access the data and draw their own conclusions. So for this study, we had 400,000 patients available to us. So carpal tunnel syndrome. I'm sure we all know it's compression of median nerve in the wrist. 1 in 20 people get it. We don't understand why the people who get it get it. What we do know is that there are well-established risk factors, and we do know that there are some diseases that also associate with carpal tunnel syndrome. So the point of this research was to use Biobank to investigate the phenotypic relationships between carpal tunnel syndrome and the diseases you see there, so diabetes, rheumatoid, hypothyroidism, and obesity. So why are we doing this? So we know the associations exist. Previous studies have showed them. We want to replicate them on a massive scale, which just gives us more confidence in the validity of the conclusions about the associations. So initial analysis of Biobank, there was 12,000 carpal tunnel cases, 390,000 controls. Among the cases, there's twice as many females as males. The BMI of the cases was significantly higher than that of the controls. Okay, so how are we doing the phenotypic associations? So we did nested case control studies, basically case control studies within a cohort study. And what this basically means is that you can take a case control study from a cohort, you can match the cases and the controls, and you can control for other variables, which in a normal case control study would cause a degree of confounding. So what does it look like? Massive cohort, 400,000 people. You take out the diseased people, you match them 5 to 1, as we did with the non-diseased people, and you basically look to see if there's a difference in exposure, aka a difference in the percentage of carpal tunnel syndrome in these patients. So to take the example of diabetes, we had 400,000 people, we had 25,000 people with diabetes, we matched them to 120,000 controls. You can see pretty clearly that there's more carpal tunnel syndrome in the patients with diabetes than the controls. When you crunch the numbers in contingency tables, the odds ratio shows that carpal tunnel syndrome is significantly associated with diabetes. Now, we're not trying to draw causality here. It's not really possible with this kind of study. And even if we were, no one is suggesting that carpal tunnel syndrome causes diabetes. All we are saying is that carpal tunnel syndrome is more common in diabetes than controls. We then controlled for BMI on our matching. So we matched on age, sex, and BMI. The numbers differ slightly, and the odds ratios are slightly lower, so the effect is slightly diminished. We think that some of the association is mediated potentially via BMI. This is quite a messy slide. It basically shows the table of what I've just showed you in the diagram. It shows that for diabetes matched, and then rheumatoid and hypothyroidism as well. So the results of this. So of the 3 diseases, they all positively associate with carpal tunnel syndrome as we expected. It replicates previous findings. Each of the disease associations is attenuated by matching to BMI as well. So this mediation, I'm sure we've all seen that patients who have higher BMI are more predisposed to these 3 diseases. In this study, we've shown there's a sizable BMI difference between the cases and the controls, and we've also shown that there's attenuation of the phenotypic associations. So let's just recap. So we've shown there's a 2-to-1 prevalence of females to males within Biobank that have carpal tunnel syndrome. We've showed that there's a sizable BMI difference between the cases and the controls, and we've replicated the associations we spoke about at the start. And we've also shown that matching on BMI attenuates this effect. So limitations, these are mainly issues of Biobank itself. There's skewed overall prevalence. It's a healthy population. They're all volunteers. And so typically they're different to your general population. Because of some previous matching, this is a white British ancestry study. So the next steps, we've shown the phenotypic associations between the diseases and carpal tunnel syndrome. And now we want to look at the genetic associations. Are obesity, hypothyroidism, and diabetes genetically associated with carpal tunnel syndrome? So if you'll excuse the corny layout, this is my take-home slide. What we've done, we've confirmed the replication that we set out to do on a massive scale. We've shown that some of this association is probably mediated through BMI, and we've used the superb power of Biobank. What I've done is Biobank you access via applications. So if you've been interested in what I've said, if you want to use Biobank yourself, you can scan the QR code, send me an email, and I can walk you through kind of how it's done. Thank you very much.
Excellent study. I'm really impressed, I have to say. I don't know who got the idea. Is it you or your supervisor? But it's a really good idea. You know, as usual, what's the kind of implication of this study, though? I still, because yes, you have proven the point, but what's the implication?
So just to address the first point, it's part of a wider sphere of research from someone who's doing a PhD. So the idea kind of comes from the overall idea of the etiology of carpal tunnel syndrome. Probably the point of the basic science research is kind of just to fundamentally improve understanding. But if you want to take home clinical points, you can start to say that if there's mediation via obesity, you can then start to say in the clinics, as well as putting you in a splint for 6 weeks or thinking about operating, we also suggest that you maybe think about losing some weight as a treatment for carpal tunnel syndrome.
Is that not what happens normally now? Obese patients, you don't advise them, or is it?
I think it's starting to come into the clinics. The plastic surgeons I've been working with find that they kind of need more of an evidence base to fully impress that point.
Okay, separate point. Do you have to have an idea to before you approach the biobank? How does it work?
So typically you have to have an idea, you have to have a hypothesis, and often you have to have some grant funding. But it's not essential. There's about 2,000 groups of researchers with access to biobank at the moment. I think the vast majority come via the PhD route, but I'm aware that there's some people who've started to use it in their sort of AFPs and ACFs as kind of a build up to a PhD. So if there's an idea that someone has that they're working on, then this is a really good way of sort of adding to that. Okay, no, I'm really curious. I'm keen to get, put an application, and I'm just wondering. So we just, how do we do that? You just scan your this thing, the QR code. Yeah, if you scan that, it will pop up on your phone with a pre-written email that you can send to me, and I will reply back with some more detail if you're interested.
Okay, can you do that?
Okay, thank you.
No worries, thank you.
Thank you very much. So our next presenter is Dr. Macha. Dr. Macha, if you can please take control of the presentation and unmute yourself, please.
Hi, can you hear?
Yes, so whenever you're ready, please go ahead.
Perfect, thank you. Hello, so my name is Nitya Macha. I'm an F1 working at St Thomas's Hospital, and today I'm going to talk about what we found when we looked into the outcomes of per-oral endoscopic myotomy, or POEM, for achalasia. So just for a bit of background, achalasia is primarily a motility disorder of the esophagus. It's characterized by a failure of peristalsis and relaxation of the lower esophageal sphincter, resulting in difficulty of passage of food from the esophagus to the stomach. It affects a large volume of people, so 100,000 people per year, and the current gold standard surgical treatment is laparoscopic Heller's myotomy, which involves a laparoscopic approach into the abdominal cavity, mobilization of the lower esophagus, and division of the lower esophageal longitudinal muscle fibers. And numerous studies have already been carried out looking at the efficacy of this, and it's been shown to be superior to the other commonly used intervention, which is pneumatic or balloon dilatation. However, today I'd like to talk about POEM, or per-oral endoscopic myotomy. So this is a relatively new endoscopic procedure proposed as an alternative to laparoscopic Heller's myotomy, and thus eliminating the need for laparoscopic surgery. So it involves the introduction of an endoscope into the esophagus and the creation of a small submucosal bleb to identify the layers of the muscles, and the endoscope is then inserted into the submucosal, underneath the submucosa, to create a tunnel. So this is quite a long tunnel and extends past the lower esophageal sphincter into the proximal stomach. So then a myotomy is carried out, dividing the muscle fibers about 8 centimeters above the gastroesophageal junction to about 2 to 3 centimeters into the proximal stomach. The endoscope is then withdrawn and clips are left in place. So today I'd like to talk about what we did to look at the safety and efficacy of the POEM procedure for achalasia, as we carried out in St Thomas's Hospital, as this is a national centre for esophageal disease and there's a high turnover of patients, and it's quite an experienced surgical team. So we identified 202 patients who underwent surgical intervention for esophageal achalasia at St Thomas's between the years 2005 and 2020. For these patients, we looked at patient demographics, so age, BMI, post-operative complications, prior achalasia treatment, duration until they were followed up, the length of their hospital stay, the Eckhart score, which is a score looking at the severity of symptoms caused by achalasia, mortality, and the incidence of post-operative esophagitis. So for our results, we found that in our patient cohort, so of the 202 patients we looked at, 53% had a laparoscopic Heller's myotomy, and 43% had a poem. So for these patients who had the poem, 39 patients had complete data. So these are the ones that we looked at in detail. So 45 patients, the average age of our patients was around 45 years of age. Around 40% of patients had a previous intervention for achalasia. So either laparoscopic Heller's myotomy or a pneumatic dilatation. So we found that there was a 0% mortality, demonstrating that this is a very safe procedure. Our median follow-up was around 24 months, with the range being 12 to 49. 29% of our patients required the use of a PPI post-operatively. 8% had post-operative complications. And we demonstrated that there was an 87% rate of clinical success. So we defined this as an Eckhart score of less than 3. And we found that 37% of our patients had esophagitis on a post-operative OGD. So when we look at the numbers, this was 9 out of the 24 patients who had an OGD, but it's important to note only 5 were symptomatic. So in conclusion, we found that the POEM procedure is very safe and effective and warrants consideration as first-line therapy in expert achalasia centres. And looking at opportunities for further data for future research or opportunities, we recommend that this area would benefit with large volume randomized studies looking at POEM and laparoscopic Heller's myotomy and pneumatic dilatation to determine its place in our treatment for achalasia. Thank you.
A question for you. Well done. It's a good audit again. Why do you need to do a large randomized controlled trial when you've actually shown that it is effective, it works, isn't it?
I think this is more of a good point. That's a very good point. I think this is more to follow the way we sort of evidence-based practice for changing of guidelines and demonstrating, and also although we compared a large volume trial, it was only 39 patients we looked at in the end. So it would benefit from combining data from other centres in the UK and sort of creating a larger patient database. And also we feel that long-term studies might be beneficial as well. So we followed them up just for this period, but looking at it after as well, looking at how many patients required repeat procedures might be beneficial. So.
Okay, just a follow-on question. Do you know then how many centres in the UK are actually using this method for treatment of achalasia? Because that would be a big problem, isn't it? If your only centre is actually using it, there are no other centres, then you wouldn't be able to recruit any other centres for RCT.
Yes, so St Thomas's is currently using it, and there's one other. Sorry, it's completely slipped from my memory, but there's another large centre in the UK carrying out this study, and we are working to combine our data to try and come up with like a larger patient data set to come up with a more strong conclusion.
Okay, good luck.
Thank you. Thanks.
That'll be a good study to do.
Thank you very much. So our next presentation is by Dr. Ong. Dr. Ong, if you can please take control of the presentation and unmute yourself.
Yep, can I start now? Can you hear me?
Yes, I can hear you perfectly. You can start whenever you're ready. Thank you.
Yep, sure. Thank you. So I'm Dr. Ong here. I'm from Wye Valley NHS Trust in the West Mids. So I'm just going to present about urgent elective surgery care during COVID-19 pandemic from a small district DGH kind of point of view. So background, what is COVID-19? I mean, everyone would have by now should have known what is COVID-19 after a year of hopefully not any longer. So it started in Wuhan in December 2019. It progresses quite rapidly by being a global pandemic by March 2020. Basically, it's quite a deadly sort of thing that is going on at this moment. So we conducted a study to see that how it affects, especially surgical procedure, that it's quite a bit of a backlog even before the pandemic, and how it affects the pandemic. So basically, data collection was done on the March 2020 to May 2020, when COVID was relatively a new thing, whether to swab, when to isolate, when the surgery starts. Primary endpoint is 30 days mortality and COVID-related complications. Secondary endpoint would be surgical-related morbidities and oncological outcomes. So as a result on our studies, we have basically 92 spreading quite equally within male and female population, and most of them was tested with COVID, but only one was tested with positive. Most of them were negative before the treatment itself. So power of calculation for 30 days mortality shows that that 82 people is needed for power of 0.95 and a p-value of 0.01, and we have basically 92 of them. So this is basically of different specialty in S4DGH, looking at breast, colorectal, ENT, gynecological, and urological. So we have quite a good spread of numbers in among these surgical specialties. Below shows basically breast is mostly for definitive treatments and what the number of procedures so far. So for colorectal, so what happens in Hereford basically is that we have a cold and a hot site. So a cold site would be in collaboration with Nuffield Hospital, where we have these elective operations, especially cancer surgeries that have to go on. So we get a patient to isolate for 14 days before the operation, get a negative swab, operate them, and then re-swab them on day 2 and day 8 while they stayed in the Nuffield Hospital, just by 4 streets down the road from the main acute hospital, which is Hereford County Hospital. And if they develop post-op complications, unfortunately 4 of them from the colorectal group, 2 of them required hospital transfers to the acute site. ENT basically is most likely an outpatient kind of thing. So they would sort of more like diagnostic procedures like EUAs, biopsy, lymph nodes, and stuff. Gynecological, it's mostly still for diagnostic procedures like Mirasna, LATs, and things that goes on. Urology, basically, all out of the 32, 1 has post-op complications from a ureteral dilatation, which have to be sent back to the acute site for more treatment that needs to go on. So in summary, there's a Lancet paper published by the COVID Search Group that is 280 patients with elective surgery, 250 ended up with COVID positive, and 53 deaths. So our hospitals in collaboration with Nuffield has 0 death. I understand that the limitation is because we are relatively a small DGH, and the data might have its own limitations. But our strategy of self-isolation before the procedure, staff PPE, theater hygiene, using Nuffield as a green site or a cold site, we would say, actually make a difference. And just to point out that victory against COVID would be from good planning and dedication. Thank you very much.
So are you suggesting from this paper, you think that there should be hot and cold sites even for the future?
Ideally there should be, but I understand not every hospital have this privilege of having a hot and cold site that could be run simultaneously, especially when COVID first started. Cancer surgeries have to still continue, but there is definite impact on the backlog of the cancer surgery kind of cases.
Okay. And also the study period you chose, and then the one from the COVID surge, slightly different, and COVID surge obviously extended a bit longer period, isn't it?
Yep, that is, yep.
Okay, thank you.
Thank you.
Okay, thank you so much for that presentation. So we are ready to proceed on to the next presentation by Dr. Seraj. Whenever you're ready, could you please start at 1600, please?
Alrighty. Good afternoon, everybody. My name is Sanjid. I'm an F3 working in London, and I'd like to share with you a piece of research that I conducted earlier this year over at Newcastle University. So essentially, I want to say that learning surgery is a complex yet beautiful art and science that will take many years to master. And for many of us, this journey will start at medical school. Will that be learning through lectures, classrooms, dissection rooms, but also in the workplace, i.e. theatres, clinics and wards and MDTs. And this learning can encompass many things, such as technical skills, professionalism, teaching and research abilities, but mainly it's about learning medical and anatomical knowledge. And that type of knowledge is what we call descriptive knowledge. So move on to the next slide. Yeah, so essentially, like I said, descriptive knowledge forms a large part of medical student learning at the moment. And throughout the literature, there is paucity across the literature about medical school learning of descriptive knowledge, and particularly about the behaviours of surgeons towards medical students and their effects on student learning. So really, throughout this study, essentially, we aim to try and identify whether this was actually a thing. A lot of studies showed kind of the relationship between surgeons' attitudes and professionalism and other aspects, but not quite medical student learning. So that's what this study kind of aimed to try and identify. So this was a qualitative study because there wasn't much data out there, so we needed to kind of find some meaningful data. It was purposive sampling of medical students, so it was across different ages, races, religions, and backgrounds as well. And it was conducted through semi-structured interviews. All were recorded and transcribed and used a phenomenological study design so as to gain a deeper meaning from those answers acquired from those interviews. We interviewed 12 medical students. The reason why it was 12 was because any more, we essentially found that there was a repetition of these themes that came around. And from the data that we got, the thematic analysis aimed to identify 3 main themes, and the interviews were a bit on the long side, from 1 hour to 1 hour 45 minutes. So what did it show? Well, the first key theme was the assimilation into the workplace, and the positive themes that arose from there was about the enthusiasm, such as the enthusiasm to teach, the appropriate student introduction, creating a relaxed work environment, and the freedom to answer and ask questions. And the negative themes that we kind of found was the absence of surgical teaching and that fear of embarrassment. Motivation was another key theme. Essentially, this really revolved around how relevant this learning was to the medical student, and ways that surgeons would find to try and make this more relevant to the student at their stage. And the final theme was about strategies, and there was an array of different strategies that surgeons made to facilitate learning, and on the whole they're all pretty positive, whether it be using tips, drawing on a spare napkin before an operation, providing effective feedback, and using Socratic questions throughout their time at placement. So essentially, overall, the discussion really showed that a supportive environment and taking an interest to the medical students' learning helped improve perceived medical student learning and knowledge of their descriptive knowledge. And this was then furthered when surgeons then took an interest to that medical student. However, there was a negative aspect to that, where if there was an alienation of the students, there was a risk of them feeling devalued, and this was essentially this discouraged their development of descriptive knowledge. So what can we conclude from this study? Well, essentially reinforces the role that medical students are here to stay. They will be here until we, for a very long time, so we can't really ignore them. And so really their experience is pretty limited. And so really it's for the surgeon to help guide the medical student through that learning. For future, the next study what I'll be doing is to interview consultants and see what their thoughts are, because it takes 2 to tango, really, and hopefully these themes will then formulate a potential survey. Thank you so much. Thank you for your time. Welcome any questions.
Good. Excellent study, Sanjid, and it's not easy to do a qualitative study, and it looks like a lot of time spent and vested in this study.
A lot of time.
Yeah, so just one question. What do you think are the limitations or actually problems which are faced with the actual trainers or the teachers in these situations, you think? Why are the consultants or the teachers not spending enough time or showing interest, do you think?
I think a lot of it will have to be to do with the pressures that they face from kind of a day-to-day work, whether it be, busy lists or, busy MDTs, busy ward rounds, it's from the study that we did, it did highlight that it wasn't so much the surgeon's dismissive attitude. It was more just about the fact that they were quite busy. And unfortunately, this is the political environment we're in at the moment, isn't it?
Mm-hmm. And where do you want to take it further? So the one thing is, you're going to do, further centers or medical schools to involve. And are you trying to approach the Royal Colleges or the ISCP to see whether they can try and incorporate something to make it better?
Well, essentially, I think the first thing is to see what the consultants think and see what their perspectives are on how this can improve medical student learning in the workplace. And then I think from that we would have some kind of rigorous data to kind of show or prove to the ISCP that there may need to be some changes.
Yeah, absolutely, because that's what I was going to ask, because you need to get the perspective from both sides. And then if you want to make some change, I think that will be a good thing to do, I think, for the future. Well done.
Thank you.
Thank you, Sanjid. When you're ready, you can progress on to the next slide.
All right. So the next presentation I'm going to deliver today is essentially about an enhanced recovery program audit in colorectal surgery over in Balasubramanian Hospital. So what is an enhanced recovery program? They're essentially evidence-based protocols designed to standardize medical care, improve outcomes and lower healthcare costs. And essentially what we did was we used those principles in colorectal surgery over in Balasubramanian Hospital and see whether we're actually following these. What comprises of an ERP? Well, it looks at the preoperative, intraoperative and postoperative factors. The preoperative factors being looking at bowel prep, looking at, providing antibiotic prophylaxis and thromboprophylaxis prior to the operation. Intraoperative, we're looking at things like providing analgesia, and postoperative, we're looking at things like removing drains and removing catheters, for example. So the outcomes that we monitored are all listed here, in particular looking at things like obstruction, return to theatre, other complications, and ileus. So we collected data from between June 2018 to 2019, and in total 114 patients were included across 6 consultants. And the majority of the laparoscopic resections, as you can see on there, is of the right laparoscopic right hemicolectomies, and of the open, we can see it's the open right hemicolectomies there. The average age of those participants were around about 69, with a split of 63 male and 51 female, and a ASA grade of 2 to 3, and BMI average 27.6. So in terms of complications, the majority of complications arose from the other complications that weren't to do with ileus, leak, obstruction, return to theatre, death or readmission. So essentially, we saw that there was a significant, relationship between the patients developing ileus and then developing HAP afterwards, and then ileus as well as then mortality as well. We'll bring your focus to this study, the ORALIF study, where it shows here that actually in their study it showed that the use of antibiotics, pre-op antibiotics, had reduced the rates of surgical site infections and infections post-op. So, and the fact that they didn't actually use any mechanical bowel prep. In our study, we showed that antibiotics actually had no effect on infection rates and no effect on post-operative recovery. And this was also shown in the prokinetics as well, that prokinetics actually had no effect on ileus either. So here's a summary of our results. As you can see, essentially a lot of the patients received stoma chat, a lot of the cancer counselling, 100% for that as well. A significant number of patients had loading drinks prior to the operation, and a significant number of them, also 74.56%, also received antibiotics. So really, what does this conclude? Well, essentially that we're going to be following different ERP protocols. We found that there was no actual benefit, which is in contrast with the Oralev study. So in Basel, they're going to be omitting antibiotic use and prokinetic use. There was limited benefit of bowel prep and pre-op load drink as well. So it was up to the discretion of the consultant as to whether they're going to continue that as well. However, it did show a strong relationship between the peri-op analgesia and ileus. And we found that the sequence from ileus to HAP to mortality was evident. Thank you very much. Thanks for your time. And that was the audit. Thank you very much.
Hi, a quick question for you. I mean, we know this already, isn't it? I'm just wondering why you decided to do this audit. Is it because there was an issue with the compliance in your hospital? Or was there a particular reason why you decided to do this audit? Because we know all the benefits of the ERAS protocol and ERAS pathways in colorectal surgery for a long time.
Yeah, no, you're right. It is a lot. Yeah, I think the thing is that I think we soon realised that we were giving antibiotics to a lot of patients, and we just wanted to see whether whether antibiotics did any effect really, and we were able to prove that it didn't really show any effect kind of pre-op. So I think that was really the main point there.
Okay, thank you.
Thank you.
Thank you.
Okay, perfect. Thank you so much for this, Sanjid. If there are any questions, people can continue to type into MS Teams chat box. If there are no further questions from the scientific panel, then we will proceed on to the next slide. And this is by Dr. Benjamin Shapira. Dr. Benjamin, can you please take control of the slides, unmute yourself, and start at 16:14, please?
Sure. Can you hear me okay?
Yes, I can hear you. Oh, thank you.
Brilliant. I'm just going to check the slide moving forward. Do you see that move forward?
Yes, it's moving on perfectly. Yeah.
Perfect. Thank you. Did you say start at 16:14, right?
Yes, I did say that, but you know, we can start early.
It's okay to start early, I think, Pedram, because we can finish early.
Okay, in that case, whenever you're ready.
I'll save us a minute of time. Brilliant. Okay, thanks, guys. So my name's Ben. I'm one of the Watford General Hospital's F1s, and I'm this audit's lead. Special acknowledgement to be given to our co-authors, Dr. Max Seabrook, Mr. Ahmed Mahmood, and Mr. Vikas Pandey. This presentation regards the results of the first and second cycle with the collection dates noted in November 2020 and April 2021. Over a 2-week period, we analysed all admission pro formas pertaining to surgical inpatients for completions of each section. And let's see. So our first cycle found key areas for improvement, including examinations of all systems except for the abdomen, completion of the VTE pro forma, and completion of DNA CPR or treatment escalation plans. Signatures too were in need of a huge improvement, was what we found. After our first cycle and discussion with the surgical faculty, we agreed to the following changes. Changes for consideration to the surgical pro forma itself, which is currently under review for inclusion in the new digital system our trust is upgrading. A series of consultant-led educational sessions for junior trainees to run on induction and at a midpoint at each rotation. These were designed to inform and discuss the concerns or difficulties with completing TEPs with junior trainees and address shortfalls in pro forma completion. We also worked very closely with the nursing teams on the surgical wards to include TEP completion in both their handover and morning board rounds. This aimed to remind doctors to complete their TEPs if the patient was admitted to the ward without one. Each cycle yielded roughly the same number of cases with very similar proportions of patients admitted to the ward or discharged directly from the EAU. In terms of taking a history, our trainees were largely very good at a bulk, but lacked in routinely taking a social history from patients, and we found marginal improvement between cycles, but largely followed the same trend. Again, in terms of examinations, we found our trainees were very good at abdominal examinations, but largely not examining other body systems. And there was a marginal improvement between sessions, but it followed a very similar trend. In our first cycle, we found that VTE pro forma completion was below 60%. After our educational sessions, we found this improved to above 70%. In most cases, identifying the class of a patient, whether or not they were surgical or medical, caused a big reduction in completion rates. But the overall results are satisfactory, but there is definite room for improvement still. Our first cycle demonstrated very poor completion rates of DNA CPR status or treatment escalation plans, being only less than 15% completed and less than 2% with a senior endorsement. After our educational sessions and help from the nursing teams, we found a 6-fold increase in completion, junior signatures, and senior endorsements. These results demonstrate a significant benefit to the educational discussion sessions that we held, but also still have a lot of room for further improvement with the senior endorsement. So, overall, our second cycle found marginally increased completion TEP rates across the board, but largely followed a similar trend as the first cycle. Our aim for the second cycle was to improve upon the TEP completion rates, which I believe we have succeeded in, with the completion rates going from 12% in the first cycle now up to 68%, but there's still large room for improvement there. There were slightly reduced rates of clinician signature, but most likely area for improvement is senior endorsement. In our trust, we've actually changed now the guidelines where the seniors need to physically sign the TEP form rather than just a junior having a discussion with the senior and noting their name. We believe this change will significantly increase the senior endorsement in time for our third cycle in the coming months. And our plan is to continue the educational teaching sessions and discussions with senior trainees for TEP completion, and we will continue to promote safe and thorough documentation of our surgical patients and push for physical change to the performer itself. We aim to re-audit again in about a few months to reassess for any further improvements on that. Thank you all for your time and listening. And I just want to say right now as well, thank you for this whole day. It's been absolutely brilliant. So thanks. And I'm open to any questions now.
Thank you. A very good project. I think anything to do with improving documentation is a good thing. And actually, we did a similar study. One of our trainees did it actually not long ago. What do you think is the main reason for a poor documentation?
We think it was basically to do with this. A lot of the F1s are actually doing a lot of the documentation, and I think they kind of get this this idea from the seniors, maybe the SHOs and the regs, that we in surgery do things really quickly. We just document things on the abdomen soft non-tender, move on to the next patient kind of thing. But this isn't the best thing. It works probably maybe like 75% to 8%, but then it's when you're on the night shift, a patient starts crashing, and you look at the documentation. Everything's really poor. There's no TEP plan in place. The ITU come down and they're like, well, what's the consultant's decision for this patient? And then you're calling up the consultant and seniors in the middle of the night. ITU are saying, oh, this patient isn't for ITU, but the consultant's saying, oh, full escalation. So I think a lot of this does just come from not having this diligence from the start of actually seeing a patient. And I think that's what we're trying to improve with our teaching sessions, is that, this is something which is important and it will have a direct benefit to you, probably when you're alone in the middle of a night shift.
Yeah, absolutely. Thank you.
Thank you.
Thank you so much for that, Ben, and thank you so much for your kind words. So that brings us to the conclusion of the oral presentations the afternoon. And I have to just say that the quality of the presentations have all been fantastic, and we have all thoroughly enjoyed the whole day. And so thank you so much for joining us. We do have another presentation to go through, and this is with regards to a course that is run by the TMS that's free of charge for our course and for all people applying to core surgical training. So I'm just going to introduce Dr. Pushpa for this talk, and she can take over from me, please.
Yeah, thank you. Hi guys, I'm Pushpa, I'm one of the other lead organizers of the conference. Firstly, thank you so much to everyone who's attended the conference today. And most importantly, thank you to all the oral and the poster presenters today. They've all been of excellent, really high quality, and we've thoroughly enjoyed all of them, and we hope you guys did as well. Just want to have a quick chat about our upcoming core surgical interview preparation course, which will be coming up this November 2021. Essentially, we ran a course last year for core surgical training interview preparation, and it was highly successful and highly recommended by everyone who's attended the course. It's just going to show you a photo of the flyer that we used, and also you can see some of the feedback we've received, and they've all been positive. So essentially, it's a free interactive online course. It's a one-day course that basically runs from 9 a.m. to 5 p.m. and it's usually on a weekend, likely a Saturday like today, so that most of you can attend the course. And we go through all the 3 stations of the interview. So your poster presentation, so your portfolio, clinical, and your management station. And the talks would all be given by current core surgical trainees. So they've done the interview not too long ago. So it'll be all quite fresh in their minds. So within the portfolio station, we go through the different sections within the portfolio criteria. So all the criteria within the self-assessment, essentially giving you tips on how to boost your self-assessment score, and also give you tips on how to evidence each section, as that's equally important. We also give you information on and tips on how to organize your portfolio, although last year was all online, but it could very well go back to having a physical portfolio. And it's always important to have a physical portfolio either way. So always have that. So it's important to make sure it's well organized, as you do get a lot of points for that. Within the clinical station, we go through the different clinical scenarios. So we go through the common clinical scenarios, as there's usually a recurring theme of the common scenarios that come up time to time. And we give you information around the topic, but most importantly, we give you tips on how to structure your answer, as you get very limited amount of time to kind of show off all the knowledge that you do have and to stand out from the rest of the candidates. So structuring your answer is the most important, and we give you tips on how you can do that. And finally, for the management station, we go through some of the more common management scenarios, and also we give you tips on how to structure your speech. Usually you give a 3-minute speech for, and it's for the last couple of years, it's been around leadership within CSD. It could be a different topic next year, but it would essentially what it would involve is giving you tips on how to, what the content for your speech and how to deliver your speech to get the maximum points. So like I said, it's going to be an online course. So again, it would be through Microsoft Teams. So again, you're not gonna, it's free of charge as well. And again, as it's going to be Microsoft Teams, you don't really pay for any accommodation or travel costs. And there are about 150 spaces available, and spaces do fill up pretty quick. So please keep an eye out for the course. We don't have an exact date for it yet, but we'll start advertising sometime late September or early October. And all of the course would be recorded and would be sent to all the attendees, would once the course finishes, and also all the content PowerPoint presentations will also be sent to you, so you always have something to refer back to closer to your interview time. So usually, so check your email. So we advertise through email, and we also advertise through social media. So do keep an eye out in your inbox, and also make sure to look at the Master Surgeon Trust website, and also their social media platforms. So their Facebook, Twitter, and I believe they've got an Instagram page as well. So do look out for the course, and we hope to see most of you at our course as well.
Thank you, Pushpa. Thank you.
And we've got an email as well, so it's take note of that. And if you've got any questions, you can email us.
Amazing. No, thank you, Pushpa. I just wanted to say one last thing from me. I've just posted in the feedback the link for the feedback form, so everyone will receive an automated certificate of attendance after you've completed the feedback form, and then a letter confirming your involvement in the course as well, whether you've presented a poster presentation or an oral presentation. So that will also be in there as well. I would like to say a few thank yous. First of all, to thank you to the keynote speakers, to Ed, Miss Lovett, and to Professor Balasubramanian. I'd like to thank the scientific panel as well, Mr. Enamosa, Mr. Asopa, Mr. Mitapali, Mr. Kulkarni, Mr. Rahim, and Mr. Aruri. I'd like to also thank the abstract reviewers as well, to get through through all those abstracts to help finalise those oral presentations and poster presentations. I'd like to also thank the oral presenters as well for those wonderful presentations that you guys delivered, and also to the poster presenters as well. I'd like to thank the TMS charity for their support throughout this conference. I'd like to also thank the organising committee as well through their hard work to make sure that today was pulled off. So no, I'd like to, from my end and from the organising team, thank you so much. Thanks for everyone for coming. Thank you.
Thank you so much for coming, guys. I just want to echo what Sanjid said. I thoroughly enjoyed today. In terms of prizes, the prizes will be announced in a week's time, and we will be in contact with the prize winners. So again, I won't keep you guys for much longer, so I just wanted to say thank you and goodbye from me as well.
Thank you and goodbye from me as well. Thank you.
Good. Well done. Goodbye.
Bye-bye.
Well done, guys. All the team.